accelerate the vaccination right now.
Yeah.
But the worry is that we were looking very closely at what is happening in Israel, and recently they had an outbreak again.
Oh, really?
Yeah.
So shall we start?
I think we have to start.
Shall we start? Okay, so it's about time to start our second day program. This topic will be the section one topic will be the prosthetic valve durability. And Dr. Yingwei Xian, Dr. Gilbert, and me will be the moderator, and the commentators will be Cao Dianping, Li Guozhen, Li Yongzai, and Lin Pinyi. Maybe I have to introduce Dr. Gilbert a little bit. Dr. Gilbert is the surgical director of the structural heart program at the Mount Sinai Health System and senior consultant at the Department of Cardiology at National University Heart Center, Singapore, and the director at the Congenital Structural Heart Disease Program, National University of Heart Center in Singapore. Okay, so he's now our moderator, and Dr. Yin is the superintendent, the vice superintendent of Chengxin General Hospital. The first topic will be given by Dr. Ye Jian. His topic will be the new advances in TAVR. Dr. Ye Jian is he's been a staff cardiovascular surgeon at St. Paul Hospital in Vancouver General Hospital since 2004, and clinical professor of surgery and the director of cardiac surgery research and in the division of cardiovascular surgery of the University of British Columbia since 2010. His special clinical interests include complex surgical mitral and tricuspid valve repair, minimally invasive surgery, transcatheter heart valve implantation, and aortic surgery. He's a pioneer in the development and the clinical applications of transcatheter heart valves for heart valve diseases. Working with other team members, Dr. Ye has performed many successful transcatheter heart valve procedures in humans for the first time, such as transapical transcatheter aortic valve implantation for aortic stenosis in 2005, and the transcatheter aortic valve-in-valve implantation for failed bioprosthesis in 2007, and transapical transcatheter aortic valve implantation for aortic regurgitation in 2011, apical transcatheter aortic implantation for the aortic regurgitation in 2011, transapical Jena valve implantation for aortic stenosis or regurgitation outside Europe in 2013, and transapical mitral valve replacement for mitral regurgitation in 2014, and the transapical mitral valve repair for mitral regurgitation using the NeoCode device outside Europe in 2015. He's now teaching and training physicians and surgeons in transapical heart valve implantation and mitral valve repair in many countries over the past 10 years. So please, Dr. Ye.
Thanks for your kind introduction, Dr. Wei. First, I would like to say that it's really my pleasure and honor to be part of the virtual Taipei Valve Summit this year. And I would like to say thanks to both of you for your hard work and the local committee for organizing this excellent meeting. Yesterday, I really enjoyed the program and the excellent lectures discussion. So I'm going to give a talk today. I just share my slides. Okay, I think I should. Can you see it? Can you see my slides?
Yes.
Excellent. Okay. So my title is a TAVI in young patient. So I'm mainly focused on the durability and some concerns about the TAVI, particularly in the future use in a very young, healthy patient. So this is my disclosure. So first, I'd like to give a brief review of the definition of bioprosthetic valve dysfunction or structural valve deterioration. This is sort of a definition has been changed and very variable, so make the comparison quite a difficulty between the surgical valve, between the valve, or different type of valves. So in 2008, there's a guideline for reporting morbidity, mortality from the 3 surgical society. And the definition is a dysfunction or deterioration involves the operated valve exclusive of infection and thrombosis as determined by reoperation, autopsy, or clinical investigation. So the reason is that because you see that there's all different, you can be reoperation or autopsy because not every patient is followed by the regular echo, like particularly every year to look at the valve, because this is not really practical in the clinical practice. In the clinical trial, you can do that, but in the real world, it's not possible to do the echo every year on every patient. So that's why it's make this kind of a definition is quite a difficult or standardized. So as you see, this is a published circulation, and you see the list of all the different definitions in previous publication. I don't want you to read this, but I just want to show you the definition is so variable between each publication. So it's really, you cannot compatible between the valve and between the type of surgical valve even, because the definition is so different, and the outcome of course will be significantly different. And the VIVID group, the register, they sort of trying to standardize the SVD definition, but this is basically is a mild, moderate, and the severe this kind of valve dysfunction. So based on the, I believe this is more based on the hemodynamic change as a definition of the moderate aortic stenosis, severe aortic stenosis. So based on this, and make the definition of severe stage 1 or stage 3, but basically it's basically mild, moderate, severe. But that's also the difficulty in the real world, because as I say, the echo is usually not possible to be performed in all the patients every year. So this kind of definition for the study, in the study, that's very useful, but in the real world, probably still will be difficulty. And the European and also established a sort of a standard definition of SVD, and you see the bioprosthetic valve dysfunction, that's including 4 categories as endocarditis, thrombosis, or non-structural valve deterioration, and the structural valve deterioration. So, and then when they reported it, you can see most the reported is a structural valve deterioration, but not including non-structural valve deterioration. I think that should be, debatable, because particularly for the transcatheter valve, so surgical valve, the suture, the transcatheter is not sutured. So whether it's a severe perivalvular leak or develop a new perivalvular leak, that doesn't count as a structural valve deterioration. I thought that this is debatable, because for the surgical valve, of course, you suture, but the transcatheter valve, that's the one thing that we saw as it's a major, sometimes it could be major concern if we develop a new perivalvular leak. I think, but in the definition, this is not including the structural valve deterioration. So I think this is debatable. And another thing is for the hemodynamic, they're trying to standardize this sort of moderate hemodynamic SVD and the severe hemodynamic SVD and the more fragile SVD. This is also a little bit confusing if you carefully look at this. Still a little bit. If you look at the hemodynamic, if mean gradient increase greater than 20 change from baseline, how could this consider as a severe hemodynamic SVD? So I'm not sure, because a patient with gradient over 20 doesn't mean this is a patient have a severe aortic stenosis. Does not need intervention. So if you consider as this is severe hemodynamic SVD, I think this is sort of a little confusion, because the hemodynamic as a criteria is not really severe. And also morphological SVD, and then they put the hemodynamic and the morphological SVD. So how could you combine the morphology? If morphology have some stenosis, if a moderate stenosis, but also have a hemodynamic significance. So what the category is? It severe hemodynamic morphology or severe median? It's moderate. So it's I think this is still a little bit confusing if you're really trying to combine this morphology and the hemodynamic. Also the severity, I'm still not 100% sure about this. And also you can see the one is new worsening from greater than 1 to 4 plus was moderate. But if you look at the severe, they say the worsening is 2 to 4 is also severe. So if here's a 1 to 4, and this is for 2 grade or more than 2 grade increase out of 4 is considered as severe, and the 1 out of 4 considered as a moderate. So it's a little bit. I think this is still not so clear, and probably difficult to report this. So what's occurring the evidence about the midterm durability of the TAVI? I think there's a few studies that registered. There's 2 registered, and also I put our Vancouver experience. So the 2 registered, France registers 5 years, the UK is 5 years. Vancouver we reported 10, but I think I will give us some explanation. And it randomized trial is partner 2, and the Notion trial 8 years outcome. So this is a France 2 registration, and as you know, this is a pretty early stage of TAVI, is 2010 to 2012, and the most valve is the early generation Sapien, Sapien XT, and Core valve. And the numbers are pretty good. Is pretty good numbers, over 4,000 patients. And the mortality is quite high. You can see that 40% because of high risk aortic patient. 60% of patients died at the almost like 5 years. So there were very high mortality during the 5 years follow-up. And the Euroscope got high mortality. But this also shows that the hemodynamic is very stable over the 5 years. There's no change in the valve area and the pressure gradient. But I think I want to be a caution about to interpret this data, because these are not a matched patient. These are just to survive the patient. So it's self-selected, because some patient died, you don't know what's the gradient, right? Whether there's an increase or not. So these are not matched patient. It's just to survive. There's maybe self-selected. Some people gradient low and then they survive. That could be the issue. So it's very difficult to interpret this kind of data. And in terms of incident SVD, and you can see the moderate to severe SVD is pretty high, because the moderate your gradient over 20 is considered as severe. The severe, so you see that the 6 years are pretty high, but the severe SVD is relatively low, and there's no really difference between the 2 types of valves. So overall, the severe SVD is relatively low over the 6 years, but that's also need a precaution, because as a caution about the interpret this data, because the number at the 6 years or 5 years are pretty low, and most people has died before that, and sometimes it can be a difficulty. So in the elderly patient, it's very difficult to interpret what's a long-term durability, because the majority of patient died before you basically 5 years or so 4 years. So it's difficult. And the UK registration, I quickly go through. The age is about 80, and the valve is also the old generation. And the number is relatively small, but you can see they basically only 1 patient had the severe SVD, and moderate sort of about 20% is similar. But as I said, as a number, you can see the drop is significant this follow-up. So that's why it could be sometimes it could be just due to the patient. The majority of the patients that died, so make this is a more difficulty to interpret this data. And our data is 10 years, and this is from 2005 to 2009. The other people is 5 years or 10 years. but that's also need to be age is pretty, old, 82, and you can see the 10 years, over 90 patients has already died. So the 5 years, the survival about 60%. That's very similar to the other register. And valve deterioration, you can see only 5 or 6% at 10 years, but I also should caution because the majority of patients died. There's only a few patients left. So it's difficult to say this is a truly affect the durability of the valve. So I think it's because in the elder patients, it's also for the surgical valves in elder patients, it's very difficult to interpret the long-term durability over the 10 years or it's not easy because the majority of patients won't survive that long. So this is a randomized trial, partner 2 trial, and you see that the 5 years outcome is there. And this just show you that the hemodynamic is stable, but it's also same. These are not a matched patient. It's just a survived patient. So you can see that there's no really significant change in surgical and the TAVI patient. And in terms of mortality and stroke, there's a cross at the 3 years, and there's some separation between the TAVI and the surgical valve. The surgical valve seems like a slightly better, but this separation will be continuous or not. It's difficult. I think the further follow-up will be very, very interesting. Whether this will be continuous separation or become a parallel. So as the longest follow-up as a Notion trial is 8 years data is out, and the average age is about 79, 78, and the most patient the criteria is over 70 years old. So this in the inclusion criteria. So as you see here, as the first mortality and the stroke, there's no difference between surgical but you look at I want you to see this one it's interesting because you see that there's a huge difference in terms of hemodynamic is definitely based on this figure is the core valve is much better than the surgical valve. But I just want to emphasize here the baseline after surgery, the mean gradient already reached 14 or 13. It's not really too acceptable for the surgical valve. After you implant the surgical valve, the gradients is a double digit. That's usually is not really acceptable. So I think the surgeon probably should do a better job. If I would usually is not really satisfied with a gradient of surgical valve greater than 10 after the replacement. So that means something you did not do a perfect job here because you cause a mismatch. So that's why you based on the height, of course, your gradient will continue to increase. That's the main reason here. So I want you to see this one is a moderate to severe hemodynamics SVD. So you can see that so based on the moderate criteria is the surgical valves much worse than the TAVI. But I just want to let you know because based on this is a gradient based on the gradient. So after surgical valves, the gradient already 14 or 15, and of course this will be continuing to increase, and then of course the gradient was much worse in the surgical valve. But I want to focus here. The surgical valve is steadily increase. Just I think the slope was the same, but the TAVI patient after 6 years, there's a significant jump here. That's I think we should focus on these kind of information rather than initial they say, oh yeah, it's 28 versus 14, the surgical valve much worse than. But you look at the after 6 years, the surgical valve actually pretty steady, despite the initial gradient is high, but as a core valve, you see the significant jump after 6 years. That's a little bit concerning. I think we should detail. And in terms of severe, you can severe the same. This is not a moderate, but they say you need to meet the 2 criteria. And of course, the rate decrease. But you also see even you use the 2 criteria more restricted, but you still can see the TAVI patient after 6 years, there's a jump here. So the surgical valve is very slope was keep the same. So I think further follow-up will be interesting. And in terms of severe, so the severe, the greater than 20 is also considered as severe. So, but overall is 8 years low. But this is whether this is a criteria is really represented severe or not. I think it's debatable. And so therefore the conclusion, I think is a reasonable conclusion 1 and 3. But the conclusion 3, I'm not sure that's the really like the core valve is better than surgical valve. I think as a cardiologist better than surgeon here. It's not as a valve problem. It's the surgeon just didn't put select as a nice good valve or put as a nice bigger valve. It's not the valve problem. I think it's more problem with the surgeons, I would want to say. So I want to show you here. This is a list of here. That's a detail we should look at it because this is a very important. Why is the notion tri-surgical so bad? And look at this, look at the valve size here and the valves they used. So look at this. The majority use the mosaic, epic, and mitral flow. And the ones that sort of the best hemodynamic and dynamic is only used a very small number proportion. The majority is we know the mosaic, epic, is mitral is a very small internal diameter. So you can see that also the 1921 to 23 is a majority of these valves. So of course these patients initially just cause the mismatch there, and that's caused a problem. So they should, I think, the better valve should be chosen, and also the large valve should be implanted. That's probably the main issue. So I think the overall, I can say that based on the register, I think a stable hemodynamic can be said, and the low incidence severe SVD and surgical SVC, I think probably similar. And I think it's strongly supported TAVI in the patient over 70 years old, but low risk trials relatively short follow-up. It's difficult to say whether long-term or not, but the short-term is similar. So the guidelines, they changed, so they're quite aggressive, actually down to the 50 years old. And above 50, actually, the either bioprosthetic and mechanical valve can be used. I'm not sure that that was strong evidence to support this at this point, particularly for the durability and long-term. So I think whether this is feasible to use in the appropriate, I think this is still questionable. So, and the partner too, I think people know there's 2 years is already merging together. So I think there's some concern with valve durability here. And also from both is the issue. And also French register confirms that anticoagulation actually doesn't reduce the bioprosthetic dysfunction. So I think there's some caution about it. And in the partner 2 trial, and this is actually you can see the majority of valve deterioration actually in the TAVI group rather than surgical group. You can see the bigger difference there. And also the hospitalization, also the much high in the TAVI group related to the valve issue. So, and the young patient, of course, will be more deterioration, but this interpreted from the result from an old patient, whether it is similar to that in the young patient, we really don't know. So there's no data here. So people proposed this. I don't think this practical, and it's really like we should patient informed consent, because you want 3 surgery, 3 intervention, 4 intervention. Is that practical or is it reasonable or the safe in the patient? I think it's questionable. So because of time, so I just quickly go through where as one is a high incident of mild TAVR leak. I think a moderate to severe TAVR leak, I think very similar nowadays for the new valve versus surgical valve, but the mild, I think is still high, regardless of the new generation of the valve. The mild is still pretty high proportion compared to surgery. And also the mild, there's some data show there's a trend of increased mortality even with the mild perivalve leak. So I think in the young patient, maybe this is more concerning than the elderly patient. So I think that these issues really not cleared yet. And another thing is the pacemaker. I think there's a lot of presentation with a new technique, new implantation technique. The pacemaker can significantly reduce. However, the left bundle branch, I think, is still pretty high, regardless you high implanted or new generation. I think a left bundle branch is still pretty high, and this is clearly associated with increased mortality based on the partner 2 trials data. So I think another thing of coronary access is a major issue with supravalve implant. You can see that almost 35% with the initial TAVI, you have a coronary access problem. So this with the valve, there will be more troubles, particularly with with a supra-involved valve, that's almost impossible. You can see that there's only 5% is favorable coronary access. The majority have some problem with the coronary access. So this is it's really issue in the young patient. So in the elder patients, not an issue, but the young patient. Another major issue is the surgery. So we strategy to do a surgery again. Is that safe to do for the young patient? And I think the surgical risk definitely is high with a TAVI and then the surgical valve. So, and usually end up you need a root procedure, these kind of things. So I think this should be really considered in the young patient. And the mortality is definitely high compared to surgical valve. And this is really should be done as like 3, 4, 5 times the intervention with in the young patient. Is that's really a practical or ethical or these kind of things? I think I don't think there's evidence supported that. And unless there's a really optimal condition, and you may consider this kind of a TAVI or surgical valve as tissue valve. So I think that's my conclusion is that in the young patient, I think it's premature to offer in a healthy young patient. I think as the decision should not be just by the heart teaming. I think the patient informed consent is the most important part in decision making. It's not just by heart team, because you need to clarify the 3 or 4 times, repeat is it safe or not. And don't forget the option of mechanical valve in young patient. I think this still shows some long-term benefit, survival benefit in young patients. Thanks.
Thank you, Dr. Yes. Thank you so much. Well, I totally agree with your conclusion. And well, I think that because of the evolution of the TAVR valves and a lot of improvement, so that now that the so-called power valve leak and is much less, and as you mentioned, the performance is even better in the TAVR valve. So and also it's good to know that all the all-cause mortalities and seems the durability and the outcome is quite equal to the surgical valve. So well, is there any comment from moderator or our audience?
Professor, I have a question. You did many balloon expandable valve. The valve need crimping and repeated post-dilatation sometimes, and in VIV scenario, you may need to break the surgical valve. So that kind of mechanical injury, would that be possible an issue in the long run?
I think excellent questions. I believe there's some effect, particularly with a high pressure like cracking, up to the 20 psi. I think that's a pretty high crack on the stent, the metal. I think that's definitely probably will have some effect on the long-term outcome. That's my belief. There's also the previous study show there's some pathological change, so histopathological change.
Igor, do you have any comment?
Yeah, Chen, you raised a very important point about the surgeons having some more difficulty with doing the redo failed THV valves. So patients who have had a TAVR failed, and then you need to go in and do surgery to remove the transcatheter heart valve. Comparing redo bioprosthetic surgical valves and TAVI valves, do you find a very big difference in terms of the risk of this redo surgery?
Yes, I think for the earlier failure, TAVI, there's no different. But if you're 5 years or 6 years, 7 years, or even like a valve in valve after, it's definitely much more difficulty compared to surgical valve. And also you have usually end up need a root procedure, aortic procedure. So that's, I think, should consider as a morbidity, because otherwise the surgical valve, you can do a very safe reoperation, no issues. But for this kind of end up, you need a major operation, as definitely is a concern.
But is it just the taller valves, or is it all valves have the same problems?
No, the tissue is growing into the stent. because they cover the stent. Basically, particularly the core valve is basically encased into the aortic wall. So you need a peeling off all these kind of things that end up you damage the aortic root, and then you need a patch or you need aortic root procedure. That's a problem.
So you even see in balloon expandable valves as well that you need to do a root.
Right. Sometimes they can depend on the root. If the root is big, I think not a problem. But it's when the sinus valve is small or the ST junction is small and they attach to the stent, that's the same problem because it can ingrow.
Right.
So, well, because of our schedule is a little behind, so we have to proceed to the second topic that will be given by Dr. Tirone David.
Professor David is currently the professor of surgery University of Toronto, Ontario, and attending surgeon of the Division of Cardiovascular Surgery, Toronto, Ontario. So I think he's a very famous surgeon in the surgical field, and had developed the TAVI operation. We hope that he can also provide some insight into the durability of bioprosthetic valves in the aortic and the mitral position. Professor David, please. You are mute. Please. Microphone, please.
How about now? Can you?
Yeah, no problem now.
Thank you. I was asked to talk about durability of bioprosthetic heart valves. I have no conflict of interest to disclose. Bioprosthetic valves were introduced in the 60s by pioneers, heart surgeons in different parts of the globe, in Europe, as well as in Australia. They are taking animal valves, mostly porcine, or in Australia, kangaroo valves, and fixed with formaldehyde. And the fixation method was a problem. The valve was very stiff, would not last very long. Within a few years, would fail. A breakthrough occurred in France with Professor Alain Carpentier in the late 60s when he changed it from formaldehyde to glutaraldehyde, which polymerized the connective tissue, the fibrous tissue of porcine valves. And the result was much better, much more durable, and the tissue much more pliable than formaldehyde. Soon after, Mr. Warren Hancock, developed a company in the United States, and he started manufacturing porcine valves, the original Hancock valve. The first implant was in April 1970 by Dr. Norman Shumway in California. In England, about the same time, Mario Ionescu developed pericardial valve, which again, he was working in pericardium, but fixing with the formaldehyde, which wasn't ideal. Then he changed the fixation method and they developed a commercially available valve called the Ionescu Shiley, which became very popular in the 70s. The problem with bioprosthetic valve are basically two. One is the hemodynamic performance, particularly in porcine valves. And the second is durability. The formaldehyde all fell apart at 4 or 5 years. The glutaraldehyde appeared to be more durable. As far as the hemodynamic is concerned, there are all stenotic valves, particularly again the porcine bioprosthetic valve. If you know a thing or two about geometry, if this is the annulus of the valve, if you implant a porcine valve, that's the resulting size of the orifice, because area is a function of pi times radius square. So by selecting better tissue, better pigs with less muscle bar, you can increase the effective orifice. But more importantly, by making the stent thinner and smaller, you can improve the hemodynamic. And of course, the best one would be to remove all the stent altogether and make a stentless porcine valve. But they're not as durable as this here because we are not perfect technicians as the technicians that make the valve are. They make this in a lab, take all the time they need, and to implant this in the operate room is much more difficult. Durability is the second issue of a bioprosthetic valve. And durability is a complex issue because invariably the glutaraldehyde fixed tissue is going to degenerate. It's a matter of time. What we know is that the younger you are, faster degeneration. Aging process delayed the degeneration. The nature of the tissue, porcine or pericardium, is very important. Remember, pericardium wasn't meant to be a valve. It was designed by a biomedical engineer to make a valve. The leaflet design of the pericardium is very important, as I'll show in a minute. And our crucial, of course, is the stent. The stent should be designed not only to optimize the effective orifice of the valve, but also to minimize the stress. Regardless of the tissue, to design the leaflet or the stent, the biological component is very serious, and calcification is going to happen invariably. You can wash a valve with alcohol to remove all the phospholipids, and this reduces calcification, particularly of pericardial valves. You can soak in sodium dodosyl sulfate in porcine tissue and reduce calcification, but doesn't prevent alpha-aminoleic acid reduce calcification in both porcine and pericardium. But it doesn't prevent. It retards calcification. And of course, we cannot change the mechanical stress. If you implant a bioprosthetic valve in the aortic position, it's going to be less stress than in mitral, because the closing pressure here is diastolic pressure. In the mitral, the closing pressure is systolic pressure. There's an intrinsic problem on the position of the heart. And finally, there are several other biological factors that we don't understand. We have a very large experience with porcine valves in immunosuppressed patients, transplant recipients, liver and kidney. They do not calcify their porcine valve, but they calcify the pericardial. We don't understand this mechanism. And the blood group likely has an effect on porcine valve as well. It doesn't have in pericardial. Patients in group A are much more likely to calcify a porcine valve than a B or O. Patients in group O negative have the most durable bioprosthetic valve, and we don't know the mechanism. So a lot to be learned yet. Why the leaflet fail by calcification with tears or become stiff. We learn a lot about pericardial valves since it's much easier to construct and has by far better hemodynamics. The initial pericardial valves were constructed by wrapping a pericardium around the stent. Outstanding effective orifice. Ionesque Shiley, mitral flow, and more recent trifecta. None of them lasts very long. After 5 years, they began to fail. At 10 years, 30–40% have failed. Have failed because, as the sketch is showing here, they open fully. There's an incredible amount of movement around the stent. Arnie Lang, an engineer with Baxter and Edwards in the 80s came with the idea that perhaps the pericardium should lie inside the stent. The valve won't open very much, but if it doesn't move very much, the pericardium is less likely to fatigue. And indeed, was a great discovery. The Edwards Magna, the Resilia, and the Medtronic Avalus are designed this way. They are very likely much more durable than Trifecta and Sorry Mitral Flow for a pure design or engineering. You can imagine that all the TAVIs are like the Sorry Mitral Flow and the Abbott. They open fully to the size stent. You cannot expect a TAVI to last as long as a Medtronic Avalus or the Edwards Magna. The durability is going to be at the best like Sorry Mitral Flow or Trifecta. Unfortunately, we talk about valve failure in 5 to 7 years. Well, 5 and 7 years is not enough to judge a valve. We need at least 15 years, particularly in older patients, anybody over 60. In younger patients, 20, 30, and 40, 10 years is plenty because they do fail in a large proportion by the first decade. But a 60, 70, and 80-year-old man needs at least 15 years to determine the true durability of the valve. And a misconception of heart surgeons, and unfortunately, they are influenced by salespeople. Because it's new, doesn't mean it's better. Oh, there is the latest technology. Well, technology has failed better than the best. Unfortunately, if you do need 15 years to judge a bioprosthetic valve, it's too soon to make any judgment on TAVI. Perimount and Magna have been around for over 20 years. The Hancock too for 30 years. And there is enough data out there to support these two valves, their durability at least. There's an extensive amount of data on AVR, limited on mitral valve, very limited in pulmonary, and practically no data on long-term outcomes of tricuspid valve replacement. The best, the most comprehensive paper on perimount is by Bourguignon from France, when they analyzed the outcomes of 2,659 patients, very old, 70 at the time of the operation, in relative short follow-up, mean follow-up of only 6.7 years. But let me tell you, large number of patients, 2,600, and short follow-up. Why? Look at the graph on the right side. Because in the end of 20 years, 40% of the patients died because of the valve. There are valve-related deaths. As a consequence, the survival is very low. If so few patients are alive, only 28 patients at 20 years, the mean follow-up is going to be very short because most of them died, but the valve let them down. Surgeons cannot read this, cannot see that this is the real message here, that a large amount of patients died because of the bioprosthetic valve. If you take a look by age, the echocardiographic evidence of failure is not very intense in the first 15 years in people over 70. It's more marked 60 to 70 and pretty bad in people under 60. So bioprosthetic valves in patients under 60 is not very durable. Even the best ones, like the Magna or Perimount, they're not very durable. They are satisfactory in over 70. You might accept in patients over 60. Freedom from reoperation is different than freedom from valve failure. Valve failure is a clinical investigation endpoint. This one here, the patient cannot carry on with their valve anymore, and that's why they're reoperate on. They're not equal. This on the left is by far more important. 10 years ago, we published 20 years outcome of the Hancock II valve. It's an old valve, first introduced by us in September 1982. It's almost 40-year-old valve, but it's still unbeatable when it comes to durability. Not very good hemodynamically. So you should not implant a Hancock smaller than 23 in any patient. Should be 23, 25, 27, 29. If you follow these rules, the outcomes are pretty impressive. But again, survival is a function of age, and durability by echo or reoperation is a function of age. But if you take a look now, patients over 60, very, very few failure at 20 years. It's not bad for somebody 60 or older. 60 or younger, as the same as the perimount, fails too. So unless you're prepared to come back for a reoperation, or more than once, you're going to have a valve failure. Are pericardial valves more durable than porcine valves? No. The first generation of pericardial that was wrapped outside the stents, yes, but not the newer ones. There's no evidence that perimount is better than Hancock II or Magna better than Mosaic. Hemodynamically, they're better valves, the pericardial valves. Durability, no. Actually, there is evidence that if you replace an aortic valve with a porcine valve, your patient is likely to live longer because there'll be fewer valve failures. Mayo Clinic has a large database, close to 3,000 patients, compared perimount with Mosaic and Hancock, all the porcines, and some bad pericardial and some bad porcine from the first generation yet. And yet, the follow-up not very long either. They're older patients. But 20 years later, there's a 10% improvement in survival, 1% per year. That's not bad, particularly if you're the patient. How about durability of mitral valve replacement or bioprosthetic? Very few papers. No paper more than 10 years, except, again, from ours, in our institution, and from France. Average age, 67. There were 559 patients. 1 in 4 had a previous operation. Survival is worse than aortic. They don't live as long as aortic, although it's the same valve. And durability is a function of age again. At 15 years, half of the patients under 65, the valve had failed by echo criteria, and a bit better, only 20% in patients older than 65. So it's a reasonable option in patients over 65. From France, they too had fewer patients, similar age to ours, but look again, the survival of the patients in red. And here's the number of patients that died because of the valve, valve-related deaths, pretty high. Age, again, was a major factor, and in patients 70 or 80 do not require reoperation. Patients between 60 and 70 in green, many more under 60. Practically they all came to reoperation. Are pericardial valves more durable than porcine valves in the mitral position? There's a recent meta-analysis from a group of Italian surgeons. They plot all the data, some 4,000 patients collectively, and compare mosaic, pericardial valve, Carpentier porcine, and Hancock mitral valve. The conclusion of the meta-analysis, porcine valves are more durable than pericardial valves in the mitral position. They're not as good hemodynamically, better in durability. I don't want to talk very much about transcatheter aortic valve because Dr. James E. described in detail to you. They appear to be durable, but they are changing the definition of bioprosthetic failure. And it looks like and this is a collective series, most of the patients had core valve. In the end of 4.4 years, mean follow-up, 3% had moderate or severe valve degeneration. Only 1.6% had severe. However, the mortality was 78% at 7 years. So many patients died that we don't know if they died because of the valve or died because of the disease. This was recently published in Jack and his partner 2 trial, where they compare surgical versus TAVR. And they had a registry on SAPIEN 3. SAPIEN 3 and surgical was no different than 5 years. But the SAPIEN XT used for the trial, failure rate was much higher. So they're gonna fail too. The patients have to live long enough for failure. 5 years is grossly inadequate. You need a minimum of 12 to 15 to make a meaningful interpretation of the data. We surgeons made a major mistake. We start using mechanical valve only, and then as bioprosthetic became available, we all switched to bioprosthetic, and it had been a disaster because many patients are suffering now as consequence of our act. This is the United States. I don't know how it is in Taiwan, but well before TAVI was invented and became available, 2006, this is almost 4 or 5 years before the advent of TAVI. Look what happened to the number of mechanical valve in the United States. Declined down to 20%, even in people who are 20 or 30-year-old. This is a gross disservice to the patient. And bioprosthetic is rising. Now, the justification is, well, when it fails, I can do a valving valve. For how long? If they are 20, 30, or 40-year-old. I think it's a mistake. Mechanical valves, particularly the newer ones, are not that bad. And in the end, it may prolong their lives. Thank you.
Thank you, Professor David, for your excellent review and insight of this topic. Professor Wei, any comments or?
Yeah, Dr. David, I thank you so much for your invention of to develop a valve sparing aortic root replacement. I like your operation very much.
That's a good operation.
That's very good. That's very good. Yeah, at the beginning it's a little bit difficult, but I'm going to do that next week and for a patient with dilated aortic root. So
it takes a few to learn, but once you learn, the operation is very good.
It's a very good operation. Yeah. Well, I agree with you that the pericardial valve looks not superior to pulsing valve, since I have the early experience with Ionescu valve, with that valve is a pericardial valve, and at that time the durability is very short, about 3 to 5 years. So we discontinued to use that anymore. So, well, I agree with you. So the bioprosthesis, the evolution of the bioprosthesis takes us many years, and with the improvement with the manufacturing, the procedures, it's become better and better. Well, now still many patients need bioprosthesis, especially for the aged people. So thank you so much for your detailed introduction and the analysis to the data for us. Thank you so much.
Thank you for inviting me.
Thank you.
Yes.
Maybe we have to move to the next topic. Sorry for that. The next talk will be delivered by Dr. Vinnie Bappa. Dr. Bappa is a very famous surgeon, but he is even more famous in the field of transcatheter intervention. He was the surgical lead of the TAVI program at St. Thomas Hospital, which is the largest TAVI program in UK, and the founder of the the London Valve. He also get involved in many pioneer work in the TAVI field, such as the transaortic approach, and developed smartphone apps, which are used all over the world as a reference tool for valve-in-valve procedure. 3 years ago, he moved to Columbia University Medical Center in New York, and now he's the lead of advanced mitral and tricuspid therapy. Bappa, Vinnie today is gonna share with us the shared decision-making in low-risk patients with aortic stenosis. Professor Bappa, please.
Yep. Just wanted to confirm that you can hear me.
Yes, please.
Yep. Thank you very much. Very interesting 2 lectures before by Janye and Professor Tirone David. But it just makes my task very easy now. I'm just going to speak on our responsibility to today to accommodate new inventions and extend that to the patient. Now, these are my disclosures. So this presentation is definitely not going to be about SAVR versus TAVR. I think it's going to be about how we can use both technologies appropriately at given time. Rightly so, many years ago, the only option and debate used to be mechanical versus tissue valves. But then came TAVR 15 at least years ago in my life, and that really shook the world completely. This is an extremely attractive option to patients. It's less invasive, shorter hospital stay, and this has really had a profound impact on management of aortic stenosis for sure in all over the world now. The evidence has been systematically built, initially in high-risk patients, then intermediate, and as we know now in low-risk trials as well. There are very good registries, such as SOURCE registry in Europe and TVT registry, which is a post-market registry. And this is continually showing improved results. This is just a snapshot of the registries on which the current recommendations are based, which are 65-plus-year-old patients can have TAVR now in United States. They are also called as low-risk patients, or sometimes we commonly refer as young patients. We just have to keep in mind is similar to some of the surgical valves, which Professor David and Janye showed, is a lot of TAVR devices are also different. The reason I say that is our evidence could be for one device, but we can't necessarily apply it to another device. And as you know, in the market, a lot of these devices have disappeared very rapidly because of inferior results and non-feasibility in less invasive approaches. So this is very critical now that the shared decision making, all patients want less invasive option. All young patients and low risk patients want to go home in 2 days and they want to do what they are doing today now is with a family, in active lifestyle, etc. We still have to remember that the patients included in the trial are very selective, and a lot of these patients we see every day in practice are totally different. And again, this is very critical because surgery still may be the best option for these patients. But we are not going to discuss that today. We are going to discuss a couple of things. We are going to take an ideal patient who is young or low risk and then discuss how do we incorporate the understanding and evidence today. So first thing, patient's expectation for bioprosthetic valves. First expectation is they don't want anticoagulation. And we have to really keep that in mind. A lot of literature today doesn't report use of anticoagulation. Second is they want to avoid reoperation if possible. This is very critical. I think this is again, these two important things I discuss with patients every time they see me, and I do SAVR and TAVR, so I am very impartial towards what they should get. So what we want to really achieve by shared decision making is we want to give patients good hemodynamics. We want to avoid anticoagulation. We preferably want them to take risk of one procedure, but if second procedure is needed, it should be less invasive. And this is probably how lifetime management is going to figure out in future. So to achieve that, we have to take three things into consideration. This is very important. All 65-year-olds are not going to live 30 years. Similarly, 70-year-olds are not going to die in 10 years. So life expectancy of the patient, we have to match with SAVR or TAVR durability, whichever we're going to choose. And if possible, we have to think of second intervention, and that could be the lowest risk and best result intervention. And I think you will probably agree with me as we go through that this is very critical. So let's look at definition of young patients, because this impacts a lot of things. So my definition of young patient is not based on age, but my definition is based simply on life expectancy and durability. So for example, if the patient lives longer than the valve, then he is young. And then if valve lives longer than the patient, that patient is old. This is, I think, a very simple definition. So let's look at life expectancy in the United States. It's roughly 78 years. Maybe in men, it is around 73 years. But the life expectancy in Japan is 10 years higher. So we can't apply the same guidelines which are published in Europe and United States to certain countries like Japan, China, India, Brazil. Everybody has different trajectory in terms of life expectancy. And the durability equation is not very clear. As Professor David said and Janya said, there's a lot of confusion. We hear a lot of marketing slides. What was glaring to me in Professor David's talk was Hancock 2, for example, sure, after 10 years, maybe 12 years, 15%, 50% are not durable. But at 12 years, only 50% patients are alive. So actually, we are looking at very small subset of patients and extrapolating the durability even in surgical valves. So it's very important for us to really understand for each patient what is the best scenario. I think this is what is really critical. What about TAVR durability? Of course, durability of TAVR is still in question because as we heard, surgeons want 15 years data. I think it's reasonable that we have at least 7 to 10 year data to understand how it fits into our current clinical scenario. Were a lot of concerns, including I had concerns about stiffer stent, non-flexible stents, asymmetric deployment. And what we have seen somehow is, although halt and ham is slightly higher in TAVR, it can still be managed relatively okay. I think time is, of course, going to prove, what the real TAVR durability is. We also have to remember that surgical valves and new models which were introduced and are still being introduced assume that the durability is good. And actually, if you look at it, this is a Toronto SPV valve, for example. After 6 or 8 years, the durability just dropped down tremendously, and this valve was discontinued by St. Jude Medical. So again, every possible durability should be studied between 7 to 10 years is very important as we go in future. Now, what about second intervention? Because as I said before, we want durability, life expectancy, and second intervention. So let's look at if we do a TAVR in a younger patient or a low risk patient who's going to live long, if we have two options. One is, as a surgeon, I explant the TAVR valve and implant a SAVR. And the second is we do TAVR in TAVR. Now, this is very important because let's not assume we know everything yet, because this is a newly evolving field. So TAVR in TAVR is of course a promise, and everybody's going to like it. The patient's going to like it. Doctors are going to like it because patients, will love it. But explanting TAVR is probably a reality because as we are implanting small TAVRs, and I'm going to show you why this is a reality. So the concerns are many. I think poor hemodynamics because it's a Russian doll effect, coronary obstruction risk is real, valve thrombosis risk is real, and a lot of these patients in our practice end up on anticoagulation. So let's not forget, we are choosing a biological valve because patients don't want anticoagulation. If we want to give them anticoagulation, might as well implant a mechanical valve in these patients. And why then bother about two different procedures? So these are some of the challenges we are going to face as clinicians who are involved in this practice. We also don't know which combinations are feasible. So in my practice, we have done evolutar in sapien, we have done sapien in sapien, and we have done sapien in evolutar. So I think we still don't know the ideal combinations, the risk of coronary obstruction with each combination. So this field is still evolving, and we should not assume that complex procedures like basilica and chimney stenting are the right way forward if patients are lower risk and can have surgery very easily. So the current data on TAVR and TAVR in my mind is extremely unclear with very high gradients, risk of PPM, AR, etc. And I'm not trying to be skeptic. I'm just trying to interpret what is there today. So let's look at TAVR explant. And I've been heavily involved in this field now, trying to educate surgeons to be mindful of TAVR explant, because initially we did a mistake as well. We thought TAVR explant is going to be easy, while some people assume that TAVR explant is going to be extremely difficult and will require root replacement and ascending replacement. That's not very true. We have to be mindful of how the taller devices interact with ascending aorta, but we also have to be mindful of how shorter devices are interacting with the LVOT structures such as mitral valve, conduction tissue, and so on and so forth. So this is, I think, really very important going ahead. The TAVR explant registry data has not been very good because this is early experience in very high-risk patients. And as you can see, 1-year mortality in these patients is very high. In my mind, the TAVR explant will become a reality if we can bring down the mortality of TAVR explant to the first-time surgical AVR. And I think as surgeons, that should be our goal in future. Very quickly, I'm just showing you a TAVR explant video, and I'm assisting one of my senior residents here. This patient had an explant nearly 2.5 years later after implant. And what we do in every explant now is we carefully do CT scan, of course, for cross-clamp, but we make sure that we check the LVOT structures properly. We take our time to peel off the stent from the pseudoendothelium and the aorta. And this, in my practice, honestly, has reduced the need for ascending replacement to zero. Once we peel it off properly, the nitinol devices are extremely easy to squeeze out from the LVOT. If you are doing a sapien explant, however, you have to be careful not to pull out the stent, but crush it inside slowly and steadily, and then remove it, because sapien valve expands in LVOT to fix. So it's extremely near. And I have actually seen people damaging the mitral valve and conduction tissue needing a repair. So I think here you can see, this is a bit fast video to keep time. We are now separating it steadily by pushing the stent inside and then removing the device. And then AVR becomes pretty simple. What about second intervention in SAVR? I don't need to go through this. This is a surgical meeting. We can do valve-in-valve or reoperation, and both are a reality. We have got decent data on both of them. Valve-in-valve, of course, we know works very well. There is risk of coronary obstruction and Russian doll effect. But the newer generation valves, such as Inspiris valve, will allow us to expand it by at least 2 to 3 millimeter in diameter, and that may take into this Russian doll effect away. So let's take a patient who is 60 to 65-year-old, who comes to our clinic. He's low risk, he's young, and I think he wants a bioprosthetic valve. He doesn't want a mechanical valve at all. And I think we should expect this valve to last at least 15 to 20 years, because this patient life expectancy is going to be that. So if I'm just choosing a SAVR valve, which is Inspiris or which is based on Perimount, as against, a TAVR, which is SAPIEN 3. And you can see from the comparison that Inspiris has been developed with durability in mind, and SAPIEN 3 has been technically developed to get the French size down to 14 French or 13 French. So slightly different in terms of the goal, why these valves have been developed. I always use CT planning, and I encourage all the surgeons to use CT planning, even in AVR today, because we heard from Janye in Notion Registry trial, a lot of small valves were implanted. I usually select my size. I can predict my size today from the CT. And if needed, I can do root enlargement. The percentage of patients needing root enlargement in my practice is around 7 to 10% only. Approach in this patient is going to be minimally invasive. He will stay 5 days in the hospital. He will go back to work around 3 to 4 weeks. If I do a TAVR in this patient, he will get good result. It's a tri-leaflet, evenly calcified valve. He will have 2 days in hospital, back to work in 7 days. Now, as far as lifetime management of this patient is concerned, this is how it's going to look like. If I do a SAVR, I hope that this will last 15 years, say. And second intervention may not be needed, because this patient's life expectancy fits into that 15 to 20 years. If I do a valve-in-valve, it's an Inspiris valve which will expand. So hopefully I can give him a second less invasive intervention, which will last lifelong. His need for anticoagulation, as we know from the valve-in-valve registry, is very, very low. If I do a TAVR, his second intervention is 100%. He's going to need a second intervention. And if I do a TAVR in this patient, there's a good chance he will end up on anticoagulation or a TAVR explant when he's much older. So I think we have to keep this in mind. So I feel strongly that at present, with the evidence, if we do this, we will have one of these two options, which are not ideal. Plus, patient has to take risk of 2 or 3 unknown interventions in future. And this is just for 2 or 3 weeks extra recovery after surgery. SAVR, on the other hand, he will have only SAVR, or he can have SAVR with valve-in-valve, which I think most of us are doing now, and we are pretty confident of it. So I think my final thoughts are, when you see a patient today, and we always see them together. Life expectancy and valve durability should be considered together in decision making. The current evidence in my mind at present still points to SAVR, provided we choose a good size valve, such as in Partner 3, and we start using CT scan for less invasive approaches and choosing the right size valve. And I think we still should be open-minded that long-term durability data can change this algorithm again. We should not assume that surgical valves will last forever and TAVR valves won't last at all. I think we need to keep our mind open as surgeons so that we also give best to our patients. Thank you.
Thank you. I think it's really, controversial in decision making regarding the younger patient, or the defined by your definition, should be taken as surgery or transcatheter intervention. So, Dr. Li Guozhen, you have a question? You are mute. Please turn on your microphone.
Thank you, Professor Bappa, your excellent talk. I have one question, actually 2 questions for you. There are some my young patients, maybe around 20 to 40 years old, they ask me whether they can receive the mechanical valve replacement first, then explain the mechanical valve and shift to bioprosthesis, maybe at 65 years old, 70 years old. Do you think such an idea is reasonable or not? And the second question is about how about your comment about the rapid deployment aortic valve? Is the pressure-free design getting more advantage in hemodynamic and durability? That's my second question. Thank you.
Thank you very much. I think it's pretty unreasonable for us to advise patients who are in 30s and 40s to have a surgical biological valve and then expect them to go on till age of 70. My thesis when I studied was, biological valve replacement in young patients. And not average, but I would say the longest biological valves around age of 30, third decade, 40, could last probably 10 to 12 years only. And then we are going to do a TAVR in them. We'll probably give them 7, 8 years more. So I think they are going to receive second surgery come what may. I think it's very important for patients to understand that. But at the same time, I have had younger patients in which I have chosen biological valve because they are at bleeding risk or they want to really pursue active lifestyle. And I think in those patients, it's reasonable. And surgeons like Janye, me, we have been using CT scans for long in these patients. We give our patients benefit of less invasive approach, using the best size valve, and so that we optimize, we already start thinking of second intervention. And I'll give you an example. Young patients usually have a bicuspid valve. Till valves came into light and I saw coronary obstruction, I never used to think that I need to orient the struts of the surgical valve in a bicuspid valve in a way that the coronary obstruction risk will be lower later. So I'm modifying my surgical practice to fit these patients if they insist on biological valve for sure. Because mechanical valve also and anticoagulation also can have a lot of problems. The second question about rapid deployment, I think with inventions like Inspiris valve, it has fallen out of favor. I think if we are going to open a chest, in my practice, I used to use both Perceval and Intuitive platform. The problem with both the platforms could be, you could say that Intuitive cannot be expanded in future, and Perceval can have a significant risk of, I would say, PV leak, etc., if your sizing is not correct. So I think given those uncertainties, I feel more confident now to implant a good size Inspiris valve so that in future, the first operation is predictable and second operation is easier with the elimination of Russian doll effect. I hope I have answered your question.
Thank you. Thank you very much.
Now let's proceed to the last topic in this session. The topic will be given by Dr. Meng Xu. Dr. Meng Xu is the chief and the professor of the cardiac surgery at Anton General Hospital, which is the affiliated hospital of Capital Medical University in Beijing. He has a lot of experiences in doing various kind of surgical procedures, such as the transplantation, ECMO, and atrial fibrillation ablation. He's especially in the recent 10 years, he's focused on the valve repair and repair for the complicated valvular disease, especially for the mitral valve, and also valvuloplasty for the rheumatic heart disease. He has a lot of publications and a lot of awards in China. So it's our pleasure to invite Dr. Meng Xu to talk about the topic of surgical mitral repair. Thank you, Dr. Meng Xu.
Could you hear? Could you hear me?
Yes.
Yes.
Okay. So today, according to arranged, I will talk about how to perform the successful mitral valve repair in OR. So I want to talk the repair from the three aspects: the good exposure, accurate detection of the natural and the stator mitral valve dilation, and the third is the repair strategy. So for the exposure, I think the first thing is the approach. The selection of the approach is based on the patient's body shape, the type of the patient's disease, the convenience of the equipment, and the surgeon's familiarity with the approach and the ability to respond to it. I mean, we couldn't keep that from the minimally invasive. So I think for the approach, we should be a wise surgeon, not an explorer. So second is after open heart, the pericardial cavity is filled with the pericardial suspension direction, and the mitral valve annular forming suture is placed before the mitral valve exposure as a common measure for our team. For the accurate detection of the natural and mitral valve lesions, I think the water test is the most common measure. So when both the anterior lifts and the posterior lift are affected, the principle is the posterior leaflet should be evaluated first, and the anterior leaflet can be assessed after PML is repaired. And if you want to check the anterior lesion, so my experience determine the A2 anatomical area is very important, and show you this case. So before operation, the TTE of this case reported the A2 and A3 area prolapse. So when we use the artificial cord, put the artificial cord tensity directly on the posterior lateral papillary muscle or anterior muscle. So we make the two sutures are placed at the corresponding commissural of the anterior muscle and the posterior muscle. Then lifting the two suture and make the water test again, we can find this video show that only A2 prolapse, the port tendency near A1 was prolonged, and the short tendency near A3 was not significantly affected. So therefore, we should put the artificial port tendency on the anterior middle medial muscle is correct. Repair strategy. Choosing the appropriate repair technique is easy to see, but hard to do. So in my team, for the posterior leaflet lesion, our principle is not to resect. So for the patient without prolonged posterior leaflet, we usually to use the tragal folding. Then for the patient with prolonged posterior leaflet, we will do the partial folding. That means the proximity of the prolapsed PL to the annular is folded and sutured under the ring, which reduces the height of the posterior leaflet. This technique has then advanced of tissue preservation and can readjusting the folded height. And for the anterior leaflet, A2 air relation, generally we use the artificial port to correct. And for the A1 or A3 air relation, usually we use the H-to-H procedure. It's very simple. For the primary lesion, artificial ring should be selected according to the area of the anterior leaflet. So after repairing, left ventricle water test is a method to determine the quality of repair surgery. I means the collaboration height of the A2 or P2 must be measured routinely, and this cannot be less than 5 millimeter. The good shape of the mitral valve after successful repair surgery is look like this picture, look like the fat baby smile drop. So for the rheumatic, the rheumatic disease is the biggest mitral valve repair center in China. We proposed a feasible and easy to breastbone repair technique according to the Chinese patient's character. So we call that the Commissural plastic. Then standard 4 steps. That means the shaving the thinking calcium the tissue, and the second is tracking the area of the commissural area, and third is do the good commissural rotomy, and the fourth is releasing the subvalvular structure. So here is the rheumatic case. We underwent the scroll procedure. You can see that's the correct the tip. Okay. Could you see the PPT?
Yes.
Right.
No, it's okay.
Okay. So we'll continue. So we can see the 4 steps. The first thing that's shaving the thinking and calcium tissue. And right now we're checking the commissural area to make sure the commissural border and where is the end point of the corotomy. So this is the third step to do the commissural rotomy. And the fourth, only the releasing the subvalvular papillary muscle. So for the posterior commissural, the similar procedure we do. Shaving and checking. Then do the commissural rotomy. Okay, we can do the water test, then plus the physio to artificial ring. So post-operation, the mitral open area can get the 3 cm and no regurgitation. So last year we published our data. This is 529 pairs, the world's largest pairs of the rheumatic mitral valve repair and replacement clinical comparison study. So for the perioperative mortality repair group with using the SPOR procedure is the 1/4 of that of the replacement groups. So for the 7 years follow-up, the mortality in repair group with using the SPOR procedure is the 1/4 of that in the replacement group. Addition to the clinical study, recently we also performed the VFN analysis by special echo to prove the superiority of the repair surgery over the replacement from the imaging patient. So compare with the healthy people, whatever the artificial mechanical valve or the artificial bioprosthetic valve, only the repair patient has the closest blood flow character to the healthy people in the systolic of the left ventricle. And the clockwise vortex is formed in the outflow tract, addition to the rheumatic repair surgery, not only repair function, but also the anatomic and even the hemodynamic states have been repaired. So therefore, it's noteworthy that repair is the first surgery choice. It can be benefited to the patient most. So thank you very much.
Thank you, Dr. Meng Xu. Okay, thank you so much for your detailed technique of the mitral valve repair, especially for the rheumatic heart disease. So I think it's quite worthwhile to do this kind of surgery instead of to replace the valve in some selected cases, I think. So is there any comment from the from our moderators or commentators? Okay, probably it's because we are quite, we are behind the schedule, so I have to stop the session. Thank you so much for all the moderators and the commentators. Thank you so much. Dr. Meng Xu also, thank you. Okay.
Thank you.
Okay, we continue the next session. I would like to invite Dr. Cao Dianping to chair the session with me. The first talk will be delivered by Professor Chen Mao, who is currently the director of Transcatheter Heart Team at Sichuan Huaxi Yuan. The talk will be delivered by a video. Please show the video. Thank you.
前面了，非常荣幸有这样的机会来跟大家一起探讨一下TAVR在2叶瓣当中的应用，现在的一些实践和还没有解决的问题。其实呢，2叶瓣呢是一个年龄相关的问题。从这个数据当中，我们能够看到，如果接受外科换瓣手术的病人的年龄相对较轻一些，就会发现2叶瓣的比例就会明显的要高出很多。那么我想呢，这也是为什么在中国的TAVR的研究当中，为什么我们2叶瓣的病人会相对比较多的一个重要的原因。比较partner 和这个 co-op high risk 研究的话，能够看到中国进行的这种临床上前的研究的话，普遍的平均年龄呢都要年轻几岁，只有70多岁。那么这就导致了在中国的这些研究当中，我们能够看到 中国的TAVI病人二叶瓣的比例会相对较高，那么37.1%左右，远远高于了西方国家，也高于了我们亚洲的这些其他的国家和地区的这样的一个。那么这个呢是跟年龄明确相关的。比如说在中国的研究当中的话，我们平均年龄73岁，在亚洲的其他地方和就看到它的平均年龄是82岁，所以这个年龄呢是导致我们为什么在中国大陆地区的这种TAVI病人当中二叶瓣比例相对较高。那么对于二叶瓣的分型，大家都非常熟悉的是 Server 的分型，那是这个是我们最经典的二叶瓣的分型。当然在 TAVI 的这个时代的话，有一些新的分型也提出来，比如说哈桑吉拉哈维提出来的这样的一个 TAVI 特殊的就是一个特殊的二叶瓣分型，不仅仅是考虑了我们的一个级，也考虑了我们的 Commissural 这样的一些情况。其实在我们实践工作当中的话，我们有很多的医生已经在做二叶瓣的病人。那么对于这样的二叶瓣 TAVI 的结果会怎么样呢？从这个 meta 分析当中能够看到的是，它其实总体来说还是差不多的，只是说呢，有一些事件可能相对较高一些，比如说需要放第二个瓣膜这样的情况可能会更高一些。但是呢，它的这个总体的生存率是差不多的。那么我们说现在呢，非常重要的就是 CT 在这个 TAVI 当中的一个应用。那么应用这样的一个 CT 的一个三维重建，能够让我们更好的去了解我们主动脉瓣根部的一些情况。那么这些情况的了解呢，能够让我们更好的去制定方案，减少我们二叶瓣的一些叫做不必要的并发症的出现。当然呢，从我们说随着这个 TAVI 器械的发展，尤其是第二代瓣膜、新一代的瓣膜，它有防瓣周漏等等等等这一些特点的出现之后呢，它的这种二叶瓣的一些相关的并发症的发生率也明显的下降。那么从我们看到的 TVT、STS 这样的一个注册研究当中，也能看到，在美国实际上二叶瓣的病人接受TAVI治疗的病人也是越来越多，它的数量是在急剧的增加。但是呢，的的确确，如果采用我们三叶瓣的这样的一个方式来做这个二叶瓣的 TAVI 的手术的话，它可能会出现一些问题的可能性就会较高一些。那么对于二叶瓣，它有哪一些解剖上的特点值得我们去关注呢？首先呢，我们知道的是，二叶瓣往往存在一个叫做非对称性的解剖，比如说它是一个椭圆形的瓣环，它的钙化和它的这种钙化的基，它的相对来说是不对称的。另外呢，它可能它的瓣叶呢相对的更加的冗长一些。那么非常重要的是，我们的二叶瓣它的这个瓣环和瓣口的这样的一个尺寸，它有存在一个不匹配的现象，也就是说我们的瓣口的面积或者说周长是要小于我们的瓣环的面积和周长的。另外的话，如果是我们对二叶瓣的病人，如果他的瓣膜尺寸的选择不恰当的话，有可能这样的一个比较高的风险出现我们的一个叫做贴合不良，或者说甚至移位，那么造成我们的瓣周漏。如果你再去处理它的瓣周漏，比如说进一步的扩张，有可能会导致我们的瓣环破裂，那或者需要我们的第二个瓣的植入，就是 valve in valve。当然还有一个问题呢，就是我们的二叶瓣病人呢，往往会合并我们深主动脉的一个扩张。那么这个深主动脉，我们做TAVI手术是解决不了这个深主动脉的扩张的。那么如果是我们不管它未来它有没有可能出现夹层或者说是破裂的风险，这也是我们担心的一个点。这儿给大家显示一个例子，这个病人的话，我们可以看到他的钙化呢是一个中重度的钙化，这个钙化的容积呢是800多立方毫米，然后它的周长呢是瓣环的周长是78.2。我们按照这样的一个传统的三叶瓣的这种方式来对这个病人进行治疗，你能看到我们用了一个25的一个普通的柱状球囊进行一个预扩，那么也在同时造影当中也没有看到反流等等。我们就选择根据这个厂家的这个推荐，我们就选择了一个29的瓣膜。从我们看是释放的位置，大家能够看到是还是比较一个比较稳定的释放位置。但是在释放的过程当中的话，这个瓣膜这是一代瓣，它就往下滑动了。滑动了之后呢，我们再进行这样的一个造影，就会发现它有明显的一个中重度的一个瓣周漏的情况。所以在不得已的情况下，这个病人呢就进行了第二个瓣膜的释放，就是 valve in valve。 那么最后的结果呢，看起来它的反流是相对比较少的。这就是我们第一代瓣膜就不可回收的这种瓣膜，在这种按照3叶瓣的这种原则来进行2叶瓣的TAVI手术之后，就可以看到这个明显的问题是在于它的这个移位的问题，瓣膜尺寸选择不当造成的一个移位的问题。那么我们有没有其他的一些方法来改进这个TAVI在2叶瓣当中的一些效果呢？首先呢，我们就是说尺寸的选择，我们可能要考虑的不仅仅是我们瓣环的结构，也要考虑我们瓣环上的结构。那么就提出了这样的一个叫 supra-annular 的这样一个，就是我们在瓣环上的这个结构。当然，在我们中国大陆地区的话，我们有很多的专家都提出了不同的方法来进行这个瓣环上结构的一个测量。总体来说，它的基本原则是一样的，就是我们知道2叶瓣的它整个的深主动脉就是主动脉瓣根部的这样的一个结构的话，它是一个火山口一样的形态，就像红色的线显示的是我们的瓣环的结构，但真正的我们2叶瓣的它的限制点呢，应该是在我们的瓣环以上，就像这个黑色的点显示的这样的一个区域。那我们中心呢，利用这个 Notus 这种柱状瓣膜来做了这样的一个研究。我们把柱状瓣膜放进去之后呢，我们再来看它的真正的限制点，最后发现它的真实的限制点是在我们瓣环上的4到6个毫米左右的这样一个区域。这个区域呢，就是被我们称之为一个 supra-annular， 就是我们瓣环上的结构。那么这个结构呢，它才可能是我们2叶瓣病人当中真正限制我们瓣膜的一个区域。那我们再来看，基于这样的一个理论，我们来重新调整的这样的一个瓣膜尺寸的选择。那么这个病人呢，同样是一个重度的一个钙化，它是这个我们的钙化的容积是超过了3000立方毫米。那么它的瓣环径是92.8，这是一个超大的一个瓣环径。那我们呢，就是说，除了这个瓣环的测量之外的话，我们也进行了环上的测量，就是我们叫做 supra-annular 的这样一个测量。这个测量呢，我们就发现它的这样的一个径线呢，就只有79个毫米，远远的小于了我们瓣环的尺寸。所以呢，我们就决定这个病人使用29的这个 Venus A 的瓣膜来进行治疗。那么同样呢，您可以看到我们用了一个25的球囊进行一个扩张。同时也能非常清晰的看到，在扩张的同时造影就能够发现这个有一点点腰针呢，就是我们的一个这样的没有扩张起来的这么一个点。然后呢，我们进行这个瓣膜的释放，可以看到整个的过程当中呢，瓣膜还是相对比较稳定的。那么做完了之后呢，应该说位置还是跟我们理想的位置是差不多的。然后呢，只是因为它的腰部没有完全起来，我们再用25的这个球囊进行了后扩。那么从术后的 CT 来看的话，其实它的位置应该是比较良好的，在瓣环下可能4到6个毫米的位置。然后呢，它的整个的结构呢，也基本上是一个比较充分的扩张。所以说的话，基于这样的话，就提出了一些新的这个瓣环尺寸选择的策略。那我们就可以看到，通过我们上面的这样的一个回顾的话，我们有传统的基于瓣环的测量。那么这种瓣环的测量的话，往往会造成这个瓣膜的尺寸选的比较大，它可能出现瓣膜的移位，需要我们的再次的瓣中瓣的治疗。那么另外的话，就是我们无论是这个 balloon sizing、supra-annular sizing， 还是其他的一些方法的话，我们总体的倾向就对2叶瓣病人都可能会减小一个瓣膜的尺寸，我们叫 down sizing。那么这种 down sizing 之后的话，它有可能会造成一些问题，比如说它可能出现因为瓣环尺寸相对瓣膜的尺寸相对比较小，出现瓣周漏的情况，出现我们说的病人和这个瓣膜假体的不匹配的一个情况。然后呢，如果是未来我们想象当中2叶瓣病人往往比较年轻，他未来可能瓣膜毁损需要再次做这样的一个TAVI手术的可能性是比较高的。对于这样的一个情况的话，我们再次植入的瓣膜又可能进一步的去影响它的血流动力学，所以这都是我们说是一个值得考量的问题。因此的话，在这个基础上，我们又提出了这样一个叫做 reshaping 的 TAVR 的这样一种方式。那么 reshaping TAVR 呢，它一个非常重要的特点呢，就是我们要用一种特殊的球囊，是一个8字形的球囊来进行这样的预扩。那么这个8字形的球囊呢，它在推挤的时候，不仅仅是把我们的这个瓣叶向这个两旁进行推挤，更重要的，它有一个向上的一个重新梳理我们的这个瓣叶结构的这样一个特点。那么我们再看一个病例，这个病人的话也是一个重度钙化 然后呢是一个2页半的病人，可以看到他的我们的钙化容积是超过了3000分，然后的话再看他的这个瓣环的尺寸是89.5这样的一个径线。我们呢用了这样的一个 TAV8的一个球囊来进行预扩，你可以看到在预扩的过程当中是不需要去进行这样的一个起搏的，同时能够非常清晰的看到我们的瓣叶不仅仅是向两旁推动，也是可以看到它有向上的这样的一个提拉的一个过程。我们再进行瓣膜的释放，可以看到29的这个 VLSA 的瓣膜非常稳定的植入了这样的一个病人的体内。从我们的术后 CT 来分析的话，也能看到在我们最限制点最明显的地方，这个瓣环的扩张也非常的充分。我们用这样的方法做了1组病人，来提出了这个叫做 reshaping TAVR。那么可以看到，总体来说的话，它的成功率，就我们叫器械的成功率，就需要一个瓣膜能完成的这个成功率是明显的提升。当然，我们对于这个2页瓣的话，还有一些其他的方式，比如说 Diva 他们提出来的，用这个巴三林卡的技术来把我们的2页瓣进行一个修饰。它通过这个巴三林卡的方法呢，把我们的2页瓣的基把它撕开，变成一个3页瓣的形态，然后呢，用3页瓣的方法来进行这个TAVI的治疗。这个是它的一个图例了，可以看到它当时用巴三林卡把这个基拉开了之后的话，能够把这个瓣膜放进去，而且呢位置也很好。通过这样的一个我们叫做它的一个 rotation， 这个 DSA 的 rotation， 能够看到它的整个的瓣膜的支架的话是支撑的非常的好的一个情况。当然，我们还有一些问题没有解决，对于2页瓣，比如说这个很简单的问题，这个是一个非常漂亮的图，它显示的是我们主动脉根部的这样的一个流场的情况。那么我们正常的情况，它可能是一个层流，但是呢，我们2页瓣的病人，他可能会出现这样的一个右手螺旋的一个就是团流的情况。那么我们说这个2页瓣的这样的一个团流，当我们用 TAVR 的治疗进行了治疗之后的话，它就变成了3页瓣。这种情况下又会出现这种流场的改变，而这种流场的改变，再一次的改变，会不会导致我们植入区的瓣膜的假体出现一些问题？比如说更早的容易出现衰败，我们也不得而知。那么非常重要的就是还有一个关于我们的耐久性的问题，这个对于2页瓣的病人的话是非常的重要的，因为我们2页瓣的病人年龄往往相对要年轻一些，他未来的话接受就是这个再次手术的可能性也会更高一些。如果我们的瓣膜的耐久性在2页瓣病人当中相对来说如果差一些的话，他可能就会更早的需要我们再次手术的这种情况。所以说对于2页瓣的病人，他的瓣膜耐久性会不会是一个更糟糕的一个情况，我们现在也不得而知。那么关于这样的一个2页瓣的病人的话，虽然说我们现在临床的工作当中已经普遍的在使用 TAVR 的这种治疗方法，但是的确它具有它的一些独特性。那么怎么样去用 TAVR 这种非常有效果和安全的这样的一个治疗措施，能够同样有效的安全的应用于2页瓣的这样一个主动脉瓣狭窄的病人，这也是我们值得去更多的思考。所以我们呢在我们大陆地区的专家呢就组织在一起呢，就做了这样的一个专家共识的一个情况。那么当中呢也特别好的去介绍了我们的这个2页瓣的这种病人应该怎么样用 TAVR 的方法进行一个有效的治疗。总体来说的话，这个2页瓣是一个比较常见的情况，在我们中国的 TAVR 病人当中。当然这个呢很大一部分原因呢是跟我们的年龄相关的。那么它相比西方的国家，或者说我们亚洲的一些国家和地区的话，它的这个发生率会更高一些。从我们2页瓣来说，它本身存在一些解剖上的问题，解剖上的独特性，所以从某种意义上来说，对我们的 TAVR 的这个技术就提出了很多的挑战。那么这个的话，就有可能会出现一些严重的并发症，比如说我们转外科的几率可能会更高一些，需要第2个瓣膜的植入可能会更多一些，我们的瓣周漏的中重度以上瓣周的发生的概率会相对较高一些，等等等等。那么我们说的话，基于我们的3页瓣发展出来的这个瓣膜尺寸的选择的话，在2页瓣病人当中可能是不是那么完全的恰当的。我们应该是要考虑一些方法，比如说我们的环上的结构综合来考量， 来帮助我们选择最合适尺寸的瓣膜，可能是一个解决2叶瓣 TAVR 的问题。那么在这个过程当中，我们也产生了一些新的观念和新的一些理念。当然，这些理念和观念最终是能够怎么样去运用，它的结果会不会是非常的理想，我们还缺乏这样的一些大规模的研究。但是呢，我们觉得这至少是一个解决问题的方法。当然还有我们刚才提出来的 reshaping TAVR 和 Basaninka 的技术，在这样的2叶瓣病人当中都有可能会发挥它重要的作用。但总体来说，我个人觉得2叶瓣的 TAVR 治疗目前来说还不是最成熟的时候，还需要我们更多的工作、更多的证据去帮助我们对于2叶瓣的病人更好的去取得 TAVR 的治疗效果。我跟大家沟通就到这儿，谢谢大家。
谢谢陈茂主任。所以陈茂主任其实提出一个很重要的，就是 bicuspid valve 的 sizing 可能 is different from 通常的 annular sizing。所以我们接下来就请汉正医院的宋光远教授帮我们讲一下这个 sizing strategy for bicuspid aortic valve。光远从这个阜外到这个安正，现在已经是
已经2个月了，
有一片天空了啊！谢谢。好，
谢谢殷教授，谢谢曹教授，在线的各位教授大家好。因为我看这场的主持基本上我们都是我们中国的这个专家，所以呢我就做了一个英文的幻灯呢，我用这个中文来做这个演讲。那么今天我的任务呢是sizing for the bicuspid aortic valve， 就是2叶瓣的一个瓣膜的一个选择策略啊。那么实际上刚才这个陈茂主任已经提过了，就是2叶瓣它有自己一些独特的特点。那么之前国际上的一些数据显示，实际上大概占到 0.5 到 2% 的一个人口的一个比例。那么为什么我们中国Wenzhi trial 里面我们大概有 45.4% 的病人，那么会做到一个2叶瓣的一个情况呢？实际上，那么从这个国外的这个年龄数据上来看呢，那么大家可以发现，因为我们中国的这个当时做 Wenzhi trial 的时候，我们的平均年龄大概是75岁，那正好是落在71到80这个空间里。那么从国外的数据来看，那么2叶瓣的这个比例在这个空间大概也就占到40%左右。那么81到90岁这个年纪是相当于国外的这个数据哈。当然他们在做研究的时候，可能 clinical practice 的时候去掉了很多的这种2叶瓣的病人没有入选所以他们显得2叶瓣的比例可能就会高一些。我想可能最主要的原因是这个原因。那么我们自己呢筛查了大概1500份的这个 CT， 那么这个中国的这个2叶瓣大概是一个什么情况？大家可以看到，我们中国的2叶瓣几乎是占到 50% 的一个比例。那么这个 to commercial 有 Rafi 的这个大概占到14.7%。那么就是 congenital 的这个 bicuspid 就是偏天性的菱形2叶瓣的大概占到 15.8%。那么很多的病人实际上是什么？实际上是3个 commercial， 但是从上面是融合的。我们把这个叫做功能型的这个2叶瓣。那么以前呢，可能叫这个他们把它混淆为这个 Type 1型的一个2叶瓣。所以呢，这个是我们中国的大概的一个数据那么我们实际做的这个比例里面，大概是占到了超过 40% 的这个2叶瓣的病人。那么这是我们对所有的这个瓣膜做了一个形态学的一个分析。那么我这次只显示了这个钙化这部分的内容，当然还有融合和增厚的这个情况。那么从钙化的这个分布上来看，那么中国的这个钙化的程度相对来说，用 HU850 来评估的话它的 volume 相对来说还是比较高的3叶瓣相对2叶瓣来说要低一些。那么2叶瓣无论是哪一种类型无论是你是 function 的2叶瓣，还是菱形2叶瓣，还是这个1型2叶瓣，那么实际上它的整个的钙化水平都要明显的升高。那么我们做了一个纵向的一个评估就是每4个毫米的这个区域，我们把它拿出来，我们重点来看一下这个钙化主要分布在哪几个区域。大家可以看到中国的这个病人，那么从瓣环到瓣下，那么实际上它钙化分布并没有很大。 那么它主要的区域实际上从2个毫米到10个毫米这个空间里，那么尤其是6到10个毫米这个空间相对来说是最高的。那么我们看了一下它钙化的这个分布的情况，又把它这个瓣膜呢单独再拿出来。那么无论是哪一种瓣膜啊，无论你是2叶瓣、3叶瓣还是先天性的这个2叶瓣，实际上中国的病人整个的钙化都是基本上是一个形态的一个分布啊，所以就意味着我们中国的这些病人在做的时候呢，可能会面临着更多的一个挑战啊。那么这个呢是目前指南里对于2叶瓣的一些推荐哈。那么当然现在重点呢还是推荐那么2叶瓣的病人最好是做外科的一个治疗啊。2叶瓣的病人为什么重点做外科治疗呢？因为这个2叶瓣的病人实际上做的时候，我们确实是面临着很多的挑战。那么包括这个非常严重的这个钙化，那么包括它的声阻的扩张，包括它的这个水平型的这个主动脉的这个情况。那么最终做的时候呢，实际上我们会面临很多的问题。那么之前呢，我们觉着可能 annulus rupture， 那么最主要的问题呢，并不是在这里啊，因为我们用的都是自膨式瓣膜。那么之前最主要的问题是 valve in valve 和这个 parallel leak 啊，就是我们的瓣中瓣的使用率，还有呢我们这个瓣周漏的这个发生率，当然还有我们这个瓣膜的不能充分的一个扩张。但是自从我们用了这个球扩瓣之后，那么实际上我们越来越多的意识到如果我们强行要用球扩瓣来做一个2叶瓣病例的话，我们会面临很高的 annulus rupture 的这个风险。这个我想因为殷教授还有魏征院长他们在台湾估计用的比较多是不是也有这种体会？那么当然这个理论上说呢，还有这个夹层的这个风险，但实际上如果这个比较稳妥的控制的话，TAVR 还是极少来发生术中的这个夹层的那么今天来重点讲讲我们2叶瓣的这个 sizing 的这个策略。那么实际上国外的研究已经告诉了我们是哪样的类型的2叶瓣是最难做的。那么实际上这个有2种，一种呢是这种calcified roughy 就是这种一个钙化的脊的这个情况。那我想刚才陈茂教授提到的 basilica 技术，这种脊是不可能撕开的那么第二一个呢是我们特别严重的这种瓣叶的这种钙化。那么这2种情况，那么毫无疑问对国外的专家也是一个非常挠头的一个境地那么我们中国的这些病人呢，实际上很多情况下都面临这样的一个境地尤其是当我们面临使用这个球扩瓣的时候。那这个就是选择的这个策略上，实际上不同的专家提出了很多的这种方法。那么有喜欢这种 annulus sizing 的这种策略，比如说我们美敦力的这个2叶瓣的这个研究，那么它就严格的要采取这个 annulus sizing 的这个策略，那么把这个球囊尽量的打大，那么打大以后呢，最终来放入一个根据瓣环来选择的这么一个瓣膜。但是这种策略可能我不知道，我们一直想跟他们的这个形态学做一个对比，看看是不是我们形态学上是一样的一个情况这种策略我不知道能不能适合中国的一些病人。那么第二一个呢，很多专家同时关注的是这个 commercial to commercial distance 就是我们连接部到连接部的这个距离，尤其是4个毫米左右的这个距离那么当然呢我们中心呢习惯是做 superannulus tracing那么这个也是很多专家在同时呢沿着这个连接部钙化还有这个粘连的这个情况，那么做一个这个 tracing 的一个测量。那么大概呢我们能够知道这个能够给你多少空间去容纳你的这个瓣膜。那么当然有人还做了一些分型那么做完了这个他把这个 intercommercial distance 和 annulus 之间的这个测量那么把它形成了一个管状的这个结构。那么有的是这种倒梯形的结构，还有这种梯形的一个结构。那么85的病人呢，实际上都是在这个管状和这个倒梯形的这么一个结构上。那么实际上这个也是跟中国的现在的我们自己测量的这个数据实际上也是差不多的一个形态那么真正这个 TAVR 的病人可能并不是特别的多当然这个时候呢我们还是要 特别关注我们的这个supraannular sizing 啊，就是刚才陈茂主任也提到了，就是我们瓣上的这个出口的这个地方。那么在这个地方，如果说是有特别严重的钙化的话，毫无疑问会严重影响到我们这个最终的这个瓣膜的这个植入哈。虽然我们不愿意碰到这种 TAVR 的这种类型，但是一旦遇到了 TAVR 这个类型，实际上我们最终选择策略的时候是非常非常困难的，尤其是这个8个毫米啊这个左右的这个地方的这个非常严重的这个钙化，而下面呢有很大的这种情况啊。所以中国呢，实际上有很多专家也一直在提自己的方法啊，包括一会儿先宝可能有自己的讲课，那么这个他们杭州的这个经验，那么阜外我们提的这种多平面测量的这个CT 测量的一个方法。那么实际上我一直在考虑一个问题，就是你看球廓瓣进去以后，那么进去以后它基本上打成一个圆形，上中下这3个平面，包括你的瓣叶的平面，包括你的基底部，还有你的瓣环的平面，基本上是一个圆形的，是一个整个都是开放的一个形态哈。但是自膨瓣进去以后，那么大家看，那么从底部到你的 annular 的这个情况，还有到你的 leafless 这个 level， 那么实际上是不一样的啊。所以说大家可以看到，从下到上，那么整个是一个减小的一个情况。那么是不是意味着这就是我们利用这个数学模型也好，或者利用我们 supraannular sizing 也好，一个理论的一个基础，也就意味着你放一个大的瓣膜进去，那么实际上上面打开的也许就是一个小的瓣膜的一个情况，那么是不是就让我们能够去选择一个更小的瓣膜，就是 down size 的一个瓣膜，那么来最终完成这个手术啊？所以呢，这是我们最终呢提出了一个多平面的一个测量。那么多平面测量之后，我们每2个毫米，那么从瓣环到瓣下到瓣上，那么形成一个数学的一个模型。那么我把它分成 A、B、C 3型。那么 A 型实际上就刚才那个这个桶状的一个结构。那么 B 型呢，相当于是一个倒梯形的一个结构。那么 C 型是一个 taper 的一个结构。那么这个数据呢，实际上我们正在整理啊，应该这个 paper 马上就出来了。那么当时18年的时候，我们用了这个多平面测量之后，那么这个测量就不是单纯的一个 down size 的一个策略。那么有些 down size， 实际上有些根据这个多平面测量的结果，我们没有做任何的 down size 啊。那么与单纯的这个瓣环的这个方法相比呢，你看我们的这个器械成功率，还有我们的这个 PVL 和这个瓣中瓣的这个植入率啊，是有一个明显的下降。刚才殷教授说，我去了安贞医院以后，这个因为这个接近我们是6月1号开的病房，现在做了21例 TAVR， 那么实际上就只有1个用了这个瓣中瓣的这个策略啊。那天我还跟他们说，我说我们做了20个了，1个都没有瓣中瓣的策略。这个但是接着就碰到一个特别偏心的钙化，没有控制好，就下去了啊。所以呢，这个我想也是这个从策略上我们做一个不同的一个选择哈，就是我们希望能构建一个数学模型。那么未来呢，我们现在正在跟以色列的一个公司在合作，那么希望把这个建成一个软件，那么供大家来参考啊，供大家来使用啊。那么最后呢，希望给大家展示几个 case 啊，那么这是我们特别不愿意遇到的一个极端的一个病例啊，这是我前2天刚做的一个 case。那么这个是一个菱形的一个2叶瓣，但这个菱形2叶瓣有一个特点，我们来看一下它动态的一个影像哈。从这个流出道开始往上啊，那么大家可以看到一个非常大的一个团块一样的钙化，从这个底部一直到瓣尖的这个水平啊，一直到瓣尖的这个水平。那么这是我们做的这个多平面的一个测量哈。那么从瓣下的2个毫米啊，到刚才的瓣环，这是瓣上的2个毫米，大家可以看到这个钙化从瓣叶下面就开始，一直翻到这个瓣叶上面去，所以是个非常大的一个团块样的钙化。那么虽然这个病人我们大概的一个 tracing 啊，大概是25左右啊，但是这个 tracing 的理论基础呢是这个钙化可以被掀开，所以呢这个呢是需要我们术中的时候用球囊去验证的啊。 这是它的下肢的一个情况。那么我们就在书中来验证这个情况哈。我们这个是做了一个造影，大家可以看到这个钙化放在这几乎是不动的。那么用22的这个球囊是难以铆定的，最终我们换了一个20的球囊，大家可以看到一个20的球囊居然被这个钙化给挤成了这样的一个形态啊，居然被钙化挤成了这样的一个形态啊。所以呢，我们根据这个术前测量的结果和数学模型，实际上应该选26的一个瓣膜，但是最终呢，根据我们这个 balloon sizing 的一个情况啊，我们最终还是选择了一个23的一个瓣膜。那么23的瓣膜释放完了之后，我们给它做了一个球囊的一个扩张啊，那么最终呢，也是达到了一个比较理想的一个状态啊。那么这是第一个病例。那么第二一个病例呢，是这个我们做的近期做的另外2个病人啊。那么这个病人呢，实际上是一个先天2叶瓣的一个病人。2叶瓣的病人以后呢，他的这个连接部这个地方实际上是有相当一部分是融合的。那么我们来看一下我们这个动态的这个影像啊。那么它从这个上面这个地方是有一部分开始，那么在大概6到8个毫米以上呢，出现一些融合的一个情况。那么我们用多平面测量看了一下，那么大概整个呢瓣环是包括瓣环瓣下是比较大的，但是呢瓣上大家可以看到基本上都是26的一个形态，那么类似于是一个直筒型。那我想对这个病例来说，我们可以用26的瓣来做，也可以用29的瓣膜来做。那么最终呢我们还是决定扩张以后我们再定啊。我们做了一个23的一个球囊扩张啊。23的球囊扩张以后起来的时候相对比较费力一些但是整个的球囊还是有一个非常好的一个膨胀就是非常好的一个膨胀，没有明显的腰部。那么这种情况实际上你完全可以选择，因为都已经把它封死了，完全可以选择一个26的一个瓣膜但是我跟他们说，我说如果是这个新手来释放的话，可能最好选一个29的一个瓣膜。那么最终呢，这个大家可以看到这个整个的弓部是一个异位的一个结构哈。那么过的时候是一个非常奇怪的一个形态，所以我们也选择了一个特别奇怪的 projection 这个 view这个来最终定它的位置。那么最终放了一个29的一个瓣膜像刚才陈茂主任说的一样，上面非功能区有一个压的一个凹部，那么最终做了一个23的一个球囊扩张，那么最后的结果实际上还是比较满意所以并不是所有的2叶瓣可能我们都需要去当 size 我们还是要依据我们的这个之前术前的这个 CT 的这个测量，那么还要依据我们术中的时候这个 balloon sizing 来校正，那么最终呢你可以选择一个策略。那么第3个 case 实际上跟第2个 case 是差不多的一个形态，我们直接来看走的比较慢那么也是一个2叶瓣2叶瓣但这个2叶瓣呢可能相对来说钙化可能会更重一些这个两侧的钙化现起来更重一些。那么从瓣环的水平大概是23，那么到瓣下呢也是23，但瓣上大概是21、22，那么在2个毫米、4个毫米的这个地方，所以呢，这个再往上的话可能都是23、22左右。那么所以对这个病人也是一个 borderline 的一个瓣膜，那么还是选了一个22的一个球囊扩张，那么扩张起来是这个形态我想这个也是从形态上看有一些腰部。那么这种情况你可以选择23的一个瓣膜，也可以选择一个26的瓣膜所以因为是让他们这个植入嘛我就让他们选了一个26的一个瓣膜。那么进去的时候确实是这个地方没有明显的一个扩张，那么最终做了一个球囊扩张之后呢，那么整个的瓣膜形态实际上还是不错的所以呢这个最后呢这是跟大家总结一下，那么我们2叶瓣呢在中国实际上是比较常见的那么另外呢我们2叶瓣的这个比例实际上这个钙化的这个负荷是很重的，那么尤其是在瓣叶的这个水平。那么我们对2叶瓣的这个定位是个非常复杂的一个策略， 那么我们建议呢，实际上现在好多中心也跟着我们做这个多平面的测量，同时做这个 supra-annular tracing 啊。那么实际上建议大家根据这个多平面测量的一个结果，那么来建立一个 model。那么最终呢，看看这个病人是一个他的铆钉区有多长，他的堵住的地方大概在什么地方。那么另外呢，我们建议这个2叶瓣的病人还是做一个球囊的一个扩张，那么同时来修正你的这个最终 sizing 的这个策略。那么最后呢，实际上我们不同的瓣膜还是有不同的这个定位的策略的。实际上今天有一个 Sapien 3的一个瓣膜，当时这个瓣环破裂的一个情况，那么最终瓣膜植入以后破入了右房。那么那个病人我没有放到这个幻灯里面去。我们不同的瓣膜，甚至是我们自膨式的瓣膜，比如说美敦力的瓣膜和启明的瓣膜，因为支撑力的不同，那么最终我们选择的策略也许也会完全不同啊。所以这个大家在选择这个sizing 的时候，我们还是要定位于不同的瓣膜的策略。那么最后就重点强调一点，就是个体化、个体化和个体化，就是每一个瓣膜我们希望做到一个个体化的一个分析。那么尤其是对于2叶瓣的这个情况，那么最终呢，让每一个病人能够达到一个最好的一个瓣口面积。那么最好不要用瓣中瓣，那么最好不要有起搏器植入，以及那么减少最后瓣周漏的这个发生率。那么殷教授，那个今天分享的内容就到这里啊，谢谢大家啊。
好，谢谢光远。Thank you very much for your extensive review and sharing of your experience and the cases. I think you are right. For different devices, maybe we should adopt a different sizing strategy. I think maybe we should collect more information regarding the sizing. Any other comments?
宋老师，谢谢你精彩的演讲哈。那我知道我们特别2叶瓣的 sizing 真的是很困难，现在也是没有什么 consensus 哈。就像您讲的一样，有些是 annular sizing， 有些是 supra-annular sizing， 有些是那个用 intercommissural distance 来做测量。那我曾经看过国外他们都是用 annular 而已 ，annular sizing， 他们也是报道就大概85%到90%左右都可以得到不错的结果。那你们发展出来的就是多平面的测量，我想应该是更精准，因为它是每2个 millimeter 去做测量。那你们这样的测量又怎么去决定这个 annular size？ 就说你们会选择最小的 diameter 来当做那个选择瓣环的一个因素吗？就说你们这样测量，那到最后是怎么去决定这个瓣环要怎么选择？瓣膜要怎么去选择？
谢谢魏院长。这个实际上我们现在测量最终的目的是为了建立一个数学的一个模型。那么我们来看一下，就是包括它从流输道开始一直到瓣上大概10个毫米左右。那么中间呢，到底是一个类似于直筒型的一个结构呢，还是一个梯形或者一个倒梯形的一个结构？实际上中国的病人我们测完了之后大概大部分病人是一个直筒型的一个结构，就是说它上下的这个 size 差出去的应该不超过2到3个毫米，所以在这种情况下，我们完全可以放心的去选择一个就是annular sizing 的一个策略。但是如果说比如说我们是一个倒梯形的一个结构，那么这种情况下我们可能就要谨慎的来选择我们这个瓣膜是铆钉在哪个地方，那么最终又是通过什么地方把它堵住的。那么然后呢，我们再根据这个balloon sizing 的情况来对它做一个校正，那么最终呢，我们选择一个比较合适的一个策略。但是这个里面确实像您说的这样，就是比如说一个美敦力的比较软的支撑力，甚至我们国内的做 VitaFlow 的瓣膜和这个 Venus 的瓣膜，那么硬的支撑力和软的支撑力，那么最终完全可以影响到你一个 size 的这个选择。
OK， 国珍。
请问宋教授，那个，因为你在测量，因为你在影像的测量实在是一个专家哈，想请问一下钙化的部分，因为钙化它的行为其实是有点会影响到你后面的 TAVR 的 expansion。那这个钙化你在计算这个perimeter 的时候，是钙化也要算进去一部分呢，还是说完全不算钙化的部分，只算它的内径？因为以前在做 EVA 或 TAVR 的时候，我们会算一下，把钙化算了一半的 的长度里面算进去。我不晓得在宋教授这边的测量这边。
谢谢李教授，您一下问到了我们这个测量方法的软肋，实际上就是我们这个测量是基于非常有经验的这个核心实验室的这个分析专家的一个 tracing， 就是因为我们做的，比如说现在做到1000多例的一个情况，那么我们大概实际上根据术前和术后的一个对比，那么我们能够知道，比如说一个团块一样的钙化，比如说你上下的这个区域超过了4个毫米的话，一般很难被推动的，或者你是一个钙化加上这个粘连的一个情况，也是很难被推动的。像这种情况，我想我们就没有必要把它画进去啊。但是有一些，比如说散在的这种钙化，那么我像您说的一样，我们完全可以把它画进去，这个是没问题的。所以现在我们就想跟这个软件公司来合作，实际上就是让他学习我们的这个术前和术后的这个 CT 的一个对比，那么最终来决定什么样的这个钙化是我们能画进去的，什么样的钙化是画不进去的啊。
了解，谢谢。
Okay, we are far behind schedule, so I would like to proceed to the next talk. The next talk will be delivered by Professor Liu Xian-Bao, who is currently the director of transcatheter heart team at Zhejiang, the second affiliated hospital of Zhejiang University. Professor Liu is going to talk about the devices for bicuspid aortic valve.
院长，听得到吗？
可以，没问题。
好，尊敬的殷院长，还有光远教授，还有各位主席，大家上午好。首先非常感谢殷院长，给我这个机会跟大家一起来分享一下2月半的一个情况。实际上，其实我看前面陈茂教授，包括光远这里都应该是讲了很多2月半的。所以我也听了，也学习到很多。今天我跟大家来分享一下2月半的一些器械的一个选择。应该说前面其实大家都提到了，这个2月半它结构还是比较的复杂，关键是它无论是说是火山口梯形，或者说它是个半环上的一个结构，跟半环之间不匹配，它会带来很多的问题，就包括它上面其实主动脉根部结构，它所提供的力学特征是不一样的。所以我们经常在做球囊扩张的时候，我们可以看到这个球囊扩起来以后，上面有一个明显的腰，这个腰呢还经常是位于这个半环以上1厘米左右。所以很多时候如果说我们对每个病人可能都不太一样，不加以区分的话，很可能瓣膜型号的选择就会出问题。所以这是我们早年的一个结果，做 CoValve 2013年、14年的时候，这个病人你感觉放太深了，也有可能放弹出来了。尤其是第一代瓣膜没得选择、没有可回收的时候，就更加会出现这个情况。所以这个对于2月半来讲，其实到现在为止，我觉得都是个挑战。那对于器械的选择来讲，那应该说到目前为止，也没有一个绝对的一个说谁哪个更好，哪个不好。所以我们一起来复习一下文献。那么从自膨胀瓣膜，应该说累积了比较多的经验，刚开始也用的比较多，尤其是国内用的比较多，包括 CoValve 系列的。那么应该说这个研究会是比较多，像 Roger Makar 教授他们这个团队应该说发了很多这样的文章。在2017年，他们的 JACC 上发了一个匹配性的一个研究，把2月半跟3月半进行相匹配，总共是从1300多个病人里边选到了这个每组都是500多个病人。所以我们可以看到两组之间，应该说从死亡率来讲，两组之间是差不多的。再然后呢，它里边其实瓣膜的种类很多。如果说把第一代的 CoValve 拿出来看，那我们可以看到，用第一代的自膨胀瓣膜，虽然说死亡率是一样，但是它对于半中瓣，包括半周漏等等，应该说还是有不利的因素。但两组在起搏器之间没有差别。那最近在 JAMA Cardiology 上发了一个在 low risk bicuspid 的一个研究当中，他们用的是 Evolut R 和 Evolut Pro， 就用的是最新一代的瓣膜，入选了150个病人，平均年龄是70岁。STS score 只有1.4%，那最后的结果应该来讲还是不错的。我们可以看到 device 这个 size 是95.3%，而且它也是跟我们想的就是我们说半环上结构，它选的瓣膜都是基于半环的，34号大瓣膜很多。那我们可以看到它的结果其实非常好，全因死亡率或者自残性脑卒中只有1.3%。那么 我们可以拿全因死亡率只有0.7%。disable stroke 也是0.7%。从这个起搏器来看是15%左右，冠脉堵塞是1个，没有出现主动脉夹层和这个破裂的情况啊，所以应该说从它结果来看，应该是非常好的一个结果。那从这个 TVT registry 也是一个倾向性匹配的一个研究，我们也可以看到它的样本量更大一些，900多个病人，2叶瓣跟3叶瓣相比较，两组之间也是相匹配的。但对于自膨胀瓣膜，国外看起来应该说结果还是不错。那但是国内确实我们可以看到 Type 0型的2叶瓣比较多，像前面那个 low risk， 它 Type 0型只有9.3%，但于我们目前国内它占到95%，就50%以上的 Type 0型，而且它钙化比较重，很多时候都不对称。对于这么难的解剖的结构，那我们如何来解决？像国内应该说 Venus A 属于一个代表性的一个瓣膜，它镜像支撑力设的比较高，所以它目标也就在于2叶瓣钙化重，把目标定在这个地方。那 Venus A Plus 它是 Venus A 的瓣膜不变，输送系统做了改进，包括我们跟启明公司也是联合来研发这个东西，但实际上遇到了很多的挑战，因为这么硬的一个瓣膜，把它实现可回收、可重新定位是一个不容易的一个事儿。但最后目前应该说用起来还是比较顺手。接下来我们来看看他们的数据。Venus A 早期的研究是101例，2叶瓣是占了40%，那 Venus A Plus 它2叶瓣占的更多了，占了将近2/3，这么多病人。所以当时实际上 Venus A Plus 做研究的时候，它是唯一一个2代的临床研究，所以大家可能把很多难的病例都留到给 Venus A Plus。那从 Venus A 里边我们可以看到，它1年、5年的死亡率，包括其他的一些事件，应该说还是不错的，非常稳定啊，跟国外同类产品相比较，应该还是类似。那 Venus A Plus 它是在 Venus A 的基础之上，它进一步把负荷的终点，包括全因死亡率、新的、卒中等等，包括尤其是起搏器指路率下降了，它达到了一个明显统计学的差异。那对于这个 balloon expandable valve， 那对于爱德华系列的自膨胀瓣膜，应该说还存在的一些争议啊，包括我们前面一直说，自膨胀瓣膜它比较长一点，容错率高一些，而且瓣环上结构对血流动力学会好一些。那自膨胀这个球囊膨胀式瓣膜，那对于它扩起来可能会扩得更圆一些，但是呢，有时候也担心2叶瓣你扩得更圆了以后，会不会引起瓣环破裂等等相应的问题，所以大家也都比较顾虑。但确实最近我们可以看到，就是也是一个匹配性的一个研究，它1比1进行匹配，从那个将近10万个人里边，这个 TVT registry 选了2691个对691个，我们去看，应该说两组之间也是一样，死亡率没有明显的一个差异。从这个反流来看，两组之间也没有明显的差异。但是呢，确实我们也可以发现，球囊膨胀式瓣膜确实2叶瓣跟3叶瓣比较，转外科开胸的比例确实偏高了 ，annulus rupture 的概率也是偏高了，而且包括脑卒中的概率，2叶瓣病人当中确实好像也是更高一些 ，pacemaker 也是更高一些。确实从总的硬重点来看，两组差不多，但是在里边的一些细小的，无论是自膨胀瓣膜和球囊式膨胀式瓣膜，应该说都还是有一些不利的因素在。而且我们也可以看到，它跟2叶瓣的分型有关系。Type 0有没有极上有没有钙化，跟预后还是有关系的。极有钙化，那它是明显影响到这个预后。那么一个 BEAT 研究，它比较了一个 STEPING 3跟 EVOLUTOR 研究，两组之间相比较，应该两组之间好像没有明显的一个差异在里面。所以说总体来讲，自膨胀瓣膜和球囊式膨胀式瓣膜对于2叶瓣来讲，应该说结果应该都是叫 acceptable。所以说2020年 ACC 的指南里边，它也做了一个谨慎的一个推荐，在解剖学结构合适的，你应该说也是可以考虑。那对于相关的其他的器械来讲，其实还是回到这个挑战里面，对于这个瓣环上结构打不开的情况，我们有没有其他的一些器械来解决这样的问题？那应该说这个 Leaflex 它如果说能够通过跟我们切割球囊一样的类似的概念，原来钙化用普通的球囊打不开的，如果说用的 Leaflex 能够把它打开的，能够把瓣环上结构全部打开，那我们选择瓣膜的型号也可以根据瓣环来选，可能结果也会不一样。那当然它目前的研究只仅限于这个3叶瓣，没有进行2叶瓣，那相信如果说这样的理念未来也可以值得我们去探讨啊。包括它做完以后瓣口面积是增加了，跨板压差是减少了，而且它组织学上来看也没有明显的一些损伤， 所以从未来来讲，对于2叶瓣钙化重的这个方向是不是可以做，值得我们进一步的研究和探讨。关键是它能打开瓣环上的一个结构。再另外的一个就是叫做 shock wave， 就我们通过超声的一个，像我们说外周的钙化，包括殷院长他们也在做。如果说能够把钙化给打开打断掉，那实际上这个结构相当于这个瓣环上结构也能够把它松解掉。所以国外包括澳大利亚他们在做一些研究在里边，应该说取得了比较好的一个结果。包括国内像这个佩嘉也在做 torus wave， 也在做这样的一个结果。但后续到底怎么样，需要有更多的证据在里面。还有像 Prosthetic 这个技术，如果说能够把瓣叶给切掉，能不能把这个2叶瓣，如果瓣叶如果说确实2叶瓣，如果把它切开，能不能达到瓣环结构打开？这个呢也没有太多的经验啊，只是从理念上或者理论上来讲，可能可以，但值得我们进一步的去商量和探讨。但另外呢，就是脑卒中的研究，就包括我们中心那个对于2叶瓣的病人，我们也做了一些研究，他确实发现脑卒中 disabling、non-disabling 应该是差不多，但 silent stroke 发生的概率2叶瓣比3叶瓣还是更高一点。所以未来对一些高危的2叶瓣病人，脑保护装置这个应用就值得我们进一步的去研究和探讨。在手术策略上，包括前面陈茂主任、光源主任他们提到的他们中心的一些经验，包括我们中心王书记带领我们团队也是一样，我们叫做杭州方案，就通过球囊扩张来看一看瓣环上的一个结构。所以刚开始我们是从小球囊再往上走这样的一个概念来做，应该说也是取得了比较好的一个结果。所以我们当时也是发表在2018年的 CCI 上，但确实呢也有一些问题。有时候球囊扩张可能需要2次，甚至需要3次，但有时候呢可能会不会downside太多了，也会有些问题。所以后来呢我们又叫做modified 杭州方案，那我们就downside最多只down1个 size， 而且破1次。那么也是根据 CT 指导下做球囊扩张来评估瓣环上结构，看有没有腰有没有漏。如果有腰没有漏，我们可以downsize 1个 size； 如果有腰有漏或者说没有腰，那我们都会基于瓣环来选择。所以这样呢，就是应该说，对于瓣环上结构力学的特征，应该说通过球囊就有一个客观的一个反应。所以基于前期的一些 registry， 那我们接下来已经是现在在做 RCT 的研究，已经开始在做了，就看看最后的结果到底怎么样。那这是2个例子，一个例子呢是69岁的一个老年女性，她的菱形的一个2叶瓣，那她的瓣环是 24.3。对于这样的病人，我们根据我们的 protocol 就拿23的球囊去扩，那我们发现有腰没有漏，有腰没有漏以后呢，就觉得这瓣环结构比较明显，所以我们选择了，因为这个病人是入选到杭州方案组，就选择了26毫米的一个 Venus A Plus， 最后的结果应该说达到了比较适当的高位释放，最后呢这个位置非常好，也没有反流，压差也没有。第2个病人呢是入选到对照组，这个病人的瓣环是 25.7， 那也是用23的球囊进行预破，那我们发现就是没有，这个病人也是有腰没有漏，那如果按照杭州方案就是要选26，但是因为入选到对照组，所以我们只能选29。确实我们在放的过程当中就发现这样的病人瓣环上结构的力量往下挤的比较，虽然说最后的结果还是不错，但是我们可以看到它深度就是明显的深了。所以这只是2个典型的例子，那接下来可能我们还期待我们有更多的结果出来。所以最后对于2叶瓣来讲，应该说它还是非常具有挑战性，目前的结果都还是不错。那么对于有个 high radial force 的 design 应该说还是比较好。但话又说回来，应该是器械包括手术的策略包括证据之间我们要平衡，所以我们需要有更多更好的器械，同时我们要对技术本身进行改进，同时我们要累积更多的证据，所以这样才能够达到一个最好的一个结果。好，谢谢大家，尹院长，这是我的汇报，谢谢。
Yeah, it's really impressive. So I think bicuspid is still a very challenging condition, and especially for Asian people, because so many papers come from the Western society. Actually, their valve is not that heavily calcified, and I think the strategy should be different for Asian and Western countries. So the last talk will be delivered by Dr. Koh. Dr. Koh is from Korea, and he's gonna share with us a complicated bicuspid case. I think for Asian countries, because it's always an issue. Dr. Koh is from Severance Cardiovascular Hospital, Yonsei University Health System, Seoul, Korea. Dr. Koh, please.
Good morning. I'd like to thank the organizers for inviting me to Taipei Valve Summit 2021. It's my great pleasure. As you all know, the bicuspid valve prevalence is varying from country to country, from continent to continent, between 0.5 to 2% of the global population, and it shows heterogeneous cause and sinus morphology, and it has often asymmetrical leaflet fusion, and it has heavy and asymmetrical classifications, and it has also long commissural distance. Often the aortic valve is associated with aortic root angulation and with transverse ascending aorta, and aortopathy with aneurysmal change is combined in up to 50%, and the coarctation of aorta is reported to be present in up to 20%, which is not that common in our population. Anyway, these conditions lead to procedural difficulties during TAVI procedure. And this is the Korean TAVI registry, the prevalence of bicuspid aortic valve. And in our registry, bicuspid aortic valve shows prevalence of 8.5%. And I'd like to share several cases which show similar features. So this is case one, the 80 very old gentleman, and with the severe AS, and the valve area was 0.8. And as you can see, the TE shows true type bicuspid aortic valve, and the peak pressure gradient, the mean pressure gradient was around 50 to 30, and the ejection fraction was decreased to 33%, and it shows concentric LVH. And this is the findings of CT scan. The annulus shows ovoid shape, and the mean and max diameters were 25 and 31 millimeters, and the perimeter was 90 millimeters. And actually, the valve itself does not have much calcification, and the coronary ostium heights were sufficient. And in this case, we decided to use Evolut system because we want to avoid the rapid ventricular pacing during TAVI procedure. So we thought self-expanding valve may be more advantageous in this case. Sometimes when we perform rapid ventricular pacing in patients with reduced LV function, then often we can encounter cardiac arrest during the procedure. So we want to avoid the kind of situation. So we chose Evolut system, and according to the perimeter, the 34 millimeter Evolut R system was the proper size in this case. And however, the CT scan shows also very tortuous aorta. As you can see, very tortuous iliac arteries, and almost 90-degree the angulation of abdominal aortic aorta, and also the aortic arch is angulated, and the annulus plane shows almost the horizontal, the course of the ascending aorta. So in order to overcome the angulation in the abdominal aorta, we used Lundakis, the stiffest wire that you can have on the market. So as you can see, using Lundakis, we was able to overcome the angulation in abdominal aorta. And then we introduced the sheath, to have a good backup, and then we, in this case, we did not predilate because the aortic valve area was 0.8, so I think it was sufficient, and the valve does not have much, did not have much calcification. So, however, as you see here in this motion picture, you know, the wire inserted, the safari wire inserted in the LV shows almost in the 90-degree angulation, and so it was not that easy. However, we slowly introduced the valve delivery catheter into the LV through the aortic valve, and so we try to release the valve slowly, and as you can see here, so actually we had no difficulty except for the the horizontal course of the aorta. There was no problem in releasing the valve. After the complete release, as you can see here, the valve almost lie, flat, right? So, however, there was no complication, and according to our imaging, we used the intracardiac echo to monitor the procedure, and we found no significant paravalvular leak, only mild to minimal. So we completed the procedure. We did more post-dilation, sorry, using the 27mm balloon, and then after that, the paravalvular leak was negligible, so we completed the procedure with this. The next case, similar case, I would say. So 80-year-old female. The echo shows the very severe aortic valve stenosis, and the T shows again true type bicuspid aortic valve feature. And according to T, the valve area was 0.5, and according to transthoracic echo, the valve area was 0.3, and the peak pressure gradient was 1/100 mmHg, and the ejection fraction was 74%. So every function, systolic function, was well preserved. In this case, this is the CT measurement of the aortic root. The annulus at the annulus level, the minimum and maximum diameter was 17 and 24 millimeters, and the perimeter was 65 millimeter, and 4 millimeter above the annulus, the perimeter shows also similar dimension, so 63 millimeters, and at the 8 millimeter above the annulus level, the perimeter shows again a similar dimension, 62 millimeters. So, and the leaflet has some calcification, but it was rather mild to moderate. In this case, again, the CT scan shows severe angulation of the aorta in the abdomen, and also severe angulation in the arch and the horizontal course of the ascending aorta. And the ascending aorta has a diameter of 45 millimeters. So, according to these measurements, actually we can choose one of the two the valve types. So SAPIEN 3, if we select SAPIEN 3, the valve diameter would be 20 millimeters. And if we choose Evolut system, then we'll need 20 millimeter aortic, the Evolut valve system. So since in our opinion, 20 millimeter valve maybe is not large enough, may cause patient prosthesis mismatch. So in this case, we selected the Evolut system, and to have a better flexibility, and so we choose Evolut R system instead of Evolut Pro. This is the baseline aortogram. And in this case also, we used sheath to have a backup force. And since the patient shows a small aortic valve diameter, we decided to perform pre-dilation using a 80 millimeter balloon. And then we introduced the Evolut R 20 millimeter valve. As you see on this picture, again, the ascending aorta shows almost horizontal course. And here, I don't know whether you can see here, but there is small spot with calcification just above the aortic valve. It has some resistance, but I did not apply too much force to overcome this spot. And I was able to introduce the delivery catheter into the LV. And then we slowly deploy the valve. And under ventricular pacing with 120 beats per minute. And then here we slowly deploy the valve. Here. Okay, and then we completely deployed. So, and we proceed. We found some paravalvular leak, and then we applied post dilation using 21 millimeter balloon. And then this was the final aortogram. So what do you see? I think you can see here the leakage of conscious dye into the fourth lumen, and there was a dissection. So when we go back to previous slides, sorry, here, when we deploy the valve, actually here, this frame, valve frame, actually, hit the ascending aortic wall, and I guess this made the dissection. So I think it was very unfortunate. But I think that was the cause. So this patient required, emergent surgery, and fortunately, the patient survived the operation, and still the patient is followed in the outpatient clinic. And the third case, a female patient, and shows also, true type bicuspid aortic valve, and according to the CT measurement, left coronary artery ostium has a distance of 15 millimeters, and right coronary ostium has a distance of 90 millimeters from the annulus level. And this patient also has severe angulation in the abdomen. And this is the baseline aortogram. And we applied the balloon for the pre-dilation. And you can see here the calcium chunk at the left coronary cusp. And in this case, because of the severe angulation of the ascending aorta, we applied Sapiens 3 system because this delivery system has a steerable feature. So we successfully applied the valve this was the final angio. And there was good flow in left coronary artery system, and there was a minimal leakage, probable leakage, and we thought, yeah, the procedure was very successful. But after the procedure, in the coronary, in CCU, the patient had nausea and showed hypotension, and the CKMB was elevated up to 170, and the troponin T was also elevated, and the post-procedural TAVI, the post-procedural ECG showed mild elevation in the inferior leads. And so after seeing this, actually we decided to do a coronary angiogram. As you can see here, the left coronary system shows actually good perfusion and no significant obstruction by the valve or leaflets. And here also, there was some distance from between the valve and the left coronary ostium. However, actually the right coronary artery was diminutive. However, the ostium shows significant narrowing. Since the right coronary artery was diminutive, and we did not think it has any significant impact on the LV function, so we decided not to intervene here. So we checked the CT scan taken prior to TAVI procedure. Here, actually, there was the right coronary artery itself very small, but there was no that significant stenosis. But I think somehow the valve leaflets compressed the proximal segment of the right coronary artery after the procedure. So these are my messages. TAVI in patients with bicuspid aortic valve is complicated because of challenging aorta and aortic valve anatomy. Often patients with bicuspid aortic valve show severely angulated aorta with horizontal ascending aorta. This patient may have also dilated ascending aorta. Thus, a flexible or steerable valve delivery system is more advantageous, and we need extra caution to avoid any injuries to aorta. In bicuspid aortic valve, coronary obstruction during TAVI may be less predictable due to longer leaflets and severe calcification. We need more detailed procedure planning and careful maneuver for successful TAVI procedure. Thank you for your attention.
Thank you. Dr. Koh, in the second case, do you think if you chose balloon expandable valve would be better?
Yeah, in retrospective, I think in that case, if we had used balloon expandable valve, that kind of disaster might have been avoided. I think so, yeah.
Dr. Koh, thank you for your excellent talk. If you have a TAVI patient with concomitant coronary artery disease, like the third case, would you treat the coronary artery disease first before the TAVR or after the TAVR?
If the patient has significant coronary artery disease, then we usually treat the lesion first. But if the lesion is very simple, then we do the PCI and the TAVI at the same procedure too. But I think anyway, doing the PCI after TAVI procedure, I don't know. I would not recommend that. So.
Yes.
May I ask a very short question about your second case? Because I'm a surgeon, I'm interested about how do your surgeon treat for the second patient? I mean, what kind of operation they done for the
after the complication?
Yeah.
The graft replacement of ascending aorta and the Benta procedure.
So they have to explain the device, right?
Right.
Okay. Yeah. I see. Great. Thank you.
Okay. Thank you very much, Dr. Koh, for your excellent talk.
Okay, thank you.
We thank you attend this meeting this year. Thank you. Now we move to the next session, which will be chaired by Dr. Cao Dianping and Li Yongzai.
So our commentators are Dr. Xiong Minsheng, Dr. Li Guozhen, and Dr. Li Dingzhao. Okay. So I would like to invite the next speaker, Dr. Gregory M. Scalia. Dr. Scalia currently is a senior consultant cardiologist, Healthcare Partner Australia, and he's also a director of echocardiographic, the Prince Charles Hospital Australia, and he is also the associate professor of medicine, University of Queensland, Australia, and the Bond University, Australia. And Dr. Scalia is a nationally respected expert in echocardiographic, and today he's giving us a talk with title of Imaging Tricuspid Valve Intervention. And Dr. Scalia, please.
All right. Good afternoon. I hope you can all hear me clearly. Okay, so let's talk about tricuspid valve anatomy for intervention, and this is obviously becoming relevant now with the use of the percutaneous devices. So let's have a think about the anatomy of the tricuspid valve. So the tricuspid valve obviously has 3 leaflets. It has an anterior leaflet, which is larger, is associated with the right coronary artery and the right ventricular outflow tract. A smaller posterior leaflet, which is associated with the right ventricular free wall, and a septal leaflet, which is near to the inferior vena cava. There are 3 commissures, but 2 that we really care about in terms of percutaneous intervention, and that is the commissure between, or the coaptation between, the septal and the anterior. And I'm going to use the word septo-anterior and septo-posterior. I don't say anteroseptal or posteroseptal because we use that in other places. So septo-anterior, septo-posterior, SA and SP. And when you look at the anatomy from above, take off, if we look from the right-hand side, this is an RAO view, take off the right ventricular free wall, there are 3 papillary muscle bodies, a large anterior papillary muscle between anterior and posterior, a smaller one between posterior and septal, and septal attachments, just if I go across to here, septal attachments, there really is no septal papillary muscle, but a bunch of caudal attachments directly to the septum. Now, all the surgical textbooks show the tricuspid valve like this, but in all of echo, we look from above and we put the aortic valve at the top of the screen in all of our 3D echo pictures. And so remember now that the anterior leaflet is associated with the right coronary cusp, the posterior leaflet is associated with the right coronary artery and the free wall, and the septal leaflet is associated with the IVC, coronary sinus, and importantly, the AV node there and the membranous septum. Now, tricuspid regurgitation, just like mitral regurgitation, has a Carpentier classification with type 1 is normal leaflet motion, so this is functional TR. You've got tricuspid valve prolapse, and you've got restricted motion, which is typically related to rheumatic disease. In our world, only 20% is actually primary disease of the leaflets, either prolapse, carcinoid, rheumatic, trauma, and so on. And 80% is functional. And this is related to annular dilatation and leaflet tethering. This is what we see most of the time. And as the annulus dilates, it's the free wall part of the annulus associated with the right coronary artery AV groove that expands. And so if you look at the tricuspid leaflets from mild tricuspid regurgitation through moderately severe grade 3, grade 4, you can see the malcoaptation is related to expansion of the dimension of the free wall there, and the leaflets just barely touch. And this is the kind of thing that we see with severe functional tricuspid regurgitation, usually with normal right ventricular systolic pressure. Now, I'll quickly just go through surgery because surgery is hardly ever done. And this is an old slide from the United States, and I'm only really just showing it to remind us that there's a lot of tricuspid regurgitation, but there's less than 0.5% 0.5% of people with severe TR actually get heart surgery. And that's because heart surgery for tricuspid valves is very difficult surgery for the patient. There are a variety of procedures, and I'll just go through them quickly, a variety of procedures that surgeons do for tricuspid regurgitation. But almost always, these are done if you're doing mitral surgery or bypass or something like that. Isolated tricuspid valve surgery is actually very rare. So originally there was the De Vega procedure, which basically involves putting a purse string around to create an annuloplasty with stitches. We did a lot of this about 25 years ago, very little of this now, and it's largely been replaced by this same sort of idea, but where a flexible annuloplasty band is put in to reduce the size of the circumference of the annulus. And this is a beautiful picture here of a tricuspid valve repair using a band, and that's a nice result. But again, mostly done when you're doing mitral surgery or bypass, very rarely done as a standalone. You can put a xenograft, an animal valve in place, and this is done where the valve is deemed to be not repairable, mostly because they're destroyed by endocarditis. And in this one, you can see a pacemaker wire through it. Or rarely, very rarely, we put mechanical valves into the tricuspid position. I've just got a 3D echo there. And the reason we don't use these much is because they require very difficult warfarin control because they clot off. Now, percutaneous devices, there's been a whole bunch of ideas for percutaneous tricuspid regurgitation intervention. And I'm not going to show them all. You've seen this slide before, I'm sure. I'll just show you a couple that we've had access to. This is the Tri-Cinch device, which involves embedding that screw into the tricuspid annulus. And then this piece of material here connects down to this stent, which goes into the inferior vena cava. Now, to anchor this thing into the muscle requires this device to go into the pericardium. And in fact, to do the procedure, you actually puncture out into the pericardium and inflate the pericardium with carbon dioxide, and then put this device on the outside of the heart. And then this stent here goes in the IVC, and basically you tighten this tether to oppose the tricuspid annulus. We did a few of these in Brisbane a few years ago. Here's a case, severe TR. And basically what we did was you get this device here, puncture into the pericardium. That's a wire in the right coronary there, obviously, into the pericardium. This is the steering catheter going through here. And basically you put that anchor into the epicardium and pull the tether down into the IVC. But the problem was, and this is the result afterwards, the problem was this, that because you've got a device through the ventricular wall, or so the atrial annular wall, there's obviously this risk of pericardial effusion. And we have not done any since this case. This device is a bit interesting. I've seen a few of these done in the Mayo Clinic, where this balloon is anchored into the right ventricular apex like a pacemaker wire, and it gives a spacer device for the leaflets to touch against, because if you've got poor coaptation, if you can coapt it against the spacer, that might help. But really, the world of percutaneous intervention has come about with the use of edge-to-edge repair, and this is obviously with originally with the MitraClip device, which is being used in the tricuspid position, and then eventually now there is a TriClip device, which in Australia has only just got licensed. So we've not used the TriClip device yet, but we've used quite a lot of MitraClip in the tricuspid position. So let's have a look at this. Let's remember the anatomy again. So the surgeon looks this way with the head at the left, and all the surgical diagrams are laid out like this. But in echo, we're going to do all of our work looking like this. And this is the 3D echo picture there from the right atrial side, with the anterior leaflet at the top of the screen, the septal leaflet associated with the atrial septum, and the posterior leaflet on the free wall. Now, look at that area on the right there, and this very important landmark here at the top of this triangle of Koch. This is the AV node, and this is something we have to be very careful about not to traumatize. This is another 3D echo showing the layout of the leaflets. Now, what are we going to do when we do clipping? Well, we're going to try and mostly clip septo-anterior, because most of the leaks are septo-anterior. Rarely, the leaks are septo-posterior, and sometimes you have to do a combination we call a clover leaf repair, one clip septo-anterior and one leaflet septo-posterior. Now, this is the most important slide of the whole talk. This is how you do the anatomy screening of tricuspid regurgitation. Now, have a look at this picture on the right. This picture is a short axis TEE 60-degree view, mid-esophagus, standard view. You'd look at the aortic valve. Have a look at the cartoon. This is the anterior leaflet, not septal. The anterior leaflet is near the aortic root, and the posterior leaflet is near the free wall. You cannot see the septal leaflet on this picture here. You cannot see it because it is wall to wall behind the screen. It is behind the screen, and in the cartoon here, I've made it yellow. So you've got septal leaflet is going wall to wall across this picture. This is like the bicommissural view of mitral of the tricuspid. And what happens is then, if you put an X-plane cursor through this point here, then this picture over here is a septo-anterior picture. That is a gripping view of the septo-anterior part. And if you move the X-plane cursor out that direction, this is now a septo-posterior picture. Now, this is how we're going to map the anatomy of the leaks. The other view is transgastric, where you put the camera right down into the stomach. This is looking from the right atrial perspective, and you've got septal, anterior, and posterior. Let's have a look at the landmarks. So, coronary sinus and septal and the atrial septum, inferior vena cava. So the septal leaflet is near the coronary sinus and near the atrial septum and ventricular septum. The anterior leaflet is far away from the diaphragm, and the posterior leaflet is in the RV free wall, which is touching onto the diaphragm. This is the anatomy. So let's have a look how we might screen. Here's a screening case. This is somebody with tricuspid regurgitation. We're thinking of edge-to-edge repair. Have a look at this index picture. This is a short axis view, 64 degrees, mid-esophagus. You can see the aortic valve in cross-section on the left-hand picture, and see the leak. The leak is coming from the septo-anterior end of that coaptation surface. And so when we X-plane down through there, so this is now on the left picture there, X-plane through that area, and then X-plane through the color, you can see that the leak is all coming now from the septo-anterior end of that coaptation line. And if we look at 3D there, from above, septo-anterior, you can see the jet is coming septo-anterior, basically from here. And so our plan to do a clip procedure would be to put a clip across that septo-anterior commissure. From the transgastric, septal, anterior, and posterior leaflets, and I'm sorry the right-hand picture doesn't run, but you can see that all of the leaflet, all the leak there is septo-anterior. And so our plan would be to put a clip somewhere across like that. So when we introduce the device, at the moment we're still using MitraClip, but as you know, Tricuspid Tri-Clip is almost ready for, well, it's licensed now in this country. And so you introduce the device like this. You bring it over the valve in the X-plane view, and then you note where it's coming from. So in the short axis view, it's coming from the left of the screen. You pull out or push in to move from the anterior to the posterior end of the valve. And in the X-plane view, the clip is coming from this side of the screen. The feet are down here. And if you turn the device clockwise or anti-clockwise, that's going to give you the movement lateral or medial on that picture on the right-hand side. So these are the manipulations of the device. In the transgastric view, the device is coming from here. And there's a flexion, which on the MitraClip is the A or the plus knob. There's a new knob on the Tri-Clip. And that flexes the device upwards. And then clockwise and counterclockwise rotation to go more towards the free wall, more towards the septum. These are the manipulations that we use. Lastly, you have to do the axiality. So note the clip as it comes in like that has to be perpendicular. And so you want to go from something like this to something like this. All right, in my last couple of minutes, I'll go through one of the cases. This is a lady that we looked after for a long time with atrial functional tricuspid regurgitation, severe TR. And this lady has had progressive right heart failure and using a lot of diuretics, something like 160 milligrams every day of furosemide. So here's her echo, pretty typical looking tricuspid regurgitation, septal flattening, severe TR, poor leaflet coaptation, massive right atrium, not so big, a moderate right ventricle, but massive right atrium, and systolic flow reversal in the hepatic veins. Have a look here now in the transgastric view from the transesophageal. And in this view, you can see this is septal anterior, but there's also some leak extending all the way down to septo posterior. Some of the leak, the majority of the leak, septo anterior. A small amount of the leak, septo posterior. So when we do our cutting, here is septo anterior, and here's septo posterior. Let's have a look at the leak and try and isolate whereabouts along it is. And actually, as we got into the case, we realised it was fairly close to the middle of the valve, most of it in the septo anterior, we thought. So we thought we'd probably do this kind of approach to the leak. As we went along through the case, we introduced the device, steered down onto the valve, always with our plan to go septo anterior first. And so here's the view. We had to get axiality like this. And then we actually did the gripping on this case in the transgastric view. There's septo anterior. You can see the device coming into place, getting the axiality correct on the coaptation line. And once we were happy we were in position, we deployed the first clip. You can see the leaflets coming onto the clip very nicely there, like that, like that. And when we were happy that we had adequate leaflet insertion into the clip, we deployed and made the first grasp of the clip. And so let's have a look what we've got here. What we've got is a clip which is not fully to the commissure. It is in the septo anterior portion of the valve, and there's residual leak. This is still septo anterior here and septo posterior here. As we did the case, to me, it became obvious that we weren't exactly sure where anterior finished and posterior started. But as we continued with the case, it occurred to me that it didn't exactly matter whether or not we were past that junction point or not. What we had to do is get the leak. So we go in now with the second clip, steer down onto it. Actually, I'll just go, yep, there we are. Click there. And so that looked too close to me, so we wanted to move them apart slightly, which we did. Steered down on and made a second grasp like that. And so now you can see septo anterior, septo something. Is it septo anterior or has it gone on to posterior? I'm not sure. I'm not exactly sure where the cutoff is. But whatever it is, we've basically plicated that portion of the valve. Now, we did do a couple of different grasps to get this right. And in my mind, I think that was mostly both of these septo anterior. So I think we actually did this in the end. Yeah, a little bit difficult to be absolutely certain, but I think this is where we ended up in the end. And after all of that, we ended up with a, I think, moderate residual leak. Now, it wasn't perfect, but what's interesting is that this is the residual leak. At the beginning, it was filling the atrium massive. But what was quite impressive was that this lady at follow-up had moderate regurgitation, but much improved. So she was using 40 milligrams of furosemide every second day instead of 160 every day. So I think that even though this is early days with tricuspid clipping, even though it's not a perfect surgical result, I think that it seemed to have the clinical effect that we're looking for. So to sum up, let me say that tricuspid valve percutaneous intervention is here. It's not easy. It's another level more complex than mitral. But if you do the anatomy and use these scans to get your septo anterior and septo posterior anatomy correct, I think that you'll find that you can start to get these procedures working. Thank you very much.
Thank you, Dr. Scalia provides us very detailed and interesting echocardiographic image for the tricuspid valve intervention. But because the time is limited, we'll move on to the next speakers. Dr. Lee will introduce the next speaker.
Next speaker is Dr. Karl Poon and he's very famous in the interventional cardiology practice in public and the private hospital in Queensland area, and he was participated a lot of international meetings such as London Valve and the PCI. So welcome Dr. Karl Poon for the lecture Mitral Valve in Valve, and thank you.
Thank you very much for the invitation and to the steering committee. Thank you. I hope you can hear me. I'll share my slides now, and I have to say it's a pleasure and privilege to work with Professor Scalia on a daily basis. I hope you enjoyed that talk as much as I always did. Now, the transeptal mitral valve in valve is in fact one of Professor Scalia's favorite procedures, so I hope I can do him proud. So these are my disclosures. I think the main one here is I serve as the site PI at the Prince Charles Hospital for Partner 3 transeptal mitral valve and valve sub-study, which is nearly finishing in enrollment. So these are the numbers in terms of operative mortality for repeat mitral valve surgery. Now, some of my surgical colleagues would argue that they would not have 5 to 10% operative mortality for mitral valve redo surgery, but suffice it to say, these have been the numbers over the past 10 years or so in terms of redo mitral valve surgery being a high morbidity procedure. And as such, it was obviously an onus on transcatheter cardiologists, specialists, to look for an alternative. And it seemed quite intuitive to have a transcatheter solution like we now have for aortic valve and valve and all sorts of valve and valve procedure. And of course, credit to the pioneers that at Vancouver and St. Paul and Professor John Webb. They did the first procedure transeptally in 2009. Now, this was utilizing the very first iteration of Edwards, which was a 24 French device with a very short valve frame. I still remember using it in 2012 in the US. It was very unwieldy. So at the time, I think there were multiple challenges in terms of sizing, recognizing that the valve labeled size is not the same as ID. So unfortunately, this very first transeptal case, the valve did not anchor onto the mitral valve sewing ring and embolized ventricularly. Patient did not do well. Unfortunately, the second case was the same, and for a while, there was a strong push to have transcatheter mitral valve and valve performed transatrially or transapically or surgically. Since the advent of SAPIEN 3, which is obviously a lower profile device with a better steerable catheter and a longer valve frame, and you can see on the right of the screen, it's only about 4 millimeter longer than an XT, for example. And those of us who've had to use XT for a while will realize how much of a difference it made even in the aortic space. So that 4 millimeter or so really changed the game in terms of transeptal mitral valve and valve. And this is mirrored in terms of the real world data. This is from the TVT registry, and the same more contemporary data presented by Dr. Guerrera at TCT a few years ago, showing the predominance of transeptal mitral valve and valve nowadays, up to 90%. And in our institution at the Prince Charles Hospital, we have not done a transapical mitral valve and valve for 5 years now, I think. So all of our mitral valve and valve cases have been transeptally, obviously guided by echocardiography like Professor Scalia can give us. It's important to note, mirroring the move to transeptal mitral valve and valve, there's been an improvement in outcome. Now, 30-day all-cause mortality 2 years ago at 4% for what is a high-risk surgical procedure was quite acceptable, of course, but that's still about 3, 4, 5% more than you would expect from a routine TAVI nowadays. And I'm sure most centers around the world would aim for less than 1% 30-day mortality. So there's still room to improve, but admittedly, these data refer to high-risk surgical candidates. In the US, the transeptal mitral valve and valve is only approved for patients at high surgical risk. Now, I've been tasked with really focusing on the procedure itself rather than the data. So I hope that the previous part gave you a bit of a preamble of where we are in terms of transeptal mitral valve and valve procedures. So I'll start off with the planning for transeptal mitral valve and valve. I think as with any valve and valve procedures, it's ideal to have the operation report. You need to know what sort of mitral valve prosthesis it was, obviously. The valve and valve app by Vinnie, it's obviously instrumental in moving the game so that we understand the fluoroscopic landmark as well as sizing. And I think CT analysis, as with any transcatheter therapy, but quite importantly for mitral valve and valve, as I will allude to shortly. So in terms of the operation report, I think it's obviously important to understand the differences between the different bioprostheses. In particular, some bioprostheses are particularly fluoroscopically visible, such as the perimount, where there's a strong, dense marker at the sewing ring. Fourth down on the picture on the right is an epic. So even though there's allegedly a sewing ring, it's actually hardly visible. So quite a challenging valve to do mitral or aortic. Some of the mitral prostheses you can only see the stent tip, such as the circles, which is the second one down the mosaic, as well as the Hancock at the top. Some valves are highly visible, such as the Carpentier Edwards Magna. So you can see the difference between all of them, and it makes sense that the hard to see sewing ring are much harder to deploy, particularly the epic. It's particularly important in the mitral space to recognize the difference between porcine and bovine pericardium. In particular, the porcine valves are particularly shorter compared to bovine, and as such, the risk of LVOT obstruction is usually lower. I always ask for a surgical note, and unless your patient has traveled or has had the operation overseas, usually available. These are some of the cases we did just last week with surgical notes locally, as well as another hospital locally. It's very important to know whether the anterior mitral leaflet has been resected. For most mitral valve replacement, that would have been undertaken. It's important for LVOT obstruction prediction, particularly in valve in MAC, for example. So with the valve and valve app, you have a very good idea of the internal diameter as well as the height of the valve. And this was the point I was trying to make earlier, in particular the porcine valve with a shorter leaflet and making you quite a lot more reassured about the risk for LVOT obstruction as opposed to the bovine pericardium. Now, in terms of the CT, perhaps the biggest use is really LVOT obstruction, but we always measure on CT, particularly on false, just to confirm the sizing has been correct or the size label has been correct. But very critical in any transeptal mitral valve intervention, whether it's valve in ring or valve in MAC, or even transcatheter mitral valve replacement, such as the newer generation, such as M3 or Tendyne. Very important, catastrophic complication to have LVOT obstruction. Now, with mitral valve and valve, the risk of LVOT obstruction is usually very low, unless you have significant septal hypertrophy, So whilst it's important to rule out because of the catastrophic complication, it's usually very rare. The challenge usually for centers doing 1 or maybe 2 a year is that you do need a dedicated mitral module, which obviously is quite costly. And I know some operators will use the CT planning for transeptal puncture location as well, particularly if they have a system that will allow for overlay, such as the Philips. These are some of the numbers in terms of risk prediction for LVOT obstruction. This was a case we did on Tuesday. At the top, there's the orange is the LVOT prediction. On the left is diastole, on the right is systole. right of the screen is systole. In this particular case, the area is 400 plus, so there's next to no risk for LVOT obstruction. This seems to be an interesting topic for when I proctor and announce proctors how to size mitral valve and valve. You'd think from all that we've learned in aortic valve and valve that it should be fairly straightforward. We should go to the internal diameter and then size it based on the internal diameter. To a certain extent, that's quite true. But sizing is really a balance. In the mitral space, the gradient matters a lot more. What we're talking about, an optimal result to a less than good, is only a couple of millimeters, as opposed to in the aortic space, where you may talk about 10 to 15 millimeter mercury difference. So that's why it's so important to select the best, largest valve possible without causing too much constraint in the valve. In the picture here, I was trying to show what would happen if you have a very constrained valve, which is essentially pinwheeling. So if you put a 29 valve in a 26 ID, that may lead to leaflets being scrunched up, and this may have strong implication of valve durability. Some would advocate that if you have mitral stenosis with thickened leaflets, perhaps if you have in-between sizing, you may go for a smaller valve. That's sort of my practice as well. So go to the procedure step by step now. Unlike in mitral clip, we aim for a low or infral posterior puncture in such a way that you won't have this problem on the right of the screen where you have to have a double curve to get into the mitral prosthesis. In the ideal world, the puncture should be at the lower half of the mitral prosthesis in such a way that traversing the septum and the mitral valve will be a bit easier. So this is the point here. So as you come down on the septum, the transeptal puncture should be at the lower half of the mitral prosthesis. This is a good little tip when you want to check that it's not too high a puncture. After the transeptal puncture, I tend to use 12 millimeter septostomy balloon, a peripheral balloon, 80 centimeter length will do, or 14 for 29 millimeter S3. Now, the vendor would suggest that a 10 millimeter and 12 millimeter respectively will be sufficient, but as we know now, a larger transeptal will usually lead to better traversal and less difficulty crossing. Don't use a 20 millimeter balloon, that's way too short. And in fact, a longer balloon may even allow you to do a septostomy and maybe the idea of flossing the mitral prosthesis with a balloon across it as well. So to test the pathway, just to pave the way, so to speak. We try not to use an Agilis because of cost and with usually excellent 3D echocardiography from Greg, we quite easily can traverse without an Agilis most of the time to save a few $1,000s there. So toe I find incredibly useful in terms of traversing the valve. You then have a pigtail into the ventricular apex to avoid catching any chordae with just the wire. I think that's essentially just a little video, sorry. So you have the Safari pointing down and using that as a rail. Now this I've learned the hard way. One of the biggest difference of mitral valve and valve is that you really need to push on the wire. Now I've already mentioned that Safari extra small is generally the go-to wire, but you can see you are asking a wire to do a more than almost a 180 degree bend. If you do not have forward tension on the wire, more often than not, this wire has a natural tendency to come back. So in the early days, we've had wires coming back all the way here as we advance the prosthesis. So very important, the first operator or the second operator, one of us has to be holding the wire when we're prepping devices at the back. In the past, I used to curve the wire, but this seems to be not that useful, mainly because I think the steerable catheter itself is so stiff. The wire will only Shaping the wire will anchor the wire, but doesn't really change the trajectory. Okay, if you shape the wire, you're less likely to have the wire buckle back. So this is the traversal. I think one of our earlier cases, a mosaic there. So it's definitely a two-person job. I, as the primary, I like to push and use the flex, and the second operator will pull on the wire to help. Now, on Tuesday, when we did this case, I did not save it, but we pushed the valve across, we pulled back the pusher, but unfortunately in the process, the valve advanced. It's very, very important to avoid that because it did take a lot of effort to actually pull the valve back across the sewing ring because you have metal to metal, and quite often it can be very tricky to pull back. So do not advance the atrial edge of the valve across the sewing ring. So in that particular case, I had to advance the pusher again, push, pull many, many times to pull it back into the atrium. So I think the key in terms of deployment is really very, very slow inflation. This was when I was the primary. My assistant was better than me in inflating. This was me inflating the valve, and this was obviously a little bit harder, a mosaic with no sewing ring to aim for. I think there's another tip or trick whereby if you do not have enough height at the transeptal puncture, you can actually clock it to pull this back so that you have a bit more height. So I think I should have been a bit slower at the last part of the inflation. The balloon advanced a little bit, but in the end, it was actually satisfactory, just a little bit ventricular. And in terms of placement, I've already mentioned sometimes it's very difficult if you don't have any visible marker. These are some of the advices from the vendor in terms of where to aim. You really need to aim for the sewing ring, not any other fluoroscopic marker. So this was my very first transeptal mitral valve and valve in 2016. Patient still going well, also a mosaic at the time. There's been a little bit of interest about closing the iatrogenic ASD, but I did that in the early days, but we hardly do that unless there's left to right shunt hypoxia or severe right ventricular dysfunction. So in summary, transeptal mitral valve and valve is superior to transapical mitral valve and valve in procedural and medium-term outcomes. I know Dr. Lee is a strong proponent of transapical mitral valve and valve from your last Proctor's meeting. I think optimal outcomes depend on pre-procedural planning, of course, but at the time of the procedure, the critical 10 minutes is all about placement and sizing. I think there's a lot of unresolved issues. We won't have time to go into it. As you may know, the Partner 3 intermediate risk transeptal mitral valve and valve is finished and rolling. So hopefully our data will be shared in the next a little bit, particularly about durability. I tend to favor warfarin ahead of any other antithrombotic, and all the other issues about whether you can do another transeptal mitral valve in valve in the future and the need for bioprosthetic valve fracturing. So thank you very much for your attention for this interesting topic to me. Thanks.
Thank you, Dr. Poon. And I have two short questions for you. The first one is when I last in Porter meeting, the Professor Krupa said that he always used smaller valve. How do you think about a smaller valve in mitral valve in valve? And do you flare the mitral valve during valve-in-valve procedure?
Yep. So I think mitral valve smaller prosthesis is, to me, a concern. If you look at the data for the smaller mitral prosthesis, whether it's 23 or even 20, you end up having a transmitral gradient of at least 6, if not higher. The residual higher gradient, at least in the registry data, was associated with a poorer outcome. So I think if you, quite frankly, if you're putting a 23 in, particularly if there's already some suspicion of patient prosthesis mismatch at baseline, have a low threshold to crack the valve. I think the flaring, I think there's two aspects to it. Number one, it may anchor the valve a little bit better because obviously the likelihood is ventricular to atrial embolization. But more importantly, I think there's a theory that in flaring, you may have a bigger valve area, a lower gradient, although I think we need more data to conclude on that.
Dr. Lee, do you have any question?
Thank you, Dr. Peng. I'm Dr. Lee, the cardiac surgeon from Zhenxing General Hospital. Will the preoperative parabolic will affect your approach for mitral valve in valve? That's my question.
I think I've seen cases where people would crack a valve in the process of mitigating two problems. I presume obviously there's intravalvular pathology as well as paravalvular. So some would think that's a good idea to use a cracking and then a bigger valve. Personally, having done some mitral valve in MAC, I respect the mitral annulus, I dare say, a lot more than aortic. The mitral annulus is a lot more dynamic. So I've done a mitral valve in MAC case where it just continued to change. At the time, the prosthesis seemed satisfactory. A few months later, there's more paravalvular leak, and we went from a 26 millimeter valve on planning up to a 29 S3 that was post-dilated by 10 cc. That was the sort of dynamism of the mitral annulus. So I think if you were to have a case where it's a mitral bioprosthesis, I would probably pluck it first and then do a transeptal mitral valve in valve. I'm not entirely sure whether cracking in itself is enough and putting a bigger valve in, because I think there's so much more dynamism in the mitral annulus than the aortic, for example.
Okay, thank you.
We next move to next topic and Professor Cao.
The next speaker is Professor Pan Wenzhi, and Professor Pan is currently working in Shanghai, Fudan Daxue Zhongshan Yiyuan. He is an expert of transcatheter heart valve therapy and also an inventor of transcatheter heart valve devices, especially valve clamp and re-access. And he also published many structural heart related papers in the world renowned journal. Today he's giving us a talk, and the title is Transcatheter Tricuspid Valve Replacement. Professor Pan, please.
Thank you, Professor Cao and Professor Lee, for your invitation for this lecture. My topic is transcatheter tricuspid valve replacement. Yeah, sorry. You know, the tricuspid valve regurgitation is a common valve disease. It has more than 1.1
Professor Pan,
million.
would you please share your screen? Sorry.
Okay.
Share screen.
Okay. Sorry. Okay. Can you see the?
Yeah, we can see clearly.
Okay. Tricuspid is a common valve disease. It has had 1.6 billion patients in USA, and the cause mostly is secondary cause. Yeah. Sorry. And the long-term survival in severe tricuspid regurgitation is poor. The mortality can reach 60% at 5 years. This is the data from our center. We have surveyed the echo data in our center. We've found the detection rates of the TR in severe is 3.8. And the most common cause is the secondary cause is direct cardiomyopathy is the most common cause. And the 5 years survival rate is 77 in our center. for the severe TR patients. And the surgery mortality in TR is very high. It can reach 10% in the North America. So it's a unmet need for the transcatheter interventions, but it's had a very difficulty for the transcatheter tricuspid replacement because the annulus is soft and fragile, and it's a non-circular run, and the dimension can change during the cardiac cycle, and the aortic structure is complex. There are several valves has go into the clinical trials for the TTVR. The first valve is Navigate. Is the first valve go into the clinical trial in the world. Is high. Is a Mitral stent. The high is 21 millimeters, and the annulus was 36, 40, 44, 48, and 52, and it had a pericardial lip date is 24 frames. It can it can implant from the jugular vein. Also can implant from the right atrial or sex. The Navigate CU study include 32 patients, and the characters of the patient is shown in this slide. Totally, it has the 30 days mortality is 12.5, and the patients are alive more than 75 in 30 patients. The second valve, called loose valve, is a Chinese valve invented in Shanghai. It has two anterior lip clamps, and it has a soft atrial anchorage, and the valve is 26 and 20 millimeter for the annulus. This valve valve sizing is based on the emphatic tricuspid orifice area, known the size of the annulus. It is 15 depending on the anterior cusp and the interventricular septum. Known from the radial force, it had good permeable nicolate profile. It can this valve is implant from the right atrium, under guided by the TEE or the fluoroscopy. The first immense study for this valve includes 55 patients, and the age is 69, and the patient is generally very poor for the standard dose. The LVEF is 55, and then the TAPS is 14. It's very sick, very weak, very risk patient because the STS score is 9.2. The operation time is 150, and the valve delivery time is 10 minutes. The implantation rate is very high. It's achieved 100%. No person convert to the open surgery, and the the other data for the post-open therapy. No patient suffer third degree MViV and also the right coronary injury. No patient had a pulmonary embolism, and the 30 days mortality is 5.7, and the echo from the 26 patient is also good. It shows the tricuspid regurgitation is decreased near 0, and the tricuspid gradient is also low. and 6 MWD and NYHA is improved. The pivotal study for this valve, also called the pre-marking study, is ongoing in China. It will include 150 patients. Now it has completed about 120 patients. So this study will be finished in the next few months. The next valve is called the evacuum valve. This valve is first meant to treat mitral regurgitation, but now it found it can also implant in the tricuspid valve and had very good results. And the valve delivery system is 28 frames. It has the currently two sizes. One size is 44 millimeter. Another size is 48 millimeter. And the ACC 2020 meeting has published the recent result for this valve. It includes 56 patients. The age is 76, and is also the very ill patients. You can see the adverse events is low. The cardiovascular mortality at 30 days is just 1.6. No patient has stroke or urinary complications. But the severe bleeding complications is some bit height, 22.6%. Device pulmonary embolization is 0. So the of course mortality is showing 2.8, and patient's device success is very high. It's 98%. The procedure rate is 94%, and the length of the stay is 3 days. So the results is excellent for this valve, evacuum valve. It's a 10. It's improved. It's implanted by the right femoral ring, and the echo results also is good. You can see the transverse vein gradient is low, and also the regurgitation is very few. So the result of this valve called transcend study shows that this valve has good results regarding the TR stability, the NHA class, or the 6 mini walk distance, or Kankakee Q squat. There are another valve may treat the tricuspid regurgitation. It's Intrepid valve. Intrepid is also debate for the mitral regurgitation, but now it found it can also implant in the tricuspid valve position, and have done several cases and showed good results. And there are another valve in the animal experiment. It's called the we done tricuspid valve, and this valve has some difference because it's the implant for the left, no the up or the down size for the valve. This is the animal results. Shows the results. The 90 days covered in growth for the this valve is implant for the IVC in this way. So I have a summary. The cons and pros. The positives of the PTVR is it can elevate TR components and can operate with of the motor TV. It have a huge possibility, and it can replace the surgical replace immediately of the patient. But the negative prospects of the PPTR is it needs better delivery system. It has if the patient has PPM device, it may interaction with this device, and it need a very strong anticoagulation, and is not suitable if the patient have right ventricular dysfunction. So thank you for your attention.
Thank you, Dr. Pan, for your excellent talk. Any question from our colleagues?
Yeah, Professor Pan, there are 50 rules. Could you explain 50 rules in your LUX-V?
50 rules? Yes,
there's just a few months ago, 50 rules. It's when LUX-V in your trial, you need the annulus less than 50 and the PA pressure less than 50. It's only indicated when the RV is smaller in your LUX system, or that's the PA pressure is higher and the annulus is higher, you still can do that.
Oh, you know, for the loose bear, or you means the annual, if the annual size is very large, can use the PPTR.
就是说，之前在讨论的时候，你们的 LUX system 有规定一个50的那个 PA 压力50，然后 annulus 50，这是在 trial 里面规定的，还是说因为大于50以上的 annulus 或者 PA pressure 是效果
是在 trial 里面规定的？
所以是硬规定，没有任何的道理可言。
是的，是临床实验它限得比较准，比较严。
那你的经验里面，因为在 Tricuspid Valve 的问题里面呢，有些都是太晚开刀了，那常常是不符合这些 criteria。那你在你的经验里面有没有做过这些病人，然后临床的结果怎么样？
实际上呢，现在有一个观点呢，就是原来就是探索的不到，现在慢慢有一些观点，就是说3件半的置换的病人不能挑得特别重，特别重的话呢，可能至少半毛给他换上去，演气效果也不会特别好啊。就是目前其实探索下来的，因为以前这个3件半置换是全世界都没人做过啊。因为呢，病人非常非常重的病人，他肯定不能开刀啊。然后呢，现在就有这个技术给他放了进去。后来发现，真的非常非常的重的病人，即使把瓣膜换好了，他可能缓解癔症，但总体预后也没想象中的那么好。所以呢，不能挑的特别重的病人，这是我们现在大陆做下来的一个体会吧。
Okay, thank you. So, transcatheter tricuspid valve replacement and has a high successful rate and lower complication and quite good clinical outcomes. Probably it may become the main treatment modality for the tricuspid valve disease in the future. So thank you, Dr. Professor Pan, for your excellent talk. So we will move on.
Thank you.
Yeah, we'll move on to the next section. So I would like to invite the co-chairman, Dr. Li Guozhen, come up to the podium, and the commentators are Dr. Li Yongzai, and Dr. Lin Dingshao, and Dr. Lin Bingyi. So this session is regarding the TAVR. And so I would like to introduce our first speaker. The first speaker is Dr. Ho K. Wong. Professor Wong is a senior consultant from Department of Cardiology with of the National Heart Center, Singapore. He is a very experienced transcatheter aortic valve implantation operator. So the topic today is PCI after TAVR, especially balloon expandable valve. Professor Wong, please.
Thank you for that kind introduction. Can everybody hear me? Yeah, so good that we have this virtual platform has allowed me to actually record the recordings. So I'm just gonna play the recordings, just making sure that everything is okay.
Yeah, we can see the slides clearly. Yeah. Dr. Wong, we cannot hear you. Can you turn on your microphone? Can you turn on your microphone? Dr. Wong?
Sorry, you couldn't hear the talk, is it?
Yeah, we cannot hear you.
Okay, then I will give up doing the video. Sorry about this.
It's okay, no worries. Yeah.
Technical problems. Let me just stop screen. Knew this will happen. I'm just going to share and present. Sorry for the delay.
Okay, now we can see your slide quite.
Okay, you can see my slide and can you hear me live? Yes. Okay, so I'm going to repeat this. Thanks for the kind introduction. The topic of my talk today is PCI after TAVI with balloon expandable valves. These are my disclosures. Outline of my talk is an overview of coronary artery disease and TAVI. First part also be mentioning about the risk of coronary occlusion and PCI during the deployment of the balloon expandable valve. And last part will be looking at coronary access post-balloon expandable valve implantation. As there will be some overlap between my talk and Dr. Gilbert Tang's talk, where he talks about coronary access and self-expanding valve. This being my talk being a simpler talk, and the first talk I thought I would give the overview of coronary artery disease and TAVI. So as earlier TAVI trials focus on higher risk, more elderly patients, these are generally patients with higher prevalence of coronary artery risk factors and hence the prevalence of coronary artery disease. However, it's uncertain if revascularization would benefit all patients prior to TAVI. A meta-analysis looking at 9 studies of PCI versus no PCI in pre-TAVI patients in more than 3,800 participants showed that there was actually higher 30-day mortality if you perform PCI compared to no PCI in such patients, but these differences were negligible at 1 year. What about the benefits? There were no difference in MI, what we're trying to prevent in patients who underwent PCI prior to TAVI with more vascular complications. So despite these evidence, the 2017 ACC appropriate use recommendation still recommended that revascularization be done in patients undergoing TAVI procedure, particularly so where there is a large area at risk, left-main triple vessel disease, or if you have high-risk non-invasive findings. As we move to low-risk younger patients with severe AS, low-risk TAVI trials have shown that TAVI is non-inferior to SEV. However, with younger patients, even though they have lower prevalence of coronary artery disease, they have higher lifetime risk for developing coronary artery disease, higher likelihood of needing TAV in TAV, and is hence important for us as implanters to plan ahead before TAVI valve implantation to see how we can best maintain coronary access. We certainly don't want this situation. So this is a patient who I implanted a lotus valve, had a previous stent in the proximal LAD as well. had chest pain about 3 years after the lotus valve implantation, and this was the coronary angiogram. As you can see from the aortogram, the lotus valve was covering the sinotubular junction, not allowing any catheters to go above the valve frame. And what we could do was only non-selective injection with the Judkins catheter, both of the right and left coronary arteries. Fortunately, the patient did not have any significant stenosis that need treatment, but if the patient needed PCI and was still in an acute coronary syndrome where urgent PCI is needed, this will be very difficult, if not impossible to do. The other situation is here. It is one of my oldest patients that I've treated. He is 100 years old. When we first implanted the core valve LVR, he's still well. 4 years after the implantation, there was suddenly one flailed leaflet that resulted in a lot of transvalvular aortic regurgitation. At 104 years old, he was still well. So we implanted the second layer of core valve within the first layer. This treated the aortic regurgitation. But if you can imagine, this was a younger patient and you need to reassess the coronaries after 2 layers of core valve, it will be very difficult. The saving grace for this patient is that the core valve was implanted relatively low and there was adequate sinuses. We potentially can go above the supraannular valve leaflet to assess the coronaries if we needed to. The second segment of my talk is coronary occlusion during balloon expandable valve implantation. Fortunately, this is of rare occurrence, less than 1%, but if this occurs, there is high risk of mortality. The risk factors are very well known. It all related to the probability of coronaries being occluded by the native valve leaflet. So if you have low coronary heights, narrow sinus of Valsalva, a short, narrow STJ, very bulky native aortic valve leaflets, the use of balloon expandable valve, or in a valve-in-valve situation where the surgical bioprosthetic valve have leaflet mounted on the outside. These are known risk factors for causing coronary occlusion. Hence, the importance of CT assessment prior to TAVI implantation. If the CT does show that there is high risk of coronary occlusion, we should reconsider whether the patient is fit for surgical valve replacement. If the patient needs TAVI, then we should avoid oversizing. We should consider the use of a retrievable TAVI valve system to increase safety margins and the use of coronary wire with stents in place in case there is coronary occlusion. This is largely one method how this is done, where we have a guider and wiring of the left main artery in this case. An appropriately sized stent is placed undeployed in the left coronary system, ready to be pulled back. It must be of an adequate length such that it creates a chimney and a conduit between the ascending aorta and the left main. So the TAVI goes on as planned, and if there is any compromise to the left main flow, the stent can simply be pulled back, deployed. This is one variation. We have seen Dr. Mann gave his variation where he used a guide extension to deploy, and it can also be just placement of a wire or a balloon. But there are downsides to this coronary protection. There may be increased use of unnecessary stents, and we try to pull that back across the deployed TAVI valve frame. There may be risk of dislodgement, or if you just place a wire across, deploy the valve, there may be difficulty to deploy a stent subsequently if there is a need for a stent. Hence, basilica was an alternative to prevention of coronary occlusion during balloon expandable valve implantation. The concept is where there is risk of occlusion either with bioprosthetic or native aortic valve leaflet. A stiff electrified wire is pierced across the aortic valve leaflet. This was snared to form a loop, and the loop pulled up to lacerate the aortic valve leaflet. And when the TAVI valve is deployed, this creates a channel to the coronary ostium as illustrated here to still maintain coronary flow. So this is the basilica procedure. I've looked back at our cases since 2009. We had 2 patients with left main occlusion. Both did not occur with balloon expandable valve, but with self-expanding valve. But I did find a patient that had a need for PCI during balloon expandable valve. This was an 86-year-old patient, adequate femoral access size for transfemoral access. The annulus measured in excess of 26 millimeter. The sinus of Valsalva was 36 large. The coronary heights, left main 12, right coronary artery 22. Same I think. This patient fit none of the risk factors I mentioned earlier. Why does this patient have coronary occlusion and being presented at the moment? We'll look through. So this was the coplanar view. You can see good coronary flow of the right coronary artery as well as the left main. So this was the XT valve. We did balloon inflation, pre-dilatation using the kit 25 millimeter balloon. We had to do this several times because the balloon keeps slipping back aortically at 180 beats per minute. And we had to increase the pacing rate to 200 beats per minute, very controlled, slow inflation of the balloon. We placed the balloon, the valve in a position that we thought was suitable, again under pacing rate of 200 beats per minute and the very slow control pacing. We deployed the valve. This was the corresponding TEE. We deployed a 29 millimeter XT valve and a 26 millimeter annulus. This will result in an 18% oversizing. The valve was adequately deployed, good expansion. Balloon came down. We thought we should go back home end of the day. However, the blood pressure never recovered. Aortogram shows left main still patent, but we don't see any flow of the RCA. TE also show akinesia of the inferior wall. We had to stabilize the patient with an ECMO supports. This supported the blood pressure. This gave us time to evaluate the coronary artery. We still see patent left main artery, but the right, you can see there was slow flow and there was a filling defect of the ostium of the RCA. The differential diagnosis includes that of a thrombus versus what was more likely, a dissection. There was no corresponding filling defect of the sinuses, and the XT valve was some considerable distance from the RCA. There were no difficulties assessing the RCA after the TAVI valve implantation. We had to change several guider because of the horizontal routes, eventually selecting the AL's 0.75 guider. With some manipulation, managed to get the guider close to the RCA, wired the RCA, eventually deployed a stent at the ostium of the RCA, restoring flow, resolving the ST elevation, and stabilizing the patient. So coronary occlusion during balloon expandable valve and in TAVI is often associated with profound hypotension and instability. As interventionists, we are all trained to open up the artery as soon as possible, but in this situation, we should take a step back. We should stabilize the patient's blood pressure prior to revascularization. Once the blood pressure is stabilized, most of the time with ECMO, the decision then is how we should revascularize. Can we easily revascularize like PCI as what we have demonstrated? Or if it's very difficult for coronary re-access, should we consider emergency bypass? So this is in balance with the risk of a crash open surgery and also the speed of revascularization and restoring coronary flow. The last segment of my talk talks about coronary access post-balloon expandable valve. Studies have been done to assess coronary angiogram difficulty as well as PCI success rate after TAVI. One such study looked at 66 patients. Balloon expandable valve generally no difficulties in performing angiogram or PCI. But when we have self-expanding valve, particularly so when we have supraannular valve leaflet, there is more difficulty and more incidence of non-selective or semi-selective angiogram, sometimes requiring wiring to help with the angiogram. Similar studies of 35 patients, again, balloon expandable valve, no difficulties in coronary angiogram or PCI, but we have more difficulties when we use self-expanding valve, particularly that of core valve. and PCI rates can also be lower. A more local flavor, we have an Asian study looking at difficulty of coronary angiogram after TAVI, 96 Asian patients predominantly. The overall success rate of coronary angiogram, 92%. Factors that predicted higher difficulty include that of smaller annulus, and in particular, the use of self-expanding valve type. In the beautiful paper that was published by Yudi and our second speaker, Dr. Gilbert Tang, it illustrates a factor that may impact coronary access post-TAVI. I mentioned earlier the anatomical factors that also increase the risk of coronary occlusion. There is also a consideration of device and procedural factors, where the commissural tab is oriented, what the ceiling skirt height is, and also the depth of implantation. Considering all these factors, a patient may have very difficult coronary access if you have normal SOV, small, narrow STJ, low coronary height, a commissural tab that is placed directly in front of the coronary ostium, or a higher, more aortic implantation. This would make coronary access more difficult. When we consider the use of balloon expandable valve, the XT versus the newer S3 valve, the XT valve is actually of a shorter valve frame versus the S3 actually has a taller valve frame and a taller ceiling skirt height. Hence, there is higher likelihood of the stent frame of the S3 covering the coronary ostium. But no worries, the top of cells of the S3 is actually 38% larger in terms of the area, allowing for easier catheter access through the cells if we do need to versus the XT valve. When we consider coronary access and catheter selection, for coronary angiogram, standard catheters like the Judkins series can be easily used. For PCI, again, standard catheters, even extra backup catheters can be used. In difficult cases, we would then have to consider wiring coronary access remotely without a selective injection, then using balloon supports to pull the catheters across the valve frame of the TAVI valve frame, or the use of guide extension catheters. Here are some examples of coronary angiogram of patients after S3 valve. We can assess the coronaries over the S3 valve easily with standard catheters. PCI, in this case of a sapien valve, can be performed using standard Judkins guiders. Even an extra backup catheters can be used when we do need to intervene on the LAD in a patient previously implanted with a sapien valve, wiring of the LAD, as well as subsequent delivery of the stents, and eventual successful PCI can be achieved easily over the balloon expandable valve. I mentioned earlier one difficult situation when the commissural tab is placed directly in front of the coronary ostium. You can imagine that it will be very difficult to engage the guiding catheter through the tab that we want. What we may need to do is go across an adjacent open cell, and this may result in a higher chance of non-selective angiogram. Again, with this situation, we may need to wire the coronary artery. With the use of wire and balloon anchoring, achieve a more selective injection, or considering the use of guide extension catheters. So in conclusion, ladies and gentlemen, as we move towards low-risk younger patients treated with TAVI, it is our responsibilities and implanters to consider how we can best maintain coronary access even after TAVI. Balloon expandable valve with its shorter valve frame and large open cells facilitates coronary access and generally not an issue if we do need coronary access. So it's hence important for us prior to TAVI implantation to plan and choose the appropriate TAVI valve for lifetime management of such patients. With that, I thank you for your kind attention.
And thank you for your excellent talk. So I can have a question for you. If the patient has a higher risk of a coronary occlusion, like lower coronary ostium or narrowed sinus valsava, and the coronary protection is planned for TAVR, so how do you select the valve?
So there are two schools of thought, whether we should use a retrievable valve type like a core valve, for example. But this will result in a longer chimney stance if we do need to bail out, and trapping the stance in a very long frame. And eventually we don't have data on the long-term patency. And if we do need to reassess the coronaries through this long chimney valve, it's going to be very difficult. So my preference is actually to choose a shorter valve frame, like a balloon expandable valve, have the stance in place. So this would allow me to have a lower segment of stance that is trapped potentially behind the stem frame, and to deploy the stance if I do have any compromise of flow after TAVI valve implantation. So in short, I would choose a balloon expandable valve in such situation.
Okay, thank you. Thank you. Any questions?
I have a question for Dr. Hong. In your case that have late occlusion of the coronary artery, so in such patient, will you suggest use the IVUS instead of the coronary angiogram to check the orifice of the coronary artery before you complete the TAVI procedure?
It depends on the situation. Sometimes we by angiogram could actually visualize that the native vessel, the sealing skirt, is actually compromising. In patients with very short STJ, we can sometimes even see the sealing skirt, particularly of a supraannular valve, is almost occluding. In such cases, possibly I don't need the IVUS to illustrate what is actually happening. In more dubious cases, yes, IVUS would definitely help. But in most cases, what I do find is there's quite a bit of space between the sealing skirt and the coronary ostium, such that the coronary ostium is actually not threatened at all, but it is a result of the valve frame and the sealing skirt interaction with the STJ that is causing more of a problem.
Okay, thank you. So thank you for the great talk. So we move to the next speaker will be introduced by Dr. Lee.
The next talk is also associated with the PCI after TAVR. Let me introduce the next speaker first. The next speaker is Dr. Gilbert Tang. Gilbert Tang, he graduated from Harvard University, and he got his MD and residence of cardiac surgery at the University of Toronto. Currently he is the surgical director of the structural heart program at the Mount Sinai Health System. He pioneered a technique to help better orient transcatheter heart valve during TAVR procedure to make it easier to re-access the coronary artery. So today he will give us a talk about the PCI after TAVR in self-expanding valves. So Professor Tang, welcome and please.
Thank you very much for your kind. Sorry that my Zoom connection just got lost, so I had to restart my presentation. So I'm going to share my screen right now. Can everyone see the presentation okay?
Yes, yes, quite clear.
Okay, great. Okay, well, thank you very much again for the kind introduction. Here are my disclosures. So we know that coronary access after TAVR, as I previously mentioned, can be challenging, mostly because the device familiarity by interventional cardiologists who do not perform TAVI or TAVR, those are the ones who find it most difficult. And we know that the aortic root anatomy is highly variable from patient to patient. Unlike surgery, though, we have a few barriers facing the coronary arteries. One is the native aortic valve leaflet. One is the stent frame of the transcatheter valve, and of course, the transcatheter valve commissure because of the lack of commissural alignment. So here are the two examples of what the coronary access might be difficult
after TAVI with a balloon expandable valve. You can see here there's a big, bulky, calcified native leaflet in the way that can potentially make selective angiography difficult. But also you can see here, this is a valve in a surgical valve after self-expanding valve. And you can see that because of the narrow STJ directly engaging the coronary ostia, even with commissural alignment, for example, might still be challenging. So we need to understand the aortic root anatomy and the TAVR device type being implanted in terms of coronary access. The shorter valve frames, such as balloon expandable or mechanically expandable, may be well balanced in reduced TAVR, unless, as the previous speaker has shown with the Lotus valve, that the stent frame goes above the sinotubular junction. With the taller stent frame, particularly relevant in the self-expanding valve, we need to look at both coronary access and reduced TAVR, particularly in the supraannular devices. So this is our paper that we mentioned already, some of the factors involved in considering coronary access, and so imaging is particularly important. You can see that this recent JACC intervention article showing that if you have a commissural interference with the coronary orifice, it can potentially make the access difficult because of the tall commissural post, especially in the case of evolute valve, around 24 to 25 millimeters tall. You can see here, this is another paper looking at if you have two transcatheter valves in place. This is now coronary access after repeat TAVI. And you can see, depending on the anatomy and the type of transcatheter valve you use, it can potentially be challenging. And you can see here that there are now an editorial talking about coronary access in terms of first versus the second transcatheter valve, potential anatomy, and the transcatheter valve geometry that can affect reaccess as well. So I encourage you to read that paper on your own. This is an editorial that we wrote recently about the similar topic, and we actually put together a classification where the first transcatheter valve was to the second transcatheter valve in terms of the height. So if the first transcatheter valve, the coronary height is above that, then after the second valve, especially a shorter valve, it should be pretty easy. But if you want to use a supraannular or self-expanding, also self-expanding valve, you should try to aim for commissural alignment to facilitate coronary access in the future. If you have a first transcatheter that is a tall self-expanding valve, you ideally want to have commissural alignment first, and then when you implant a second valve, it would still make the coronary access potentially easier. The other point that people are talking about now with younger patients, can you do a TAVR and TAVI in the future? Now, one thing that we know is that after surgery, remember, there are no native leaflets behind, and because we align the commissures 100% of the time, as the previous speaker mentioned, we can consider performing basilica in the surgical valve. However, after TAVR, we know that the different devices have different frame height and profile and leaflet profiles, and because there's no consistent commissural alignment, until more recent attempts, basilica may not be always feasible. So we feel that commissural alignment may matter for future coronary and aortic valve reintervention after TAVR. The reason is that, as I mentioned before, in surgery, we do it all the time in the operating room. And if you don't have a commissural post overlapping the coronary, it reduces the barrier to access. There are now some early reports and presentations talking about potential durability impact if you don't have commissural alignment, such as increase in gradient or maybe even the halt phenomenon. And we know that basilica is not really feasible if you have a commissural post facing the coronary artery because you cannot split the commissural post of a transcatheter valve. Here's an example what we mean that commissural alignment may be important even in the case of basilica leaflet management. These are mitral flow valves that have basilica performed in the bench. And you can see that if the commissural post, you can see by the arrow, faces the split portion of the leaflet of the surgical valve, you still may risk coronary obstruction. And so here's a paper that we published on a multi-center study last year looking at 3 transcatheter valves and see whether we can align the commissures to better provide coronary access perhaps in the future as a hypothesis. And what we looked at is the SAPIEN 3, the Evolute, and the Accurate Neo valve. With the SAPIEN 3, we crimped the valve commissure at a particular clock face orientation, and we deployed the valve in a standard fashion. With the Evolute valve, we put the flush port at 3 o'clock instead of the conventional 12 o'clock, and try to get the head marker at the outer curve or center front at the time of the deployment. And finally, Accurate, we looked at the commissure orientation, tracking on flow before and afterwards. You can see that with the sapien-free valve, despite our best efforts to crimp the valve in different orientation, there's no consistent approach to align the commissures relative to native commissures. However, as the previous speaker mentioned, that coronary access is less of a challenge in the sapien-free valve unless the valve extends above the STJ with the commissural post facing the coronary. With the Evolut platform, you can see that the C-tab represents one of the commissures of the supraannular platform. And you can see also that the hat marker on the capsule delivery system has particular orientation. And by here, I show that outer curve, center front, or inner curve. If you look at how the Evolut valve is mounted, you can see that the C-tab is actually mounted up roughly 90 degrees away from the hat marker. And so there's a mathematical relationship in terms of potential achieving commissural alignment with this valve. Sorry, I think the connection is lost again. Let me share the screen. Apologize. Okay, so here it is. So you can see that this is a paper that in the paper you can see that the hat marker can be put oriented in different manner during the deployment, as you see here. And the C-tab can also be located in different manner. And so our goal is to try to position the C-tab as in the inner curve of the ascending aorta in terms of optimizing commissural alignment. And you can see that if the initial hat marker where you deploy the valve, if the hat marker is the inner curve or center back, you can see the red bars, the incidence of overlapping a commissure of the coronary artery is much higher than the green bars if the hat marker is located in the outer curve or center front as you deploy. So what we try to do now is to insert the Evolut system in the femoral artery at 3 o'clock instead of 12 o'clock to try to align the hat marker at the time of deployment, either at the outer curve if you do the valve deployment at a classic or LAO view. If you use the RAO cuff overlap view, then the hat marker should be facing you directly. And I'll show you a couple of cases in a moment. So the goal, as I mentioned before, is to try to land the C-tab at the inner curve to facilitate commissural alignment. This flush port, as I mentioned before, in the Evolut system on the gray handle is located here. And what you do is simply to insert into the femoral artery with the flush port away from you at 3 o'clock. So here's an example of the video showing the hat marker tracking along the outer curve of the arch to the ascending. You can see that the hat marker is an outer curve. And you can see in the fluoroscopic view that the hat marker will be outer curve or center front, depending which fluoroscopic view you deploy the Evolut valve. And what you find is that if you look at the precuspal planar view, the C-tab would always end up in the inner curve if you want to achieve commissural alignment. And this patient actually had a post-TAVI CT. You can see that the commissures are well aligned in this particular patient. And you can see that this patient actually had a coronary angiography afterwards. So with the appropriate catheter and guide, you can see that it engages selectively pretty easily. So our center now has done over 400 consecutive cases up till in May. And we actually compared over 250 cases that were done since last January compared to 120 cases before March 2019 when we adopted this technique. And you can see now we can achieve the hat marker in the outer curve or center front almost 97% of the time. So which is really remarkable. And as a result of that, you can see also the coronary overlap with a commissure is also significantly reduced, particularly in the left main, from 31% down to 13%. The right coronary is a bit more variable. That's why you don't see a statistical difference, but certainly it's still reduced to around 14%. And really rarely now you would have a commissural post-facing forward coronary, around 5%. There are some limitations of this technique. First of all, it's transfemoral approach only. We've not tested in alternative access. And of course, iliofemoral tortuosity, calcified vascular myotomy may limit the ability to track the hat marker to the outer curve. There are some other papers now also looking at valve in valve. You can see this is the case report on JAK intervention looking at using valve in valve and the cuff overlap technique, and also at the commissural alignment, as I mentioned before, with the hat marker in the center front. And in terms of accurate neo, you can see that with the line on the white arrow, you can see that that's on the commissural post, and you can see that how that can be determined in terms of commissural alignment or misalignment to facilitate reaccess. Now, this valve has a very low profile in terms of the frame, even though it's a self-expanding valve. So coronary access may not be particularly difficult, but remember this commissural post is very tall, it goes above the SPJ. So you must need to get around the post to access the coronary. And you can see that here, if the commissural post at the time of deployment, the center backward inner curve, it makes the coronary access potentially easier. There are now ways to actually perhaps customize commissural alignment to facilitate reaccess. So one way is to look at the CT. So this group here, you can see that basically use 3D printing to allow the handle to track exactly how the patient would track in terms of the anatomy to enable to deploy the accurate valve in a commissural aligned manner. And you can see this particular paper on using a bench model doing the portico valve and also trying to use CT to help achieve commissural alignment and also fluoroscopy as well. And this one particularly using the touch overlap technique. Now, of course, ideally, we would have a transcatheter that requires commissural alignment to deploy, and these are two examples of these valves that are undergo clinical trials right. So in summary, I think current TAVI devices are not designed to achieve commissural alignment to facilitate coronary access. However, we know that commissural alignment now makes lifetime management of these patients potentially easier. The technique modification so far, we have been able to improve evolute commissural alignment, but not SAPIEN-3. And there are other transcatheter valves currently being tried to use technique modification as well. And of course, CT-based and patient-specific analysis may still improve commissural alignment. And we need a prospective study really to, at the time of deployment, to actually do coronary access. And I'm part of a group based in Vancouver and John Webb's group looking at a prospective study called CAN Access to evaluate coronary access after the Evolute platform. And of course, I think really we need to talk to our manufacturers to design valves and delivery systems to consistently achieve commissural alignment. And I'd like to report to you that this attention that my colleagues, Dr. Sharma, Dr. Kinney from Mount Sinai, who are my interventional cardiology partners, developed this app. You can download it online. You can also download it for free on your Android and mobile and iPhone Apple platform. Essentially, this is a tool developed by us to learn how to do coronary access with the SAPIEN-3 and the Evolute platform with or without commissural alignment. And I encourage you to look at the different anatomies and tools and catheter. This is based on our tools and has been supported through a restricted educational grant. Thank you very much for your attention.
Thank you, Dr. Tang, for your great talk, especially talk about the commissural alignment. The technique is very important and that can refine our current practice in TAVR. Is there any question or comment from the panelists? So I'm interested about the CT image, I mean the fusion technique. I think it's reasonable to make a fusion to orientate the device, no matter what kind of device. So what's your experience about the fusion CT in TAVR or in some aortic procedure like TAVR or EVAR in your institute?
Well, we haven't done any, we don't have any CT fusion right now available in our lab. We're actually having some, maybe an echo guidance in terms of fusion with fluoro. But I think the issue that you brought up is a good one because each device, as you know, has different flexibility, right, in terms of delivery system. And I think that is what is driving the ability to align the commissures consistently. So what you're proposing, I think, is we can overlay potentially the CT and using 3D printing to guide the delivery catheter in a certain way initially, so that we don't have to twist and torque the delivery system at the time of deployment, because I think there are risks associated with that, such as aortic injury or annular injury or causing complication. So I think this is an important step forward. I think the issue, though, is this is still only by operators, right? And it's also quite labor intensive. You would have to have the technology, the imaging equipment available to do this. Ideally, what we like to do is to have manufacturers make something that, like in surgery, we do it all the time with the commissural alignment, so we don't have to think about it, or we don't have to worry about the patient anatomy to decide whether it's possible or not.
And the second question is about the calcification. Will the calcification will interfere the commissural alignment, the technique? So I mean, do we have to do BAV first to correct the calcification and make the alignment more easier than without BAV?
Yeah, we haven't found this to be the case in terms of whether BAV matters or not. We BAV based on the patient's, as you mentioned, the calcification anatomy. For example, in bicuspid valve, we tend to pre-BAV beforehand to avoid the valve being constrained or having to post-dilate. We know that if you don't pre-BAV, there's might be a higher need for post-dilatation, which has its own risk factors. But in terms of alignment, we have not found to be the case with the Evolut system. Remember, the Evolut system has 2 spines right now that limits the ability to rotate. So we don't recommend any kind of rotation, just like you would not rotate a SAPIEN-3 valve or other valves, and when you deploy to try to get the alignment, because I think at least right now we don't have that data available to say that it can be done safely. But you can see that at least based on our experience so far, over 200 cases with the Evolut system, is about 90%. 97% rather, so we can get the head marker to the outer curve. So, which a majority of the time will get the commissural alignment.
Then there's a question from the audience, and for the VIV case, would you fracture before implantation of the balloon expandable and self-expanding valve?
Yeah, no, that's a great question. So I don't think there is the jury is in. There are definitely 2 schools of thought. Some prefer to fracture before, some prefer to fracture after. I think we actually presented, there was a table that talks about an upcoming review in Euro intervention. Actually, you might want to look at that is a pretty comprehensive on valve-in-valve TAVI. So the advantage of fracturing post is some people say you might be able to get a better expansion. And you don't avoid the hemodynamic instability of fracturing pre causing acute AI. But there have been reports of coronary obstruction, also valve migration, and also injuring the transcatheter valve leaflet with fracturing post. If you fracture pre, you certainly are able to see the waist of the balloon very well, and you might be able to implant the valve more easily, self-expanding valve, especially in small surgical valves, where let's say you have a 19 or 21 surgical valve, you need to put a 23 or 26 Evolut system. The mismatch might make it more difficult to implant if you fracture afterwards. But if you fracture before, you may risk the acute AI and hemodynamic instability. So if the mechanism of the surgical valve failure is predominant AI, I think it's fine to fracture before because you already have existing AI. But if it's mostly AS, you have to be prepared to implant the valve very quickly because we've had experience where the fracturing caused acute AI and we need to deploy the valve quickly to address that issue.
Okay, thank you, Dr. Tang. We'll move to next speech. The next speaker is Dr. Simon Lam. Simon Lam is our good friend and also teach us lots of about the protector system. So Dr. Lam, he is an intervention cardiologist from the Division of Cardiology Department of Medicine, Queen Mary Hospital in Hong Kong, and he received post-fellowship training in structural congenital heart intervention in Frankfurt, Germany, under the Professor Silver in 2013. And he is a physician, a proctor of structural heart intervention procedures, including Edwards, SAPIEN-3 transcatheter heart valve, and the eminent left atrial appendage occluder device. Today, he will give us a talk about the maximizing embolic protection in TAVR and the structural intervention. Dr. Lam, please.
Hi, thank you very much for a kind introduction. So my topic is about embolic protection in TAVI and structural heart interventions. I would like to share some challenging cases so we can learn through these cases to maximize the protection to our patients. First of all, to start with, we have to know the system, and before putting in the patient, we have to make sure the system is properly prepared and flushed. We don't want to use a gloveless full of clots and prepare the system, you have to put it in a clear water and try not to have air or any clots inside the basket to start with. So you have to make a good preparation. And back to the basics, we know about the anatomy of the neck arteries. The theory of using this filter is we have two filters. One is the proximal filters and one is the distal filter. So the proximal filter will land at the basocephalic trunk to protect the right carotid artery. And it will make a U-turn to the left side to cover the left carotid artery so that two of the major blood flow to the brain is protected. But we have to be aware that the subclavian artery, due to the intrinsic design of the sentinel system, the left vertebral artery is not protected. So that's why we still have to talk to the patient. It is not 100%. We still have to be very careful with our own TAVI procedure to start with, to minimize risk of the TAVI procedure in the first place. For example, to minimize unnecessary maneuvers, to try to make it as simple as possible, to try not to introduce thromboembolism. So this is a short video showing how we approach the patient when using the sentinel. We definitely need the right radial axis. The left doesn't work because we have to put the proximal filter in the basocephalic trunk. Following the anatomy, we have to make a U-turn and wire the left carotid artery and put it in the distal basket. So we have to prepare our usual gadgets for our transradial access. No matter it's a micropuncture set or the usual transradial puncture set, we have to prepare a coronary wire to introduce into the aortic root in order to put in the device. Ultrasound guidance would be also good because you don't want to spoil the right radial artery, because some difficult arteries want to spoil because there's no alternative route for you to put in the sentinel. So we have to be very careful in establishing the access. So we are showing some cases that a rare minority, but most of the time when using Sentinel, it's very smooth and uneventful. But just to take note of some scenarios that we have to pay special attention to. So we usually make a root shot of the aortic root, aortic arch to know about anatomy. And this information can also be got from a CT. So sometimes we encounter patients, especially those very frail, thin elderly lady, they have very small and spastic radial artery. So we have to be very careful. We don't want to create complications by preventing complications. So we don't want to have vascular complications because of putting a device. So we have to be very careful in wiring, and we can find loops in the aorta. So I mean, in the radial axis. So we have to be very careful when moving along with our wires. For example, we found there's a loop. So as with our PCI experience, when we encounter a loop, we have to wire it very carefully with the flexible wires, and we try to strengthen the loop by advancing and suddenly pulling to the wire, and try to strengthen the loop to allow the passage of the device. But we don't want to do it using excessive force, otherwise we'll damage the artery. So in this case, after careful manipulation, we'll put in the device, and the patient is protected from embolism during the TAVI procedure. So the second case, we also do root shot of the aortogram, which is a typical anatomy, and we successfully wire from the radial axis to the aortic root. But we found that when we root, because initially we want to pass our catheter through this wire, but we found resistance. In order to use excessive force, we do a selective angiogram, and we showed that actually there's a second pathway. It is not in the same pathway, but eventually these two pathways will end up in the aortic root. So this is the wire we're in through the radial axis, and this is the expected pathway we have to go through for our protection device. And with this case, we try to see what happens, and we found that it also have very complex anatomy here. So after struggling for a while, we decide to go for the brachial axis with care. And we eventually, after careful wiring, we confirm that we are in a good path. Otherwise, even though your wire can enter the aortic root through the alternative pathway, but it's too small that at a high chance you damage the vasculature with your sentinel device. And using this, in this case, the rest will be very smooth, and put in the sentinel device, and the patient is protected. And this is a case of TAVI put in an S3. It's a small aortic root, and the procedure is uneventful. So just a review on the normal arm, we usually have no problem doing our radial access for our PCI and coronary angiogram. But there are anatomical variations, especially radial loops. You can see that with this radial loop, you have to go over the loop and go towards the upper part. But sometimes your wire may end up going as a side track from this accessory pathway going up, and it will also end up in the aortic arch. So we have to be very careful to identify the pathway that you're advancing the wire. And there are lots of different variations, and if you're in doubt or you encounter resistance when you are moving your catheter, try not to use excessive force, but to step back and to understand the anatomy. Just like this case, the case that we were before, it actually ends up here and going up using through the accessory or remnant major artery towards the aortic arch. So when we encounter radial loops, we try our simplest maneuver to try to thicken it. But then in case it's difficult, try not to, because the population we encounter for TAVI would be elderly patients, and they may have very stiff or atherosclerotic radial arteries or peripheral arteries. Too much force will actually damage the vessel. So case 3, we have anatomical variation not only in the radial or brachial axis. We also have problems along with this region. And this is one anatomical variation called arterial lusoria, and in which the subclavian artery end up into the very end here. And if you want to advance the sentinel, you have to go through this artery, and you have to make a big turn going up here, or you can select the left common carotid artery. And this is why CT is very important for the initial assessment for the patient before you put in a sentinel. So in this case, we go through this anatomical anomaly, and we curve it upwards with care, and we protect the patient. But then we know the limitation here, because we are now, on one hand, the proximal basket is not protecting the brain, it's protecting only the right subclavian artery. So in this case, heart team ourselves has decided what to do, but eventually I think try to protect as much as possible would be good enough for this patient. So in this case, we protect the patient's right carotid artery and the right subclavian artery because of an anatomical variation. And this is a case of transapical TAVI, which the rest would be quite simple. And we have to be aware that this anatomy exists, and from CT, we have to evaluate before doing TAVI procedure. So case 4 would be another anatomical variation that we may encounter, which called a bovine arch. Bovine arch is per se is not a contraindication or big problem to sentinel, but there's some tips and tricks to overcome this anatomy. First of all, you have to do a careful wiring, and one way you can try to do primary wiring to go through this V shape of bovine arch. And then you can advance your sentinel, and then to deploy the distal and proximal filter in 2 consecutive steps. And in this case, we have a little bit difficulty. For example, you can see this is just like a left main branching to the LAD and circumflex. You have to have this U-shaped loop in this region and to widen it, so that you need some time and try not to damage the anatomy there. In this case, with careful wiring, we successfully established the sentinel setup. You can see this U-shape now exactly going into this area. So another thing would be, if you remove the system later, you have to be aware that this anatomy with this patient, and you have to try your best not to push too hard. You have to do it very meticulously. Otherwise, you may have sudden jump or sudden tanking of the system that will make things worse. In this case, we do a cups overlap wheel for TAVI using eFluid. So bovine arch have different variation by itself, but CT definitely will tell you beforehand. You will encounter this anatomy before the TAVI. So we will also use sentinel device in non-TAVI scenarios. For example, this is a case of, you can see this artery is very smooth. So it's a relatively younger patient undergoing PBMV, And this is not a standard sentinel indication, but among our heart team, we ask ourselves, why not put in a sentinel if the patient could afford it, and we can offer this option to our patient. And eventually we capture quite a number of clots that may be pre-existing on the mitral stenosis of this patient. And this is another example that we use sentinel, and this patient we perform sentinel before putting in a left appendage occluder. So in some patients, we know for occluders, for left atrial appendage, the first thing we have to rule out clots inside the appendage. But sometimes it's ultra difficult for patients to assess whether they are clots because of the anatomy or because of dense spontaneous echo contrast. You don't know whether they're really clots, for example, here, trapping in between those small trabeculations. So for some case that if we're in doubt, first of all, the most important thing is not thinking about the sentinel, but to maybe to give anticoagulation for a patient for a period of time and reassess TE to see if the clot will go away. And in some scenarios, we'll put in a sentinel just to protect extra protection to our patient. And this is the case using the Watchman flex device to close the appendage. So other consideration when we encounter TAVI, not apart from the technical issues, first of all, the patient when referred to us, they may have been seen by other cardiologists or interventionists. They may have been using the right radial access for coronary angiogram or arterial lines. But sometimes, if it had been used for one time, sometimes you may have difficulties in re-establish the right radial access again in a short period of time. So we communicate with our referral physicians or other doctors, try to preserve the right aortic artery for our patients if they're planning for TAVI. And we, at the initial stage when using the device, we always remind our anesthetists to avoid setting the right arterial line on the side. So we are moving towards LA and MAC, and for GA, the patient will totally relax. But then from MAC and local anesthesia, when doing TAVI, sometimes the patient may accidentally move the arm, and then the basket may dislodge, or there may be damage to the vessel. So we have to secure the right arm position during the TAVI. So we talk to the patient. Still, there are stroke risks associated with TAVI. There are limitations because, first of all, the sentinel is not 100% protected, as we know the limitation. For example, the left vertebral artery is not protected, and secondly, it doesn't protect you from distal embolization to the legs, to the limbs, to the arms, or to the organs. So we have to explain to the patient this is not 100% protected, but this is something that we could do to minimize the risk. So, but then we also go back to think we have to minimize the thrombotic risk in the first place. We don't rely on the sentinel. We have to keep our procedure smooth, clean, free of unnecessary manipulations to start with to prevent stroke, but not rely only on the sentinel. So some other words to say with the guide-wire selection, because of time limitation, I will not talk about it, but then make sure you're familiar with the guide-wire you're using with the system and what is the stock that you store in the cath lab, and some of the wires are not recommended. So just the final word is a CT assessment, and sometimes selective angiogram will be important to make sure you don't create new complications by putting in a sentinel. So this was one case I shared for you yesterday that I performed, and you can see that also we have very difficult anatomy. We have the radial access setting in this very small radial artery and go up to loop and joining to main branch. And we are thinking whether we want to put in the sentinel because it is very difficult for negotiating through the sentinel through that system. And eventually we try to use the brachial artery, but we have to do it with very ultra precaution because the brachial artery is associating risk. But this case is a bicuspid aortic valve, type 0 bicuspid with a lot of calcium. And this is the pre-ballooning. You can see the dense calcium here, and you can see here. And the procedure is very, very smooth. We'll put in the valve right after the pre-ballooning, achieving very good hemodynamics and excellent valve position. But eventually, when we put we pull out the filters, we found a lot of calcified debris here, a little bit clot here. But we would not regret that because the procedure take about around 1.5 hours. And actually, the first 45 minutes we're setting up the sentinel. So I think it is very worthwhile to protect the patient. Otherwise, in case this patient end up in stroke, then we'll regret. Why not put in the sentinel? So it become a routine for us to put in the sentinel for all our patients. And this is the end of my presentation, and would also welcome you to join our Hong Kong WAF in October. Hope to see our friends in Taipei and along Asia and worldwide. Thank you very much for your attention.
So thank you, Dr. Lam's great talk. Any question or comment from the panelists or audience?
Simon, I enjoy your talk very much.
Thank you.
Is there any difference of long-term cognition function of the patients with embolic protection device or without embolic protection device during the TAVI procedure?
So usually we separate into two things to assess. One is usually for even before the sentinel era, the stroke risk is, if you just assess clinically, the difference is not that big. But then if you take into account a very detailed cognitive assessment, or you use MRI as a marker to determine whether they're from embolic events, you can see actually the stroke rate, if you determine by using those criteria, will be very high. So I think there's some data saying that maybe in terms of acute stroke, it can have protection, but more importantly, cognitive impairment is also a marker that you want to measure for those patients who have undergone TAVI, because some very small microemboli that go to the brain may not cause immediate or very obvious clinical events, but it end up into impairment of very fine motor abilities or cognitive functions of those patients. But I would say I would like to see those long-term data, but I would start with protection to my patients today or earlier on before seeing those data.
Okay, thank you.
Simon, if some patient we will find from the CT, we can find some soft plaque within the carotid artery. So what's the how about the severity of the soft plaque is contraindicated for the sentinel system?
So there are no definite criteria how to rule out patients, but usually if there are around 50% of plaques over there, then we try to avoid using sentinel. But if there's in doubt, we try to advance the system. As long as when it's a smooth passage of the sentinel without struggle, without very challenging difficult maneuvers, even there's a plaque there, if the lumen is big, then shouldn't be any problem. But even if a very minor plaque, but then when you advance your sentinel, you find a lot of frictions, a lot of interactions between the vessel wall and the sentinel. In those scenarios, I try to give up to putting the sentinel, because, as you say, may create new problems and introducing stroke to our patients.
Okay. Thank you. Thank you for your excellent talk.
Thank you.
Let's move to the next speech. So the next speaker would be Dr. Lars Sandegaard. Dr. Sandegaard is the professor of cardiology, University Copenhagen, Denmark. He is the head of the congenital and structural heart intervention program at the Rigs Hospital in Copenhagen. He also the lead principal investigator for several trials, including Notion and the Reduce trial. And he's also a global proctor of TAVI. So Dr. Sandegaard's the topic is updates on TAVR durability and the new generation devices. Dr. Sandegaard, please.
Thank you. Thank you so much for the kind invitation to be part of this meeting. Let me see if I can share my screen here. I hope you can see my slide.
Yes, we can see your slide.
Yeah. So I'm going to talk about durability, because of course this is an important matter here, particularly as we're going to move to not only patient at younger risk, but also patient with longer life expectancy. And then afterwards, a little bit about a new generation TAVI device. See if we can move here. So again, as I said, when we are moving to patients at a low age, these patients have longer life expectancy. And I think that's more important to talk about life expectancy than the patient risk, because the patient can be old but have limited life expectancy. And also when we talk about treating these patients with aortic valve replacement, we have to talk about lifetime management, because it's not only about the replacement we do today, but it's also about the possibility to do replacement of these valves in the future. If you go a few years back, most of the patients we treated was quite old. If you look into the studies, the mean age had been around 80 years. And if you assume that that patient is going to live to he or she is 85, the patient only have 5 years of life expectancy. And even though we do not know the durability of these transcatheter heart valves, we can assume that they're going to last around 10 years. So you see, up to now, durability of these valves has not been an issue, because the valve has almost always survived the patient. But if you look what the surgeons are doing, you see this is data from Copenhagen. This is 2005, 2006 patient undergoing aortic valve replacement. The bars here in gray are patients who received a bioprosthetic aortic valve, and the black one, patient who received a mechanical aortic valve. And you see the break even between those two valves was 68 years of age. Less than 10 years ago, that came down to 61 years. So surgeons are putting more and more bioprosthetic valve into these patients. First of all, because the patient do not want to go on anticoagulation treatment, but also because the patient got a perspective that if that surgical bioprosthetic valve one day is going to fail, we can do a valve-in-valve procedure, putting a transcatheter valve inside the failed surgical prosthesis. So if you follow what the patients, what the surgeons are doing, treating more and more younger patients with bioprosthetic aortic valve and treat them with a transcatheter approach instead of a surgical approach, we coming down to patient maybe at 60 years of age. And that patient is still going to live to his 85. You see that this patient is going to survive several transcatheter heart valves. So if he's still lasting for 10 years, when he's 70 years, he needs a valve-in-valve procedure. When he's 80 years of age, he needs a valve-in-valve procedure. So of course, durability is a really important matter when we go into younger patients. And also we know that patients at a younger age, in those patients, it's more likely that the valve is going to fail early on than in elderly patients, because the aggressive calcification is more pronounced in younger patients than it is in elderly patients. We also recently saw that the new American guideline came out and dividing patients into 3 groups: patients who were younger than 65 years of age, recommended to have a surgical aortic valve replacement; patients who are more than 80 years of age, a transcatheter aortic valve replacement; and then you have this very difficult group between 65 and 80 years of age, where you have to consider both a surgical or a transcatheter valve replacement. And also, if you look, what you should take into consideration is not the patient's risk, it's a balance between the patient's life expectancy and the durability of the valve. So once again, durability is really important for these valves. So what is going to dictate the durability? Here you see the main factor in this meta-analysis of several studies on bioprosthetic valves. You can see the main risk factor for early failure is patient prosthesis mismatch. So patient receiving a too small bioprosthetic valve got a higher chance for an early valve failure. And you all know how we divide this in. So severe patient prosthesis mismatch mean that the patient have an opening area of 0.65 or less square centimeter per square meter. And of course, it had to be adjusted to the patient's size. So obese patients, it's a little bit higher, but this is the criteria we work from today. And also, not only will the patient prosthesis mismatch increase the risk of early failure of the valve, but it's also going to be associated with higher mortality. So again, in this study, patient with severe patient prosthesis mismatch got more than a 6-fold higher risk of cardiac-related death compared to patients who have a valve without patient prosthesis mismatch. So how can you avoid patient prosthesis mismatch? We can have a look into the 2 low-risk trials, the PARTNER 3, where a patient was treated with a SAPIEN 3 platform, balloon expandable valve with intra-annular leaflet position, and the Evolut low-risk trial, where patients were treated with the Evolut platform, self-expanding technology with a supra-annular leaflet position. And you see, if you look into the data here, for the SAPIEN 3, actually the patient receiving a SAPIEN valve had smaller opening area and higher mean gradient than the surgical patients. And that also translated into a higher, and almost a similar rate of severe patient procedure mismatch between transcatheter and surgical bioprosthetic valve. In the Evolut low-risk trials, it was opposite. Patient in the TAVI group have larger opening area, lower gradient, and a lower rate of severe patient procedure mismatch. So of course, it matters which kind of valve you're choosing, a balloon expandable or self-expanding technology. We used to say that the best hemodynamic was achieved with patients who received a self-expanding technology with a supra-annular leaflet position. I think this report from the US Portico IDE trial, where Portico valve was compared to both the Evolut platform and the SAPIEN platform, was an eye-opener for quite a few of us. Because in the group randomized between Evolut and Portico, we saw that the Portico valve actually had exactly the same opening area and transcatheter gradient as the Evolut platform. So meaning that it didn't matter whether it was a supra-annular or intra-annular leaflet position, as long as it was a self-expanding technology. So again, self-expanding technology, both supra and intra-annular leaflet position, provide the same hemodynamic performance and a better performance than balloon expandable technology and surgical bioprosthetic valves. So what data do we have on durability for these valves? I mean, the longest follow-up is from the NOTION trial, which was conducted very early on between 2009 and 2013, 280 patients who were 70 years of age, randomized between TAVI with the first generation core valve and surgical aortic valve replacement. So since this patient was at a lower risk, the mean STS score was around 3%, we also for the first time have quite a good survival rate. So at 8 years, we still have half of the patient alive. And again, you see no difference between the surgical and the transcatheter group with regard to durability. And of course, this is going to give us a unique chance to have some early data on at least durability out to 8 years. So when you talk about durability, of course, you need to have a consensus. So the first consensus report came out in 2017, a European consensus dividing patient durability into two groups, valve dysfunction and valve failure. And if you start to look at valve dysfunction, there's four groups: structural valve deterioration, non-structural valve deterioration, valve thrombosis, and endocarditis. And for durability, of course, the most important thing is to look at the structural valve deterioration, which is defined that the patient have a mean gradient of 20 millimeter mercury or more, or a step up in mean gradient of at least 10 millimeter mercury from baseline, or at least a moderate intraprosthetic aortic regurgitation. You may argue that this is not taking patient procedure into account because the patient will have a too small valve and coming out of the OR or the cath lab with a mean gradient of 19 millimeter mercury only need to have 1 millimeter mercury step up before he's actually classified as structural valve deterioration. So therefore, you can also use these modified criteria saying that the patient both need to have a mean gradient of at least 20 millimeter mercury, as well as a step up of at least 10 millimeter mercury from baseline to include patients with procedure mismatch into this definition. So again, applying this definition on the NOTION cohort using what was reported in the consensus report, you see that patients undergoing surgical aortic valve replacement have a double risk of structural valve deterioration compared to patients treating with TAVI using the core valve platform, 18 versus 14%. Again, if you use this modified criteria to not include patients with patient procedure mismatch, you see lower rates, but again, exactly the same pattern, almost double rate of structural valve deterioration in the surgical group compared to the transcatheter group, 16 versus 9%. Again, this is only for self-expanding technology. If you go once again to the balloon expandable technology with higher rate of structural valve duration, you see the opposite pattern. These are data from the Partner 2 trial randomizing patients between the SAPIEN XT platform and surgical valves. And where you before saw a lower rate of structural valve duration in the TAVI group, here it's opposite. 9% at 5 years for a patient undergoing TAVI compared to 3% in the surgical group. So what about the other arm, valve failure? Again, it's defined as patient had severe structural valve duration with a gradient of at least 40 millimeter mercury or a step up of at least 20 millimeter mercury from baseline. A patient undergoing a valve re-intervention, surgical or transcatheter based, or a valve-related death. Going back to the NOTION trial, looking at the self-expanding technology with the core valve compared to surgery, you see a lower rate, even though it's not statistically significant, for patient undergoing TAVI, 7% compared to 10% in the surgical group. Again, it's opposite with the balloon expandable technology. Back to the Partner 2 trials, opposite pattern, almost 5% at 5 years for the SAPIEN XT compared to only 1.3% in the surgical group. So again, durability matters, particularly in patients with longer life expectancy. We know that self-expanding technology, both with supra and intra-annular leaflet position, offer the largest opening area and the lowest transvalvular gradient. And this may transform into a lower rate of structural valve deterioration and valve failure as compared to both balloon expandable transcatheter heart valve and surgical bioprosthetic aortic valves. And also, it seems that lower rate of severe patient-procedure mismatch with the self-expanding technology may improve survival rate after TAVI. So let me now move from durability to this next generation valve here. I want to give a few slides here on the Navitor valve, which is a next generation portico valve. And you all know this is a self-expanding technology with intra-annular leaflet position. It got very large cell stents in order to optimize flexibility and also access to the coronary arteries. And also what has been added here to the Navitor valve compared to the portico valve is this outer active sealing skirts. And also the radial force has been optimized across valve sizes. It currently comes in 4 sizes, 23, 25, 27, and 29. But there will be very soon a larger valve, the Titan valve, which will going up to an aortic annulus of 30 millimeter valve, 30 millimeter. And also, it's been an iteration on the delivery system. We're now using this FlexNav system, which first of all have a very low profile. It's actually the lowest profile on the market due to an integrated sheet. It got very flexible system due to this large cell stent, and also it's very hydrophilic. It's easy to introduce into the patient. The Navitor valve was tested in the Portico NG trial, which was conducted both in the US, in Europe, and in Australia. It's going to include 160 patients, but the first 120 patients was reported at EuroPCI. These patients was used to apply and also receive CE mark for the Navitor valve, so it's now approved and in commercial use in Europe and Australia. So for the first 120 patients, you can see it was elderly patient, meaning it's around 83 years, high and extreme risk patient. They have an STS score of 4%, and all the patient had some frailty on the top of this. So again, elderly patient with at extreme or high surgical risk. So if you look at the outcome, despite it was this cohort, the 30 days mortality was 0%. There was 3% who needed a third valve because there was a pop out of the first valve, but successfully treated with the second valve. None of the patient was converted into surgical aortic valve replacement. And there was no other patient who left the cath lab without a Navitor valve. And also here again, of course, no cardiovascular mortality. One patient had a stroke, 0.8%. Rate of lifetime life-threatening bleeding, acute kidney injury, and vascular complications was very low. And also the rate of new permanent pacemaker for patient at risk, patient without a pre-existing pacemaker, was 15%. And that accounts for 16 patients where 13 patients actually had pre-existing conduction abnormality, such as right bundle branch block. Once again, hemodynamic performance was excellent. At mean, it was 2.0 square centimeter opening area, and the mean gradient was 1 digit, around 7 to 8 millimeter mercury. And very importantly, this new active sealing skirt provided, and probably the top of the class results with regard to paravalvular leak. So 80% of the patient have none or only trace PVL, and the remaining patient all had mild paravalvular leak. So none of those 120 patients had moderate or severe paravalvular leak. So I think this is the best results you get today with regard to paravalvular leak. And of course, this transformed into the patient's function class. Most of the patient was at function class 2 and 3 at baseline, and afterwards, the majority of the patient, 97% of the patient, was actually in function class 1 or 2. And it's also translated into the 6 minutes walking distance, which improved 21 millimeter from baseline to 30 days after revalving. So just to conclude here with the new Navitor transcatheter heart valve, there was a low rate of VAC2 events. And also this demonstrated it's a safe option even in very old patients at high and extreme surgical risk, suffer from severe symptomatic aortic stenosis. It had an excellent hemodynamic performance with large opening area and a low transvalvular gradient. And again, there was none of these 120 patients had moderate or severe paravalvular leak. 80% had none, only trace paravalvular leak, and the remaining 20% had mild paravalvular leak. This again, due to this new active sealing skirt. So I think I'm going to stop here, and I'll be very happy to answer any questions or comments to this presentation.
Thank you. So any question from our colleagues?
Hi, Lars. I'm Dr. Yin.
Hey.
Long time no see. Yeah,
Yeah.
Thank you for attending this meeting, and thank you for helping us regarding the development and the improvement of the TAVI team. And I have a question for the protocol system. Do you think that it's feasible to use in patients with heavily calcified bicuspid valve?
Yeah, I mean, we have been using it in all times, kind of anatomies, even severe calcification. It works really nice. One of the difference between the portico valve, or now the Navitor valve, and the Evolut platform is that even though they got the same radial force, it often got lower opening force. This will also give you a better flexibility. You don't have as much metal, so if you have tortuous anatomy or acute angulation of the aortic arch or horizontal aorta, it's a very nice valve. But you need to compensate for the lower opening force if you have severe calcifications. You probably need to do more pre-dilatation with the Navitor valve or the portico valve compared to what you do with the Evolut valve. But if you do that, you can treat the same kind of complex anatomy with severe calcification, with bicuspid aortic valve or calcium in the left ventricular alpha tract, and get these kind of excellent outcome as I just show you here with the new Navitor valve.
Okay, thank you.
So, you know, PPM is related to the rate of long-term mortality of the patients. So does the optimization of valve implantation reduce the PPM? For example, should we do the post-dilatation for every cases of TAVR? And how to assess the optimization of the valve implantation during the procedure?
Yeah, but I mean, of course, as always, when you have a patient with severe aortic stenosis who's coming forward to the heart team, you have to try to predict is this patient at risk for PPM? And if you have a CT scan, it's quite easy to see this patient have a small aortic annulus. You have to be aware. If the patient is going for surgery, you have to ask the surgeon to do root enlargement. If the patient is going for transcatheter aortic valve replacement, choose a valve which is going to provide a large opening area. And again, that's going to be a self-expanding technology. And again, at least it was a surprise for me to see these Portico IDE trials that hemodynamic performance is the same for self-expanding technology with supra and intra-annular leaflet position. So again, as long as you stay to a self-expanding technology, you're going to have the optimized hemodynamic performance. If you also, after valve deployment, see that this valve is not fully expanded, I would recommend to do a post-dilatation. You don't need to be extremely aggressive. Just try to choose a balloon which is maybe up to the mean aortic valve diameter.
Thank you. Any questions?
Professor Sonnegat, some speakers talk about the commissural alignment. So what's your comment about the newer concept about commissural alignment, especially in Portico or the new device of non-vital valves, such as valve design? Yeah.
Again, I was starting my presentation talking about moving to patients with longer life expectancy. And I think for these patients, there's a lot of issue which was not a main concern in the past because the patient was very old and had limited life expectancy. But again, if you move to patients with longer life expectancy, durability is going to be a main issue. We need to make sure that these patients have a valve which is lasting as long as possible. And also access to the coronary arteries is going to be important. So you need to have commissural alignment. There's two ways to do it. I mean, Gilbert Tang have nicely presented how you can actually optimize it on the way you introduce your delivery system into the patient. That's going to give you near commissural alignment for all patients. We got a presentation, a publication coming out in JACC Cardiovascular Intervention very soon, talking about patient-specific commissural alignment. So when you have the aortic valve around the aortic arch, across the aortic valve, you go to a cross-ball lab view, and if you know where the posts are located on the valve frame, you just try to rotate it so you have one of the leaflet posts on the far right of the screen, and that's going to give you commissural alignment. Of course, you need to know where are the leaflet posts located. For the Everett platform, it's going to be the C-tab, which is going to indicate one of the leaflet posts. For the Accurate Neo platform, it's one of these, what we call free stent struts, which is pointing out of the stent frame. And for the Portico valve, you look at the middle of the stent frame, you see those three stent posts. You have to isolate one on the right-hand side of the screen and make the two other one overlap on the left-hand side of the screen. So for all valves, you need to understand where are they. All the companies now has been aware about this commissural alignment. So I'm sure you're going to see next generation valves all have clear markers on the stent frame on the delivery system, so you know where the leaflet posts are. So you can not only offer near commissural alignment to all patients, but patient-specific commissural alignment.
Okay, because time is limited, thank you, Dr. Sonnegat, for your excellent talk. So I'd like to introduce the next speaker, which is the last speakers in the whole program.
So I show you a case. This is an 85-year-old gentleman present with severe aortic regurgitation. His logitic euro score was really high, so the TAVR team would like to try TAVR for him. As you can see, the baseline echo shows significant aortic regurgitation, and the annulus measured was 26.8. During that time, we only have 31 millimeter core valve. We all know that you should use about 20% oversizing, valve, but actually we only have 31 core valve at that time, so we can only use that. As you can see, there has been no calcification at all. And although the coronary orifice for the takeoff is okay, but the procedure was still challenging. As you can see, the valve regurgitation was severe. In the first attempt, actually the valve just popped out. And during the second attempt, it died too much. We tried to manually pull back the valve, but it was failed. So we tried core valve in core valve procedure to seal the valve leak. However, the second valve just pulled the first valve upward and just pop out of both valves. So we have to snare the first core valve, held it in aortic arch, and then pull out the second valve. We reload the second core valve and insert it again. This time we use a sapphire wire for valve implantation and the body wire technique, super stiff wire to facilitate the passage of the reloaded valve through the first valve. Because the first valve is already anchored in the aortic, and this is the post-procedure follow-up. As you can see, there has been no AR at all. This is another case with the use of evolutor. As you can see, the valve can be deployed precisely and end up with a satisfactory result. However, the implantation depth was still a bit deeper, so the pacemaker rate was still around 18%. So we focus on the dedicated valve for pure AR. That was the transapical J valve. J valve is designed, a special design. It has a three-prong clasper to sit on the sinus of the aortic valve, and then you can pull back the valve, and the frame, the three clasper work as a frame, and you can use the valve, put the valve inside, and the claspers work as a dock. In this way, the valve can be securely sit inside the frame. With the use of J valve, as you can see, we can successfully did 3 cases of such cases. You just put the 3 clasper in the sinus, and then pull back the valve and deploy the valve. As you can see, the clasper can grasp the aortic clasp very well, and the implantation depth is really low. So this can avoid coronal obstruction and avoid pacemaker implantation. As you can see, the follow-up echo showed actually no aortic regurgitation anymore. From the early experience of short-term outcome of the J valve, as you can see, the need of permanent pacemaker was really low, only 4.7%, and there has been no significant paralytic in 38 out of 39 patients. So the transfemoral system is on the way. So I think in the future, this will be the default methods to treat pure aortic regurgitation. To compare the experience on early and the newer generation in our center, as you can see, with the use of early generation core valve, we can only choose 31 millimeter device for the large annulus. But for the newer generation patients, we can use 34 millimeters and 29 millimeters J valve. So the device success rate was really high. In our later 10 cases, consecutive 10 cases, the success rate was 100%. There has been no need of the second valve, and there has been no residual significant aortic regurgitation. The implantation depth was 8.5, which was significantly shorter than that of the early generation valves. And to solve the valve-involved scenario, in our experience, we also found that if you want to, if the first valve dive too deep, and you want to seal the paralytics, you should use a sapien valve, a balloon expandable valve in the first core valve, because the core valve, the radial force is not enough. As you can see, if you use a balloon expandable valve, you can get a better and a satisfactory sealing of the paralytics. So if you have to use a second transcatheter heart valve, please use balloon expandable in a self-expandable valve. So the outcome showing that the only predictor of a device success is the use of newer generation valve. However, the long-term result of this patient still dependent on the age of the patient, whether there was concomitant coronary artery disease and the baseline STS score. That means that the baseline patient condition determine the long-term outcome. So my take-home message are the self-expandable core valve, due to its longer stem frame and hourglass shape, may be used in severe pure AR, but the early generation valve, which is not retrievable, not repositionable, resulted in suboptimal result. This is because the pure AR patient are prone to valve dislocation due to the lack of native leaflet calcification. So in more than half of the cases, you may need a second valve. And even you use the second valve, there are high likelihood of significant residual paralytics after implantation. Only if you use the newer generation valves and the valves dedicated for the pure indication can improve device success rate and the possible clinical outcome. So in the foreseeable future, I think newer generation valve, including the dedicated valves for pure AR, is expected to solve the AR problem. So I think TAVR for pure AR is gonna be solved in the future. Thank you very much.
Okay, thank you, Professor Yin, for your interesting talk. So for the first case, the two valves pop out together, and then later on you perform several cases to just need one valve. So what make the difference? Does it relate to the valve design or any tip and tricks for the valve deployment?
I think the major issue would be the valve size, because the annulus of the patient with AR is almost always much bigger than we expected. And also during the exaggeration during the systole and the diastole phase, the dynamic also changes very dramatic. So you have to use a valve size oversized more than 20% for this purpose. In the early days, we only have 31 millimeter core valve. In recent 2 years, we use a 34 millimeter core valve for this kind of large annulus. So I think that's why our success rate can be improved.
So Professor Yin, from your practice, is there any difference as compared with the Evolut and the Portico system in pure AR? Is there any difference between two systems?
I still think that the key issue would be the size. If the annulus is too big, even a Portico cannot fit very much.
Okay, thank you, Professor Yin. And because time is limited, we have to close the section. So we would like to invite our superintendent, Professor Wei, to perform the closing remarks. Yeah.
Well, it's the time for us to close the meeting. I would like to thank all the world-renowned speakers, moderators, and commentators, especially Dr. Ye Jian, who acted as our co-organizer. I also thank thousands of audiences who were watching this program in these 2 days. In the end, I'd like to thank all the staff of our heart center who organized this meeting. These include our doctors, nurses, IT personnel, and the pump technicians who were responsible for audio-visual control by the familiar operations of seeders and mixers. Now I want to say goodbye to you and hope to see you again during the next meeting in 2022. Have a good time in this weekend. Thank you.
Thank you.
Thank you, Dr. Ye Jian. You're still.
Okay.
Thank you so much.
Excellent program. I really enjoyed. Thanks, everybody.
Thank you.
Thank you. Thank you.
Thank you.
Simon.
Hi. Hey, see you. 你好，你好。我们的 Hong Kong Mafia 要你帮忙一下，
哦，没问题，没问题。Thank you.
Thank you.